Good morning, sir. Good morning, everyone. I am Dr. Arpita Das. It's an absolute pleasure to welcome you all on behalf of AIIMS Bhubaneswar Medicine Department to a day of scientific learnings. I am delighted to extend a warm and heartfelt welcome to each and everyone present here. Without much delay, let us start with the first session of the day, the session on infectious diseases. To chair this session, I call upon the dais our esteemed chairpersons, Professor Dr. Lalatendu Mahanti sir, Dr. Sanjay Das sir, and Dr. Pragyan Rautray sir. I would now request our esteemed chairpersons to invite and introduce our first speaker of the day, Dr. Sagar Khadanga sir.
A very good morning to you. I welcome you all to this new update, AB MEDICON, organized by Department of Medicine, ORGANISED Medicine Bhubaneswar. I must congratulate the entire team of Dr. Anupam De and his team for conducting such an event in this prestigious institute. And our first speaker is Dr. Sagar Khadanga. He will be speaking on virus outbreaks in 2024. It's a new concept because nowadays viruses are coming, a lot of viruses are coming up and causing havoc sometimes. Or a very bad experience COVID time, and monkeypox virus, oropouch virus, a lot of viruses are coming up about which you are not very aware of. Suddenly you will end up in very different clinical situations. So to give us some idea about what is the outbreak in 2024, we invite Dr. Sagar Khadanga, who is presently working as additional professor in the Department of General Medicine at AIIMS Bhopal. He is the nodal officer of ART Center, AIIMS Bhopal, and MP State AMR Technical Committee. He is part of more than 25 extramural projects as PI and co-PI. He has more than 100 peer-reviewed publications in national and international journals. I invite Dr. for his talk.
Before sir delivers his speech, we would like to welcome Dr. Sagar Khadanga sir with a token of appreciation for coming all the way from AIIMS Bhopal to deliver his talk. I would request our organizing chairman, Dr. Anupam De sir, Dr. Scientific chairman, Dr. Rasmi Ranjan Mahanti sir, and organizing secretary, Dr. Dhriti Sundar sir, to please come and felicitate Sagar sir.
I have the unique opportunity to speak in front of my teachers, my colleague, and some of my students. Thank you for the invitation to the organizing committee of AIIMS Bhopal. We are delayed. I will quickly brush up the various outbreaks in 2024, and some might be till March 2024. We can't skip influenza unless otherwise we are very keen to skip it. As we know, there are various strains of influenza. H strain from 1 to 18 and N strains are 1 to 11. If we look at the various outbreaks in 2024, H1N1 had an outbreak in Spain and Vietnam. H5N1 in Cambodia, Australia, USA, Vietnam. H5N2, there were 2 outbreaks in Mexico. H9N2 in Ghana, and you can look at a outbreak in India, somewhere from the southern part of India and the western part of India in June 2024. Vietnam, there were 2 outbreaks, H3N2 plus H10N5. This was a unique co-combination of influenza viruses in China. If you look at, we all know that to give a correct surveillance of influenza is difficult, so we do not know the exact number, at the same time morbidity out of all these strains. The global picture of influenza virus outbreaks are seen here. India is also part of a influenza strain outbreaks. MERS is typically, usually we ask to our ID fellows, when will you suspect MERS? If you want to know only one line, the cattle herds who come from Saudis for last couple of decades, about 10-15 years, there are occasional outbreaks of MERS. In this year, we had 9 cases of MERS in Saudi and 3 of them died. Coming to Marburg virus, this is an interesting one. We had 2 outbreaks in Tanzania and Rwanda. It's a filoviridae group of virus, something similar to the Ebola virus. Incubation period is around 2 to 20 days. Usually, on the first couple of days, day 2 and day 3, they will have fever, headache, some amount of malaise. Like any other viral illnesses, you might have some watery diarrhea, abdominal pain. Day 5 and 7, there occur some hemorrhagic manifestations, usually on the skin and mucous membranes. Ultimately, towards the end of first week, the patient will have shock and usually death by late first week or early second week. It's again, Marburg virus have a urban and sylvatic phase. It comes from monkeys and enters into human. There is a propensity for man-to-man transmission, but they are rare. With this background, as I've already mentioned you, 2 outbreaks were there in African countries, Tanzania and Rwanda. Relatively small number, but if you look at the number of deaths in Rwanda, out of 66 cases, 51 were dead, and in Tanzania, 10 out of 10. So it's a very high fatal disease, but it was well contained by CDC and WHO. Again, Sudan virus disease, the name is Sudan virus, but it's actually as it initiated in Sudan. But this epidemic was in 2024, was there in Uganda, 14 cases and out of 4 were dead. Again, this is a filoviridae virus, something equivalent to Ebola. Incubation period is 2 to 20 days and almost similar presentation. Person to person transmission is possible, but usually rare. So these 2 viruses were something similar to Ebola, though this year Ebola was not a outbreak in any part of India, but just for the information of our esteemed audience, 2021 and 22 there were 2 outbreaks. One person was diagnosed in India, if you can remember, in 2022. He had a travel to Africa. He was detained in Delhi. There was a huge hue and cry from the Human Rights Violation Committee, because that fellow had a certificate of clearance from the African country. He was reported in Indira Gandhi National Airport. Because of only of our academic interest, the person was detained for about 30 days just to identify or to manufacture vaccines against this particular virus. So we should have a human ethics rights for these cases. Zika virus is a outbreak in India in 2024. If you look at Maharashtra, was the most important state where 140 cases were there. All of these cases were confirmed cases in India. Traditionally, it started in Gujarat. First time it was diagnosed in Gujarat in 2016. In Madhya Pradesh, AIIMS Bhopal, we diagnosed it in 2018. Tamil Nadu, MP, Rajasthan, Kerala, Maharashtra, UP and Delhi, all these states, sometime Zika virus has been figured out. Zika virus is important for pregnancy and newborn. It has a propensity of microcephaly and various neuroencephalitis syndromes. This year in India, out of all these 151 cases, no cases had microcephaly, GBS in this particular outbreak. This is an interesting virus called as Chapare hemorrhagic fever. The name is self-explanatory. It will be hemorrhagic fever of rhinovirus family. Only one case was detected in Bolivia, but it has a propensity of bioterrorism and global pandemic. That is why it was important, and it was well contained. It was figured out in 13 Jan 2025, and no second case has been found out since then. Coming to human metapneumovirus, all of us might have seen toward the end of 2024 that this may be the second pandemic. It initiated from China. Nobody knows the exact incidence. I have quoted all these lines from the WHO site. If you look at toward the last couple of lines, data published by China up to December 2024, acute respiratory illnesses in certain provinces have increased, and detection of seasonal influenza, rhinovirus, respiratory, RSV, HMPV have all increased. It was a generalized statement, but the exact incidence and mortality has not been given by China to WHO. Again, this is a very interesting outbreak for me. What happened in the African country of Congo, in one particular hospital, the under 5 mortality increased drastically. For example, around 35 children died in 1 week, and all of them were having malaria positive. African countries are endemic. They diagnose it by IgM antibody titer, and they instantly reported to WHO outbreak team, and they identified all of these patients. Out of 891 patients, 48 died, and all of these patients had various combinations of influenza A, predominantly H1N1, rhinovirus, SARS-CoV-2, human coronavirus, parainfluenza viruses and all. So the WHO team had an outbreak notification that in children with malaria, there might be a co-infection of various life-threatening viral illnesses, which probably we were thinking in many cases of atypical malaria, but for the first time WHO has come out. There may be co-infections of various viral infections, particularly respiratory viral infections in patients with in patients of malaria. Again, one more very interesting virus, Oropouchi viral disease. Predominantly, it occurred along the eastern belt of America, both north and southern part of America. It is a flavivirus disease. Symptoms are like dengue, fever, joint pain, aseptic meningitis. It occurs in Amazon basin, America across 10 countries. Most cases recover within 1 week. But the interesting feature is this is one particular disease which has a very high relapse rate within 2 weeks to 2 months. And many patients develop, like we see chikungunya, after the onset of fever, they will have some amount of joint pain. Here, there was some amount of joint pain. Some presented with aseptic meningitis, and there were a very interesting finding of early cataract in this particular Oropouchi viral diseases in America. About 11,634 of confirmed cases, but death was less in comparison to other. A vector-borne disease, usually Aedes mosquito. West Nile virus, whenever we see any sudden increase of encephalitis like syndrome, we usually send for West Nile virus. But because of some change in probably the increase in heat across the globe because of climate change, this particular virus has been told that the incidences has gone down over last couple of decades. So WHO says that this should not be suspected in sporadic cases of encephalitis. Only one outbreak was there in 2024 in Barbados, one case and no mortality. Coming to monkeypox, probably the audience will be more interested for monkeypox, what happened in 2024. 20 cases were identified and there were 3 dead. If you look at the cycle, there is a wildlife cycle. The virus circulates among rats, monkeys, and squirrels, and incidentally, the humans are affected. One predilection was found: those who are having MSM, male having sex with male. This virus was found out of these 20. 14 cases were having MSM. So those who are HIV positive or having MSM, their predilection is more. None of the system is not affected. I mean, all the systems are affected by this particular virus. The earliest or the probability of palmoplantar vesiculobullous hemorrhagic lesions, if you are thinking in epidemic area, you can think about monkeypox. If you look at it, initiated in middle of Africa, and all the secondary cases traversed from Africa to all the sites. There were few cases were reported from Karnataka and Kerala, and one in Delhi from India also. Dengue, as usual, it was a very highly populated outbreak in 2024, but fortunately or unfortunately, India's outbreak in 2024 was low for dengue. Across the globe, about 12 million cases were identified. If you want to look at various numbers, the darkest were having highest prevalence, and as the color fades, they were of smaller and smaller numbers. Measles, many of the countries have started giving measles vaccination to adults again. There is a fading immunity of MMR, and if you are visiting the Americas, you must have a measles vaccination these days. India was again in the surveillance. India was one of the country with fading immunities, and across the globe there were about 10.3 million cases, predominantly from last part of the 2024, September to December, and in 2024 the numbers has gone down. So some countries has come out with adult measles vaccination, and we can also think at least to our geriatric population. Hepatitis E. Hepatitis E, whenever I thought of hepatitis E, I only remembered one of my teacher's class, that it affects only the pregnant woman and the mortality rate are high. If you look at the literature of last couple of years, the hepatitis E affects predominantly young children, 6 to 17 years, 53% were involved in young adults. And after that, 18 to 60 years, about 23% cases. Pregnant women were involved only 1.33%. So that particular statement, I am not sure whether that was right or wrong. Case fatality rate is low, but looking at the epidemic potential of hepatitis A and E in low-income countries like India, the case fatality rate of 0.3 will be a huge if there will be a epidemic in India. Yellow fever, as we all know, this is contained in Africa, and this time also there was outbreaks in African countries. Yellow fever has a mortality rate of about 11%. If you want to visit African countries, you will not be given visa without yellow fever vaccination. Nipah virus. Nipah virus is again a very fatal disease. Literature says 30 to 100% mortality, but if we look at the southeastern region of data, Singapore, Bangladesh, India, the mortality rate is about 70%. Last year, there was a epidemic of Nipah in Bangladesh, and 2 out of 2 were dead. If you look at various outbreaks in India, in the downmost table, I've tried to give you a data from India. The last epidemic was in 2021. 65 cases were there, and the case fatality was about 68%. As the name signifies, it traverses from beds to your food, and ultimately it is there with us. It is a endemic in Bangladesh, so any patient coming to us from West Bengal or Bangladesh, we should always suspect about Nipah. Polio, this was an interesting observation from WHO. There were 3 cases of vaccine-induced polio outbreak nearby Gaza and 1 in Indonesia. None of these patients died, but the propensity is huge. There might be a vaccine-induced polio outbreak in near future. Obviously, the signs, symptoms and the CNS affection will be low as they are attenuated virus. Lassa fever is again, this is important for bioterrorism, and 1 out of 1 case died in western part of the Africa. The patient traveled to Africa and ultimately died in the Americas in last part of 2024. Last slide is various outbreaks of 2024 in India. If you look at that pink color is of 2024, 20 to 24 different color sets. Acute diarrheal diseases has in various parts of India was the highest prevalent viral outbreak last year. Dengue was there in a couple of states, but if you look at the number wise, it was less than since 2023. So there was not a outbreak response. Chickenpox, measles, hepatitis, viral hepatitis, particularly hepatitis A. Mumps, we saw a lot of mumps cases last year in AIIMS Bhopal. Probably I have seen at least 20-25 males with scrotal swelling, and 1 among them also died in mumps. Chikungunya had some episodes, acute encephalitis syndrome, fever with rash. Probably we couldn't diagnose them which type of virus. With this, I can stop my presentation. There is a very good site of Government of India. My wrong slide was uploaded, no issues. From the IDSP network, every week they share what are the prevailing outbreaks in India. Those who are interested for infectious disease, they should be going through those particular sites. Thank you.
Thank you, Professor Khadenga. The session is now open for questions.
Sir, I think we should take the questions late.
No, this is what the organizers have told us.
Oh, fine, because so we are already running late by 30 minutes.
I would be happy if I could share something. There is one very important Chandipura infection virus which had happened last year, I think from July to August in Gujarat. Though this is prevalent endemic in Maharashtra, and as you know, this is quite case fatality rate is more than 33%, and it causes acute encephalitis. So if you can shed some light on that.
My talk was viral outbreaks.
Right.
The definition of outbreak is really difficult and different.
Yeah.
If it is prevailing in one particular area, Chandipura virus is endemic in India as per the WHO site. Yeah. So if the number of cases are not increased beyond 2 standard deviation in one particular year, there will not be any viral outbreaks. So any patient, adult or young adults, those present with aseptic meningitis, particularly from the western part of India, like Rajasthan, Gujarat, Maharashtra, even some cases have been reported from NKCG way back in 90s. So the virus is there, but there was no outbreak response in 2024.
I'm sorry, Professor Khadenga. Government of India Health and Family Welfare had actually declared this was last year, this was an outbreak, and there were 264 cases of this, out of which positive rhabdovirus was isolated in 64 cases. I was just going through this yesterday, so I know a little bit about this. So this was the case fatality. What interested me was case fatality rate was so much, but we in Orissa hardly knew about this virus. Thank you.
Thank you.
Thank you, Dr. Khadenga. I am Brigadier Mohanty from KIMS.
Sir.
The 3 things you discussed about the Hep E. Hep E is not common in pregnancy. But once it comes in pregnancy, mortality is very high. The reports is from AIIMS New Delhi. Professor Subrat Acharya, he keeps on talking is fact. But it's not that is not common in pregnancy. Mortality is highest. Second observation is your slide, you have to see, go back and see the dengue in India. What we have been observing, once upon a time dengue used to come once in 4 years, 2 years because of serotypes were different. But now we are seeing dengue every month, every day.
Across the year.
So I think that slide has to be, all the reports are not being
All
sent.
my presentation was from a WHO site called as WHO DAWN, Disease Outbreak Response.
Because you have shown so much of interest, please go back and tell them dengue
Fine.
is rampant. People are dying. The last observation is regarding, we see a lot of sort of acute respiratory infection lower. Bacteriology is normal. The biofire for the bacteria is normal. CRP is usually slightly high. They're all virus, I think. Most of them get all right, but it's time to think. We have to do something for that. Elderly population, low respiratory infection, ICU, sepsis, they die. I think something has to be done there. These are my observations.
Thank you. Well accepted all the information given to me. Yeah.
Any other comment or question? So if there is no question, I will hand over the mic to
Thank you.
I would now request our chairpersons to introduce and invite our next speaker of the session,
Thank you.
Professor Dr. Dalim Kumar Vaidya sir.
I take this opportunity to introduce Professor D.K. Vaidya, who is presently heading the Department of Anesthesiology and Critical Care and Pain Medicine, AIIMS Guwahati. His area of interest, as you all know, is critical care medicine and difficult airway. He has lots of publications in peer-reviewed journals. He is also an examiner of MD Anesthesiology and DM of Critical Care Medicine. He is book editor of the most important handbook for us, that is Washington Manual of Critical Care South Asian Edition. And he is also editorial, journal editorial of various journals, and he has got lots of awards, internationally acclaimed awards. And so I introduce Professor Vaidya, and I request him to start his delivery.
Your speech, sir, we would like to welcome you with a token of appreciation for coming all the way from AIIMS Guwahati to Odisha to deliver a speech. I'd like to request our organizing chairman, Dr. Anupam De sir, our scientific chairman, Dr. Rasmi Ranjan Mahanti sir, and our organizing secretary, Dr. Dhriti Sundar sir, to please come and felicitate sir with a memento and uttariya. Our chairperson.
Hello, good morning everyone. Thanks a lot for the invitation first of all, and such a wonderful gift. Can I leave now? Okay, so the topic is recent advances in the management of septic shock, and I am from AIIMS Guwahati. This is my institute. So although the topic is recent advances, instead of having too much of discussion on the underlying pathobiology or the newer molecules, I thought might as well discuss a bit more about the bedside clinical approach and what are the recent advances in that field for the purpose of benefit of mostly the postgraduates who are the delegates here. So if you look at the definition of sepsis and septic shock, you will realize sepsis is nothing but an infection plus organ dysfunction. So whenever an infection is having an associated organ dysfunction, that becomes sepsis. An organ dysfunction you identify by change in the SOFA score. We'll talk about the SOFA score. And septic shock is a subset of the clinical phenotype of sepsis, where there will be in addition profound circulatory and metabolic disturbances. Septic shock is a subset of sepsis where there will be, in addition, profound circulatory and metabolic disturbances, and it will be manifested clinically by mean arterial pressure of less than 65 plus a serum lactate level of more than 2. In other words, you will be requiring to supplement volume resuscitation, on top of it vasopressor support, to maintain a MAP of more than or equivalent to 65 at least, and it is obviously associated with a much higher mortality. So from the definition, if you take the keywords, you will see SOFA score, mean arterial pressure, lactate, volume and vasopressor. So SOFA score is for identification, MAP and lactate are your targets of resuscitation, and volumes and vasopressors are your strategies or methods of resuscitation during the process. So in this aspect, some of the knowledges are already clear, but there are a lot more evolution going on in each and every field of this. So as far as diagnosis is concerned, SOFA score is the gold standard, and as we already know, all the places the ICU charts should have SOFA score printed. Doctors as well as nurses should be following it up daily basis. But does it increase early diagnosis, or do we need to have other scores as well, or are there any biomarkers which are required for the diagnosis of sepsis? These are the questions to be answered. Similarly, the mean arterial pressure target is more than 65. That's kind of resolved, and invasive arterial pressure monitoring should be used whenever possible. But what are the role of other advanced invasive or non-invasive hemodynamic monitoring we need to explore? Similarly, lactate is also considered an important gold standard strategy. It should be available point of care, and repeated lactate monitoring should be there. But what about the other markers of organ perfusion in terms of saturation of central venous oxygen, carbon dioxide gap, that is veno-arterial CO2 gap in EBG, or capillary refill time? Volumes, there is no debate that crystalloids are the most important, but how much, when to administer, how to assess for fluid responsiveness, when to start de-resuscitation of the patient. For vasopressors, noradrenaline is the drug of choice, but how to titrate it, when to start it, how to administer it, central line, peripheral line, what are the second line agents, what are the third line agents, what to do in refractory shocks. So those are the questions we need to understand. So to begin with sepsis screening and diagnosis, for this, as we already discussed, SOFA score is the most important factor. It involves different organ systems, and we choose one marker from an organ system and score them 0 to 4, so we can have a maximum of 20 score or minimum of 0. And from the baseline, elevation of by 2 or more is regarded as a significant pointer to the diagnosis of sepsis. But most important here is that, do we need to enhance sepsis screening of high risk population? The answer is yes. So patients, the key to successfully reduction of sepsis mortality is to identify them early. So acutely ill high risk patients who are at risk of sepsis but not yet in sepsis, for example patients in wards or ICUs, there should be enhanced screening methodologies of these patients. And how to do it? The SOFA score we do in the ICU or in the emergency department who are already critically ill. But for the other patients, to identify, you can use various other scores like QSOFA, NEWS or MEWS or SIRS. The staff should be educated to follow these scores. Why it is important is that if you start developing these practices, these QI projects, then there will be better adherence to sepsis bundle by general staffs, that they need to monitor all these things, and eventually it will translate into reduction in the mortality. So SARS and QSOFA scores have been in vogue since long, and people have been using this. SARS were initially used a long time back in the diagnosis of sepsis as well. QSOFA came a couple of decades back, and it was propagated by Surviving Sepsis Campaign Guideline Committee. But later on, a variety of studies and subsequent meta-analyses have shown that if following QSOFA will underdiagnose the cases of sepsis, and there is decreased sensitivity. So the emphasis on using the SIRS scores, or you can use these two important scores which are used in various countries, including the UK's, the MEWS and the NEWS, National Early Warning Scores and Modified Early Warning Scores. So, in patients are high-risk patients, the wards or HDUs, in their daily assessment sheets, these scores should be printed to be followed by nursing officers, and yellow and red zones are the different flags you raise. For a yellow zone, the nurse become concerned and inform the resident doctor. For the red zone, the consultant should be informed. So if you develop such strategies, definitely your sepsis diagnosis and screening will be much more improved. So let us move on to the management part. So first, IV fluids. So fluid resuscitation, which IV fluid? The answer is quite clear, crystalloids. In different slides, you will be seeing these green and red dots in my presentations. The green dots, double dots means strong recommendation in favor, and one exclamation marks in green means weak recommendation in favor, and red is otherwise, recommendation is against. So crystalloid is the fluid of choice and first line of resuscitation. In most of the cases, the only type of fluid you will require for resuscitation in sepsis. And similarly, there is strong recommendation against starches. Starches or gelatin should not be used in patients who are suspected of sepsis or septic shocks. And variety of studies which have been performed, including 6S and VICEP trial, which have shown that there is enhanced mortality with the use of starch and gelatins, predominantly by the mechanism of major adverse kidney events and requirement of renal replacement therapies. If you need to use colloids, you feel, because you are requiring large volume crystalloid resuscitations, then albumin you can use as evidenced by SAFE and Albios trials. However, it's a class 2A recommendation. Now, among the crystalloids, in the last decade, the main debate was whether to go ahead with our old age normal saline, or we need to start using balanced salt solutions like ringers, lactates, acetates, all these solutions. Now, most of the studies in last decade, randomized control trial, have been performed in this regard, and apart from the SMART trials, other did not find any significant difference in the clinical outcome in terms of mortalities, but SMART trial have found that with the use of normal saline, there is significant increased incidence of, again, major adverse kidney events, which is defined either by rise in creatinine beyond a certain level or increase in the incidence of renal replacement therapy requirement. So, although subsequent trials, including the PLAS and BASICS, did not find the same data, but yes, when you are requiring large volume resuscitation, you should be very cautious while using solely normal saline and try to prefer balanced salt solutions. And that's what we are doing in most of the places, except maybe few African countries where there is still scarcity of balanced salt solutions. Now, how much fluid? The soft recommendation was at least 30 ml per kg in the first 3 hours, but these were mainly based on the different observational retrospective database. The most importantly, nowadays what we do is individualize our approach, because blanket 30 ml per kg has got a lot of troubles, and you cannot really reassess the patient only after 30 ml per kg has gone inside. So continuous assessment and reassessment, early initiation of vasopressors over the full bolus of fluid, and individualization of the patient is more important. Second most concern was the EGDT, the early goal-directed therapy approach. Is it really necessary? The Rivers et al. Almost 20 years back had proposed that in sepsis and septic shock resuscitation, EGDT is the way forward, and it was popularized instantly. There was specific approach and an algorithm. You achieve a MAP target of more than 65, urine output of more than 0.5 ml per kg per hour, central venous pressure target of more than 12 millimeter of mercury, by starting with fluids and vasopressors, and after that you do a central venous oxygen saturation. If it is less than 70%, that means the oxygen delivery to the peripheral tissues are not adequate. So that means either the oxygen carrier hemoglobin is less or the cardiac output is less. You do hematocrit. If it is less than 30, you transfuse blood. You put an advanced cardiac output monitoring, and if it is less than 3.1 ml per liter per minute per meter squares, you start dobutamine. This entire approach was not feasible to be followed in most of the research limited settings, although it was mandated by the guideline committees. And subsequently 3 large multicentric trials were performed: PROCESS in US, PROMISE in UK, and ARISE in Australia. So all these three important trials in three different subcontinents have found that the standard of care is as good as following this EGDT approach, and this specific adherence to this specific approach is actually not required. However, use invasive and non-invasive monitoring depending on your expertise and availability. Do have the MAP as urine output target, of course, and lactate is the important microcirculation marker of resuscitation. However, the debate is still that that with the implementation of EGDT, perhaps the standard of care had improved over the subsequent 10 years, and that was the reason for no significant difference in these trials. So next part is that guide to resuscitation. Now you start with fluids, you start with vasopressor, still the blood pressure is low, and you are always in a clinical dilemma whether to administer more fluid or to step up with the vasopressors or both. So the best answer is to find out the fluid responsiveness. Now fluid responsiveness on top of your clinical markers, or even nowadays in the point of care ultrasound IVC assessment, over and above all these static assessments, the key is to start using the dynamic parameters. So dynamic parameters means in response to a fluid challenge, how your cardiac output or stroke volume is getting augmented, or in response to intrathoracic pressure variations, how your stroke volume is getting augmented. That is the dynamic parameter. Now instead of the age-old exogenous fluid challenges and subjecting the patient to be at risk of fluid overloads, what we can do nowadays to assess fluid responsiveness is endogenous fluid challenges by translocating 250 ml to 300 ml of blood from peripheral venous capacitance vessels into the central circulation by simple passive leg raising maneuver. And if you find that there is increase of stroke volume variation or pulse pressure variations or left ventricular outflow tract VTI in echocardiography, then you know whether the patient is fluid responsive. So if these variations are less than 10 to 13%, that means patient is not responsive, does not require any further volume. But if these variations are more than 13% or 10% in various studies, that means patients might respond to exogenous fluid administrations. But SVV and PPV will require invasive hemodynamic monitoring or the cardiac output monitoring. So if you don't have it, you can use simple bedside echocardiography and assess the left ventricular outflow tract VTI. Now next, the MAP target. So MAP target is more or less settled. It should be at least 65 millimeter of mercury and above. However, this generalized recommendation may not hold good in certain populations, particularly who are at risk of organ dysfunctions at lower MAP. And moreover, setting a target of 65 might means that if you follow up the time weighted average MAP duration, many times you will be having episodes where the MAP will actually fall down below 65. So the studies nowadays focus on targeting a MAP of about 70 or 75, so that almost always it is above 65. And the at-risk population, as I was talking about, in elderly patients who are already chronically hypertensive, in that subset of population in sepsis PAM trial, it was found that if you target MAP of 60 to 65 versus on the other arm 80 to 85, the incidence of AKI and RRT requirement were increased in target of 65 group. So beware of this issues in patients who are elderly and who are hypertensive. Now which vasopressors? The vasopressor of choice is noradrenaline. There is no confusion nowadays. Multiple RCTs have proven that. And of course the target of 65 MAP, and consider invasive arterial monitoring at the earliest. But the important question is that during emergency department resuscitation, it might require time to put a central line and you might miss the golden hour. So can we start NORAD in the peripheral line? Yes. There have been observational studies performed which have shown that initiating a NORAD up to a dose of 0.25 to 0.5 mics per kg per minute, which is 15 to 30 mics per minute, from a large bore peripheral IV cannula placed at the antecubital or above towards the central circulation, and running that NORAD infusion along with an ongoing fluid flow will not cause significant local side effects, and you can do it, but try not to continue it beyond 3 hours or so for the purpose of patient safety. The next important is that if you are having escalating dose of NORAD, when to start the second vasopressor and what. The idea is to start vasopressin, is the second line vasopressor of choice in septic shock, and start as early as 15 mics per minute of NORAD as per the VERSE trial and VICEP trial. Vasopressin will work from a different receptors and will augment the mean arterial pressure, will cut down on the noradrenaline dose and thereby the side effects of vasopressors. In the subset of patients with cardiac dysfunctions, in addition to septic shock, NORAD vasopressin combination obviously will decrease the cardiac contractility and the output by increasing the SVR significantly. So in those cases, the recommendation is to add dobutamine along with NORAD or stop dobuta-NORAD both and switch over to epinephrine. Right? This epinephrine was added keeping in mind the African resource limited countries where dobutamine was not available. So in those countries, it is advisable you stop the NORAD dobuta combination and run only epinephrine. However, that you can also might as well practice in your clinical setting. Levosimendan was found to be beneficial in few of the initial studies. However, subsequent RCTs and a meta-analysis by our group have proven that levosimendan does not have any significant advantage over dobutamine in terms of any of the heart clinical outcomes. So it is now ruled out of the guidelines. Now, only targeting MAP and other macrohemodynamic parameters may not suffice, and we need to identify the microcirculatory changes. So for that we have lactate and capillary refill time. Lactate is again the point of care test which all of us will do. Capillary refill time was found to be as good as lactate in Latin American countries in large multicentric Andromeda shock trial, which in fact have shown that following CRT every 30 minutes compared to following lactate, which was done every 2 or 3 hourly, has in fact reduced the mortality by absolute risk reduction was 10%, although it did not attain statistical significance. In resource replete countries, you can follow SCVO2 and CO2 gap, where performing repeated ABGs is not a concern. If you are finding SCVO2 is less than 65% or 70%, you can quickly follow veno-arterial CO2 gap or the differences. If the gap is more, that means microcirculation is suffering. You need to augment the cardiac output. Few drugs in refractory shocks, refractory septic shocks, methylene blue and angiotensins 2, not again routinely used in our clinical practice, but early trials are encouraging. There are some role of heart rate control in patients with septic shock. Once you have achieved the other targets, but there is undue tachycardia, controlling the heart rate by esmolol or landiolol may have some benefit. Earlier trials with esmolol found that there was slight mortality reduction, whereas subsequent landiolol study in the Landicep trial did not find that. Still, it's an area of which needs further exploration. Antibiotic initiation, I won't dwell much over here. There have been multiple famous trials which shown that each hour delay in the initiation of antibiotic have increased mortality by 7 to 10%. So the recommendation is to start, irrespective of shock is present or absent, is to administer antibiotic immediately within 1 hour if you are reasonably sure that yes, you are dealing with a case of sepsis. Only when sepsis is one of the differential diagnoses and you think you need to rule out sepsis by certain investigations, then you can delay up to 3 hours. But even at the end of 3 hours, if you still have a sepsis in your DD, administer antibiotics, don't delay it further. The recent guidelines have incorporated based on your local data, epidemiological data of the infectious diseases. You can add empirical MRSA, you can add dual gram negatives empirically if you are dealing with a patient with septic shock, and even empiric antifungal coverage is allowed. However, you should have appropriate risk factors for starting all these antibiotics, and always choose antibiotics based on PKPD principles. For beta-lactam, prolonged infusion over prolonged infusion over Q 6 hour or 8 hour drugs is advisable. And most importantly is the source control and daily assessment for de-escalation of the antibiotic once your patient is getting improved. So if you need to follow the bundles, again in the 1 hour bundle, these are the minimum points you have to do. So obtain blood culture and administer a broad spectrum antibiotic. However, do not delay antibiotic administration if you don't have a blood culture bottle available. Measure the lactates and start with 30 ml per kg of crystalloid resuscitation if the patient is hypotensive, that is MAB less than 65 or lactate is more than 4 and target of more than 65 of MAB. A few points about the other therapies towards the end. So steroids, again, it's not a class 1 recommendation, but I believe most of us use it in septic shock, and the data have found that beyond a dose of norepinephrine 15 mics per minute, hydrocortisone 200 milligram per day is beneficial in terms of earlier shock resolution and earlier stoppage of vasopressor therapies, but it did not translate into increase in the mortality. Various trials have been performed and the findings are almost same everywhere. The dose is 200 milligram per day. If you run 200 mg over an infusion of 24 hours or divide it in the 50 mg QID fashion, does not have any significant difference in any of the outcomes. Glucose control, very strong recommendation in favor of maintaining sugars in 140 to 180 milligram per DL range to reduce further hospital-acquired infectious complications, and even nice sugar trial have some beneficial effect on the mortality as well. In this context, in shock patient, do not prefer the capillary sugar level because it is affected by significantly by the microcirculation. Even the venous blood may not be really good because it may be affected by regional circulation. So if you have an arterial line in situ, take the arterial blood and do it in the ABG machine or in the point of care glucometer tests. Transfusion strategy, more or less settled. You can tolerate up to 7 gram per DL of hemoglobin, except in patients with having ongoing ischemic heart disease or severe hypoxemia like severe ARDS or acute hemorrhages. Just to correct coagulopathy, INR or platelets, administration of blood products is not advisable. Several trials have found that only when you have a planned procedure is there, you transfuse FFP to correct INR or target a platelet of more than 50,000 and transfuse platelet. However, in the absence of bleeding, you can transfuse platelets in the range of less than 10,000 or 20,000 with significant risk of bleeding. Thromboembolism prophylaxis, yes, again, strong recommendations. Pharmacological prophylaxis alone is sufficient. You may not administer mechanical prophylaxis like DVT pumps, because a few of the studies have found that there may be even translocation of thrombus in certain high risk population if it is there already in situ. Regarding LMWH versus unfractionated heparin, LMWH has found some benefit in terms of lowering the incidence of thromboembolism, so it is advisable except in patients with acute kidney injuries where unfractionated heparin may need to be administered. De-resuscitation is an evolving concept. You already know that cumulative positive fluid balance and fluid overload in fact increases hospital mortality, increases subsequent organ dysfunctions, mainly the pulmonary and the kidney dysfunctions, increases ventilator days, increases the incidence of RRTs. So once you have stabilized the patient, initial resuscitation phase you will be administering more and more fluid volume, but once you have optimized, you will think about the neutral fluid balances, maybe by day 3 or day 4. By the end of 1 week, you reach the stabilization phase where within first 7 days, you will try and have at least 2 days towards the end which have negative fluid balance, and you might as well consider evacuation phase later on to administer diuretics. However, the de-resuscitation protocols, the strategies, the exact methods is still evolving, and it is not as stabilized and standardized like the resuscitation protocols. So researches are being conducted, but this is the basic philosophy of resuscitation. Now, sepsis is one such subset where precision medicine should be considered. Although in critical care database, if you think about personalized or precision medicine, more and more research is coming out in the field of ARDS. But in sepsis also, the recent genomic studies have identified grossly 2 types of genome-based endotypes, which are called innate host defense, interferons or adaptive endotypes versus the neutrophilic suppressive or inflammatory endotypes. So in short, immunosuppressive or hyperimmune inflammatory subtypes will have poorer prognosis compared to the other endotypes. So classification of this at this stage will help you in prognosticating the patient, but in future we may have therapies directed towards these different kinds of endotype based phenotypes. So to summarize at the end, the key take home should be enhance screening in your hospital setup to have an early diagnosis, fluid resuscitations, of course crystalloids mostly, and use dynamic parameters of fluid responsiveness as often as possible. And on top of macro circulation, you have to take care of microcirculation by assessing lactate or capillary fill time or both. Noradrenaline followed by vasopressin will be the vasopressor sequence of choices. Consider the role of steroids, glucose control and thromboembolism prophylaxis from the beginning, and beware of the fluid overload, fluid congestion, and think about de-resuscitation. Thank you.
I must say, Dr. Vaidya, very lucid and brilliant presentation. Congratulations for that. House is open for any questions if you have. Even regarding the previous speaker also. Yes, sir.
Sir.
Mimics. Would you like to throw some lights on the mimics?
So I did not intentionally include it because it was not part of the topic. So I focused on management of established sepsis. So not the differentiation of sepsis mimics. For that I think you guys will be much better than me because I am a pure intensivist from a trained anesthesiology background. So I dwell more on fluids, resuscitation, vasopressors and other things. But yes, for sepsis mimics, we on and above our history, clinical examinations and bedside tips, we may have to consider certain biomarkers like procalcitonin, presepsins and maybe more, which again you will be knowing better. So
in fact, Kawasaki and macrophage activation syndrome and APLA, these are very nearly similar to these syndromes. So
Absolutely,
while
sir.
treating cysts, we must focus on these three important causes to differentiate out.
Absolutely, sir. So in my clinical practice, we rarely see these diseases actually. So it goes from emergency to straight away to medicine ICUs. So we take mostly the unstable patients with organ dysfunctions.
Thank you very much for wonderful presentations.
Thank you, sir.
Just a quick clarification from your presentation that you have given vasopressor.
Yes, sir.
So, do you think that first of all, is there any role of bolus, if at all? How many boluses should be given? And then at what point of time you will go for vasopressor? It is right from the beginning if you diagnose sepsis and you start with the IV fluid challenge as well as the vasopressor, or you go sequentially, first you go for the challenge, fluid challenge, and to see the refractory shock. Sometimes you're not responding,
Right,
and
sir.
then so what is the point probably?
Right, sir.
Clear.
That is still a matter of important debate. The previous teaching was first to give a good amount of fluid bolus, maybe 1 liter or 2 liters, like 20-30 ml per kg, and then reassess and then start vasopressors. But we have realized that in spite of so much of fluid boluses, many patients will not respond. The map will not improve because predominantly at an early stage sepsis is a predominantly vasodilatory shock. So the emphasis shifted towards early initiation of vasopressors. No study or guideline has exactly defined it in terms of minutes or hours, but the latest guideline defined that within 1 hour, the first hour bundle of sepsis, that is presentation to emergency department, still within 1 hour, we have to initiate vasopressor if the mean arterial pressure is not more than 65 with fluid boluses. So fluid boluses will start, crystalloid bolus, which may go up to 30 ml per kg in first 3 hours, and within 1 hour we will initiate a vasopressor, which is the noradrenaline infusion as the first line of choice. As regard to such questions on bolus versus infusions, the noradrenaline vasopressins are the drugs which we cannot give as boluses. We have to give it as an infusion, but there are important role of boluses for some other drugs. Practically what we do, preparing NORAD infusion, attaching it and starting it might require some time. Previously it used to be started only after central line insertion, so it used to be delayed further, maybe 1.5 hour, 2 hour in a busy emergency wards. So the committees, the guideline committees recommend starting with peripheral line itself, the way I described. But even that may take 30-40 minutes of time. So during this process, you can use some vasopressors to give boluses to augment blood pressure along with your fluids, that is phenylephrine or ephedrine or mephentermine, depending on your availabilities in small aliquots. This is particularly important if you consider emergency intubation of the patient as well. Many times you will get patients with severe shock who will require intubation as well as hemodynamic resuscitation. So if you are performing intubation, always have a bolus of vasopressor ready with you, because as soon as you intubate these patients, hemodynamics will crash significantly and they can go into cardiac arrest also. Mainly because two reasons. One is the anesthetic drugs which are used for the intubation, which have myocardial depression effect, vasodilatory effects and all. Secondly, more importantly, the catecholamine surge suddenly goes off from the patient, and the loss of spontaneous breathing, which was maintaining venous return of the patient, is suddenly abolished. So that causes the crash, induction and cardiac arrest in many cases. So in such cases, vasopressor boluses should be ready and administered as early as possible, and most of the times you won't have a dynamic arterial line monitoring during this time. You do it only most of the cases practically after intubation. So keep NIBP for the students at 1 minute interval, and you think that I have intubated, so BP will fall. BP will rise because of the response, but that will be there only for 1 or 2 minutes. After 5 minutes, you will see that the BP has crashed significantly. So if your NIBP is at 5 or 10 minutes interval, after intubation, the fast BP reading you will realize in the monitor after settling your intubation tubes and ventilator, will see 60/40 BP. So keep your vasopressor boluses ready. Phenylephrine 50 microgram boluses or ephedrine or mephentermine 3 to 6 milligram boluses.
I think very nicely said. The same trials have, few trials have proven that if you start vasopressor along with fluid boluses,
yes,
it causes early reversal of shock and early, of course, lactate clearance as well.
Yes.
Of course, mortality benefit is difficult to prove, but I agree. So going forward, what you told is that early first hours are very, very important in this management. So majority of the faculties and delegates over here are going to man some centers which might not be as equipped for getting an arterial and getting a lactate.
Absolutely.
So although you have covered all of them, just pinpoint down in a resource limited setting how we are going to manage in first 1 or 2 hours before we send the patient to equipped center or somewhere like this. Few salient points.
So IV cannulation, I will start with ringer lactate as fast as possible, and I will ask the nursing officer to be ready with the phenylephrine or ephedrine boluses to administer. NIBP will follow follow 1 minute interval. And when I getting the IV cannula, I will send a venous for other investigation work. I will send on top of it. I will use it for a venous lactate if arterial lactate is not available. But I will attempt an arterial puncture to get a lactate and other oxygenation parameters and everything in the ABG. So at least one ABG. And then fluids and vasopressors and respiratory support, of course, oxygen by face mask. If intubation is required, ventilation is required, that I will do. And yes, of course, the culture. Whenever I'm getting the IV cannula, I will get the blood and send it for blood culture and start the antibiotics. So these are the things to be followed within 1 hour.
So very nicely said, Dr. Vaidya. Any questions from the audience?
Somebody has a question. Thank you. Thank you.
I want to know how you monitor the lactate level.
Okay. So lactate, few things are fixed. Most of the things are fluid and left to the clinician. The fixed things are, if it is more than 2, you know it is septic shock. If it is more than 4, I mean you know in the septic shock in the appropriate clinical context. And if it is more than 4, you start fluid resuscitation. Even if your MAP is more than 65, if the lactate is 4, you consider and treat it as a septic shock. And then as far as the frequency of monitoring is concerned, of course, it requires, ABG reagent and cartridges require a lot of money in our country. So in our practice, typically if the lactate is very high, say 6, 8 or 10 on presentation, we do it 2 hourly. And once it starts coming down, we move on to 4 to 6 hourly. So in the first day we may see total of 5 to 6 times lactate. From the day 2 onwards we will be doing it twice a day, or maybe 3 times a day max, depending on the patient's improvement and response. And that is the beauty of capillary refill time. You can do it as many times as possible and equally good and sensitive, although it will not give you a precise dynamics like a lactate. Like lactate has a bigger range, 2, 4, 6, 5, 10, you know where you are. Capillary refill time you will interpret as more than 3 seconds or less than 3 seconds. More than 3 seconds means you are probably still lacking in the perfusion. Less than 3 means your perfusion is good. But monitoring it over a period of time, every half an hour, definitely give you a clue. If you have started with CRT of say 5 seconds and coming down on 4 seconds after 1 or 2 hours, that means you are doing a good job. So that can be done much more frequently in the bedside.
Thank you. Thank you so much.
Thank you.
Wonderful presentation.
Thank you.
Thank you for audience for great participation. Thank you again. You just boss, can we take that question later on? Excuse me. We'll discuss separately. You'll have a one-to-one audience with the speaker.
Thank you so much, speakers and chairpersons, for such a marvelous session. I now request our distinguished chairpersons to felicitate our speakers, Professor Dr. Sagar Khadanga sir and Dr. Dalim Vaidya sir. Chairpersons, please. Sir. Thank you, sir. I request the chairpersons to please stay on stage. I would now request our organizing chairman, sir, Professor Dr. Anupam De sir, scientific chairman Dr. Rasmi Ranjan Mahanti sir, and Dr. Sujata ma'am to please come and felicitate our chairpersons with a memento.
Thanks for inviting us.
We now have among us our esteemed guests who have spared their valuable time to grace this occasion. Our Executive Director, Professor Dr. Asutosh Viswas sir, our Dean Academic, Professor Dr. Prasant Raghav Mahapatra sir, our Medical Superintendent, Professor Dr. Dilip Parida sir. I would request them to please come to the dais. Sir, please. I would now request Professor Dr. Rohini Handa sir to come to the dais as our guest of honor. I now request our organizing chairman, Professor Dr. Anupam De sir, and organizing secretary, Dr. Dhriti Sundar Das sir, to join them on stage. Our distinguished guests with flower bouquets, our chief guest, Executive Director, Dr. Asutosh Viswas sir. Our guest of honor, Professor Dr. Rohini Handa sir. Our Dean Academic, Professor Dr. Prasant Raghav Mahapatra sir. Our Medical Superintendent, Professor Dr. Dilip Parida sir. our organizing chairman, Professor Dr. Anupam De sir, and our organizing secretary, Dr. Dhriti Sundar sir. Thank you, sir. We would now request our honorable guests to
गुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं गुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम्
I would now request our organizing chairman, Professor Dr. Anupam De sir, to give his welcome address.
Honorable Director of AIIMS Bhubaneswar, Professor Dr. Ashutosh Biswas, the guest of honor, Professor Dr. Rohini Handa, the Dean Academic, Professor Dr. Prashant Raghav Mahapatra, the Medical Superintendent, Professor Dr. Dilip Kumar Parida, Organizing Secretary, Dr. Dhriti Sundar Das, all members of the organizing team, esteemed faculty members from all across India and Odisha, and the delegates from many parts of the state and also from outside, and the entire organizing team, I extend a warm welcome to you on the occasion of MEDICON 2025, the annual update of Medicine Department. I welcome you to this conference and extend my gratitude to you for coming over here and being a part of this academic journey of one day. Medicine is a sea of knowledge and in no way can be covered in one day. It's an attempt on our part to bring forth the recent advances in the field of medicine, and that's why we have coined the theme as Frontiers in Clinical Medicine and Lessons from 2024. So we have tried to choose topics which are relevant and in which there is some change in knowledge and that we want to disseminate through this forum. I extend my heartfelt gratitude to our speakers who have taken all the pain to come from various parts, from Delhi, from Nagpur, from Bhopal, from Guwahati. I am extremely thankful to them for sparing their time and coming over here to enlighten us and to be with us. I am extremely thankful to all senior physicians and the senior professors of this state and faculty members of this state for coming over to our institute. It's our privilege to have you here, and we hope this one-day program will enlighten our delegates, and you'll go from here with knowledge of recent advances in 2024. Thank you very much.
Thank you, sir. I would now request our respected medical superintendent, sir, Professor Dr. Dilip Parira, sir, to say a few words. Sir, please.
I can only say a few words. Dignitaries on the dais, esteemed faculty members, delegates from outstation, our organizing team, and resident doctors. Medicine is the mother of everything, and about mother, nothing can be told. It is everything. Medicine, without medicine, no other curriculum I can imagine, no other super specialization. So, medicine, medicine. And when I saw the invitation card sent by Professor Anupam, I did not see about any theme, any organ, any message. It is only about the AB MEDICON. So I just failed to understand medicine being such a vast this thing, how they have not given a particular theme, but right now I heard he is saying just actually this conference is about the journey of medicine from 24 to 25. That means only recent. So I wish this conference CME a great success, and thank you so very much for inviting me.
Thank you so much, sir, for your address. I would now request our distinguished Dean, Academic Professor Dr. Prasant Raghav Mahapatra, sir, to say a few words.
Good morning, sir. Respected our Director, Professor Biswas, our guest of honor, Professor Handa, and our Medical Superintendent, Professor Parida, Organized Secretary and Chairman, Dr. Anupam De and Dr. Dhiti, and respected and these audiences, some of my seniors and teachers, my regards to all. I best wishes to residents and staffs. It's my honor to be here to welcome to the update, medicine update, and regarding recent advancements, challenges in internal medicine. As we gather today, we reflect the incredible progress, this journey we made. Internal medicine is, Dr. Parida told, cornerstone of all these whole medicine medical subject, bridging the specialty and addressing the need of our patients. Yet there is yet progress to come, and always there is a gap. And things medicine is changing, and I want to recognize the dedication of our faculty, new department, researchers and clinicians. They have taken this way up to to these steps last 12 years. Dr. Anupam has joined with me as a assistant professor, and now he's professor. Things have changed over that, and now this is a good thing to know that this under the leadership of our director, and but the department is the academic committee has passed DM in intensive care medicine. And that will be really add to the medicine department to serve critical care as a specialty. Together, we stand together as an institution and challenge ahead and continue to make impact whatever possible in lives of the patient and academics. Thank you very much for this your efforts, for this update. I thank you very much. Best wishes for the conference.
Thank you so much, sir, for your address. I now request our guest of honor, Professor Dr. Rohini Handa, sir, to say a few words.
Professor Ashutosh Biswas, dignitaries on the dais, friends and colleagues, and I see many friends in the audience. I would like to extend my greetings to you on the occasion of this conference. Actually, medicine is perhaps the mother of all specialties, and notwithstanding any of the advances that we may witness in any of the subspecialties, unless you are a good internist, you cannot be a good subspecialist. The bottom line is that you need to know your basics well, and medicine is rapidly changing. The concepts of today become the discards of tomorrow, and conferences such as this one help us to update ourselves, and there is no substitute for staying abreast, so that eventually we offer the best care to our patients whom we seek to serve. And I wish the conference, the organizers and the institution all success. Thank you very much.
Thank you so much, sir. I would now request our esteemed Chief Guest, Executive Director, Professor Dr. Ashutosh Biswas sir, to address the audience.
Good morning to all of you. The guest of honor today, Dr. Professor Rohini Handa, and all the faculty members, Dr. Dean Pierre Mahapatra and MS Dr. Parida, and the organizing committee, Dr. Anupam, Dr. Siti Sundar Das, and then other faculty members of the Department of Medicine organizing this medicine update today. I'd like to congratulate them for organizing this, the update, and they thought probably this should be a right time, right way to update the Department of Medicine associated with all the faculty members and the resident in this domain. And it is, yes, I have heard that all previous speakers told about medicine and mother of medicine and all. We know the journey, how now it is transforming over the time. If somebody asks me in which subject you are specialized, I say medicine. Oh, आप दवाई देते हैं? So this is medicine. Public think probably I dispense the medicine, the tablet. That is what my specialty. So this is understanding the public in the community. Medicine doctor, they give medicine. A pharmacist. So this is what. But yes, if we go inside, it's really an internal medicine, a turmoil, a challenging things, how to really attain and clinch the diagnosis. Finally, if somebody comes with the fever, there are maybe 10, 20 causes of fever. So now, yes, this is malaria fever. This is the key challenge for the medicine. And then treatment, obviously after malaria, everybody knows what is the drug for malaria. Nothing to go for it. So anyway, and we are trying to also understand the medicine. We are specialized in which subject? Still we are looking for. General medicine, you are general, okay, general surgery. And then all, if you cut piece by piece, liver is taken away, the brain taken away, lungs taken away, kidney taken away, nothing is left for medicine. I was looking for what is for my domain, where I stand. So I did not find anything, any land to stand on that. So then probably it is everywhere I have to go. I have to roam around all the branches under me. This is general. So Lieutenant General and all like general degree. So I am also that in that way. But yes, this is very challenging. Over the time I spent more than 30 years in AIIMS Delhi in the medicine. And what challenging, it is mostly the highly overloaded department in the institute, the medicine and general surgery, and the OPD burden is very high, and it is difficult to manage all. And Dr. Handa, I was associated with Dr. Handa for a long time, almost 30 years in AIIMS Delhi, and we worked in the same department, same unit, and for a long time published many papers and all, although he has branched out to a very specialized, and I was trying to look into the infectious disease and all. So that is how we started our journey. And Dr. Handa, I am very grateful and thankful. I gave a call for attending, and he was very positively said, yes, I am very much I'll be coming to your update, although I may be maybe my schedule is busy, that he gave the time and he's flying back immediately after this to Mumbai. He's assigned his commitment. I am extremely thankful for his contribution and coming and supporting this update, sir, for this program. And also I am thankful all the senior faculty members here around from Bhubaneswar and all many AIIMS participating, and the higher officials are all dignitaries coming here to, and the residents also coming here to understand, to know the update in medicine. Yes, I was going through the program is very exclusively, designed and kept some subjects that to really look into, to understand and keep this for advancement. What are the recent advances taken place in this subject, and to discuss and to disseminate this knowledge. And this is the right forum to know and to understand. So I think without wasting time, thank you very much for once again to the department, the organizing committee for organizing this, and all the student and faculty members supporting this program. Thank you very much.
Thank you so much, sir, for your address and boosting our morale by gracing the occasion. I would now request our organizing chairman, Professor Dr. Anupam De sir, scientific chairman, Professor Dr. Raspiranjan Mahanti sir, and organizing secretary, Dr. Dhriti Sundar Das sir, to felicitate our honorable guests with memento and uttariya. Our chief guest, Executive Director sir, Dr. Ashutosh Biswas sir. Our guest of honor, Professor Dr. Rohini Handa sir. Respected Dean Academic, Professor Dr. Prashant Raghav Mahapatra sir. Our respected Medical Superintendent sir, Professor Dr. Dilip Parida sir. Just keep it straight. I would now request the dignitaries on stage to please felicitate the members of organizing committee, our organizing chairman, Professor Dr. Anupam De sir. Our scientific chairman, Professor Dr. Raspiranjan Mahanti sir. Our organizing secretary, Dr. Dhriti Sundar Das sir. Our treasurer and joint secretary, Dr. Debanand Sahu sir. Our poster and food committee members, Dr. Sujata Devi ma'am and Dr. Anupama Behra ma'am. Our Transportation Committee, Dr. Srikant Behra, sir. Myself, Dr. Arpita Das. I would now request our organizing secretary, Dr. Dhriti Sundar Das, sir, to give his vote of thanks.
Good morning, everyone. So it is my privilege to stand before you today to deliver the vote of thanks for this remarkable event, MEDICON 2025, organized by the Department of General Medicine, AIIMS Bhubaneswar. First and foremost, I would like to thank our chief patron, come chief guest, Professor Ashutosh Biswas, sir, Executive Director, AIIMS Bhubaneswar, for his address and valuable inputs, which emphasized the role of institutions like AIIMS Bhubaneswar in shaping the future of healthcare. I'd also like to extend my gratitude to our guest of honor, Professor Dr. Rohini Handa, sir, for his valuable time and insight in his address to the gathering. We are equally grateful to Dean Academic, Professor P.R. Mahapatra, sir, Medical Superintendent, Professor Dilip Kumar Paida, sir, whose addresses were not only inspiring but also reinforced the importance of collaborative efforts in advancing medical science. Their speech seems like igniting our enthusiasm for continuous learning and academic growth. I would like to express our heartful gratitude to all the distinguished guests and esteemed faculty members for gracing this occasion. Without their invaluable support, this event would not have been success it is today. Moving forward, I would like to offer my deepest gratitude to the eminent chairperson and distinguished speakers for their scheduled enlightening sessions. Your expertise and commitment to sharing knowledge is envisaged to enrich us all and set a high standard for academic excellence. I would like to extend a warm thank you to our organizing chairman, Professor Dr. Anupam De, sir, for his leadership and for delivering the welcome address, setting the tone for this important gathering. I'd also like to express my deepest gratitude to Professor Rashmiranjan Mohanty, sir, our scientific chairman, for his outstanding leadership and tireless efforts in curating such a comprehensive and impactful scientific program for the conference. A special token of thanks to the hardworking members of the organizing committee, to the scientific chairman, joint secretary, registration, invitation team, transportation stage committee, poster committee, and the food committee. I'd also like to thank all the delegates, participants, and attendees for being part of this conference. Your enthusiasm and engagement will immensely contribute to its success. Finally, I would like to thank the IT's electrical, security, sanitary staff. Each one of you played a pivotal role in ensuring the smooth execution of this gathering. Your dedication and teamwork have truly been remarkable. In conclusion, it has been an honor to be part of this event, and we hope the knowledge shared here will continue to inspire us in our respective fields. We look forward to more such enriching interaction in the future. Thank you once again. Have a wonderful day ahead.
Thank you, sir. As we come to the end of inauguration ceremony, I would now request the dignitaries to please take their seats in auditorium. Now we have our esteemed Executive Director, sir's oration. Chairpersons, Professor Dr. Punna Chandra Das, sir, Professor Dr. Rabindra Kumar Dalai, sir, and Professor Dr. Lalit Kumar Meher, sir. Sir, please. And invite our Executive Director, Professor Dr. Ashutosh Biswas, sir, for his oration.
most prestigious executive directorate. And the speaker is Dr. Ashutosh Biswas, Executive Director, AIIMS Bhubaneswar. Sir, please come to the dais. Now, as you all know that antimicrobial resistance is a serious global health problem, and the present situation continues. If the present situation continues, probably the mortality rate due to antimicrobial resistance will exceed more than cancer or any health disease. And we all are responsible for this. Reckless use, prescription of antibiotics, misuse and overuse of antibiotics. So these are the main causes of antimicrobial resistance. To overcome this, we have got no drugs, newer drugs in the pipeline to replace the older drugs. So I think antimicrobial stewardship and the stringent use and not reckless prescription of the antibiotics use, and in the future the genomic-based precision medicine may help to steer clear all this antimicrobial resistance. I now request my co-founder Dr. Lalit Meher to introduce Dr. Biswas.
At the outset, I thank Professor Anupam for giving this opportunity to chair this prestigious session where Professor Dr. Ashutosh Biswas will be delivering the talk on antimicrobial resistance and the antibiotic stewardship. You know that he is presently the Executive Director at AIIMS Bhubaneswar. He was the former Director and Vice Chancellor of AIIMS Patna. Also, he was the Professor of Medicine and Infectious Diseases at AIIMS New Delhi. He is the recipient of fellowship in ID from UCLA and USA. He has also received fellowship in infectious disease from Manchester University, UK, postgraduate diploma in epidemiology, diploma in infectious disease from Bangkok, and master's training in clinical research, Albert Einstein College of Medicine in USA. So he's one of the pioneers in infectious disease, and now we'll be listening from him one of the very important topic of today, that is the antibiotic stewardship. Now I request Professor Ashutosh Biswas to go ahead with the talk.
Thank you, sir, very much for your all compliment, but I don't deserve those. And extremely thankful for giving me opportunity to the organizers and the chairpersons. So just as you have heard that this is very challenging, that AMR and antimicrobial resistance and stewardship program is a emerging infectious disease resistance is a great challenge for the world. So it's a global challenge, public health challenge. In that context, how we are really, how we are heading towards this is how we are addressing and what we should do for this. So it's a challenge for everyone. I'm going to talk about some policies. I'm going to talk about the human behavior and the habit associated with the use of antibiotics. So left and right, we know that we have been using antibiotics, and most of the time before we attain the 18 years of age, probably now more than 10 to 20 times have been exposed with the antibiotic, given antibiotic for the treatment of our 18 years. So this is one, before you start your really adulthood journey and you have been exposed. And over the rest of the life, I don't know how many times you have been given antibiotic or we have taken antibiotics. And this is how these antibiotics are taken by us and how we are using, what policy, and what is our habit in the community and as well as in the hospital settings. So hospital institutions or medical institutions are the most important. We are focusing on that, how really stewardship program, antimicrobial resistance associated with most of the time the hospital setting, but we don't talk about the community stewardship program and emerging of these resistance microbes in the community. So that is most of the time it is neglected. So I am going to focus on a little bit on that also, to go into the community part, how they are responsible, and also hospital setting, the medical health care settings and all healthcare workers, including doctors, nurses, and other staff associated with the spreading of this, transmission of this resistant microbes in this setting. So it's I think gradually it's a huge economic loss to the country and to the world, and is a the financial burden, economic burden to the institution as well as on the family, those who are taking this. So, and also it's not that the economic, we were also losing our high mortality, the lives that associated with the increase of emerging of the resistance microbes across. So it's a huge burden on us, and this is something which is interaction between the many domain. It is mostly say this is not only the human health, this is one health now. We cannot ignore the other health of the animal health, or maybe this COVID has taught us this infection, the COVID is a zoonotic disease. Now we are suffering, the whole world suffered from that zoonotic disease, the COVID, corona. So spillover. So we cannot think the human health only will protect our environment, human environmental health. And only we talk about the hospital and all about our health. No, it is the one health now concept, and you have to look, if you have to survival of the human being is dependent not only our institutional medical institution, but also the other look into the environment and also animal health. So we have to look how they are using this antibiotic for it's a growth promoter used in the animal and in poultry, and also used in the agriculture industry. So that is the huge burden for increasing the transmission of this resistant microbes. So how we are addressing that? Because this is the part of the veterinary department, where the animal, where the human health, so there is no interaction. Now we have to talk one line, one health. That is how we have to, if you want to strengthen this policy. And then also, other than health institutions out of the hospital, what is the community, how they are responsible for spreading this resistant microbes inside the community? What is the prevalence of this resistant organism inside the community? We talk about the hospital, infection control, stewardship program focusing on hospital, but we are neglecting this community. So recently we have seen that many policy makers and many countries are giving very, very important policy to imbibe the community, how we should behave, changes the behavior of using antibiotic. Most of the time we see that 70% of the time, if we have some upper respiratory infection, we go to just chemist and get antibiotic 1 or 2 days. Antibiotic because why to take risk? Definitely, we don't want to take risk in my life. So antibiotic if we take, probably you are safe. That is the mind concept, and also doctor prescribing. Maybe infection, first you give antibiotic, let us behave, let us treat in a safe zone. Ye de do, wo de do. So pehle now, so this is how you want to play safe game. And that game blame, and then you really, it has been seen 70% of the time we are misusing the antibiotic, which I call abusing the antibiotic. So misuse and abuse are the very fundamental and very casually we are taking this, and this is what, and different other, how we are disposing this. Have you ever thought this all disposal contaminated with the antibiotics, all we are disposing, and it's going out of the hospital, how they are disposed? Have you ever thought in this going into the community, and these are all contaminated with the water? We are consuming the water with these antibiotic chemicals. We are consuming it through the water content. How many? Now, do you have any idea in that? Have our health department estimated what antibiotic chemicals are present in the water, in the groundwater? And this is also the vegetables that we using, that is also absorbed by the plant, that all chemical we are going to eat. So vegetable, and also the meats and all, every other things, vegetables. these are all exposed to the antibiotics. And as a promoter or whatever, maybe the disinfections and then preservatives and so many. So we are really heading in which direction, we are not sure. We are saving the life, or we are really promoting or killing the lives further. And you have seen the resistance of antibiotic. No, antimicrobial resistance is increasing. So that is one way of saving, another way is creating our own grave due to this process. So what we should do? So this is a very huge economic loss and financial burden. And this is how the graph has been. But shortly you can see the pre-antibiotic era, antibiotic era, and we are going to step towards the post-antibiotic era where no antibiotic will be there and virtually no antibiotic to treat the resistant microorganism. You can imagine. Pre-antibiotic, पूरा एक गांव में एक इन्फेक्शन तो पूरा huge mortality होते थे. Antibiotic saved the life. Now this antibiotic is going to bring you such a situation, it's unimaginable. And this is narrow part is because no new molecules, no antibiotics are coming up, no research development. We do not have much antibiotic to play with all these resistant microbes. We are going to face a huge challenge in future. So this is a matter of concern. What are the drivers of this AMR, antimicrobial resistance? How we are going to? These are all the misuse of the antibiotic. If you are using more antibiotic, you are increasing the more resistant prevalence. So this is how the hospital, if they are using and misusing, the resistant percentage is very high in that hospital. It is very clear. So that is how this is all infection now. We have definitely going into that infection control and stewardship program. That is how it has been seen that is going to reduce this infection resistant microbes. Now agriculture and antimicrobial, this is all livestock and crops are as I said, are also contributing very equally into this business. So in our hospital setting, what is really happening? Who are the people to support this, to minimize the resistant organisms to emerge? Because of our rapid diagnostic facilities is not there. We go for empirical treatment. Most of the time, infection. You clinicians, you think, this is a bacterial infection. You don't need antibiotic for fungal and viral. We don't know, but still we give the antibiotics. And other also antifungal and antivirals, they are equally also important if we are not very much sure. So antibiotic use are the most important misused, that we are concerned about that, and we do not have much molecules to play with those. So this is how how it is. Globalization and travel are the most important factors for transmitting this from one place to another place, international as well as the one institution. The people are coming to meet the patient. If the treatment dose is not adequate or dosing interval is not adequate or duration is not adequate, you can imagine this leads to prolonged illness, and that window is going to transmit to the environment and to the healthcare workers associated working in that environment. So it's really is a very, each and every component, I'm not going, is a huge task, just a guideline and where we are and what policies. ICMR is for last 10 to 15 years working on it all over the countries. I think they're gathering the data and going to have a national national policy for using the antibiotic, and they are going to give you, and there it is mentioned in the also ICMR website and the guideline that how and what reasons they are going to have what antibiotic. It's not that the national guideline is going to solve you. We have to develop our own regional policy of antibiotic, because the national will not really work for the Bhubaneswar or many other hospital. We have to develop in this region what or the susceptibility test after doing the susceptibility to the specific organisms, and then your antibiotic. So this is how each and every institution should have their antimicrobiome and also susceptibility testing policy and then antibiotic program. So these are all So how we are going to address these issues in the hospital setting and your community setting. So at this moment, I would like to focus on the hospital setting. It is just not a one-man show. It's a multidisciplinary task. So antimicrobial stewardship program, you should have a committee. First, all the institutions, they should have your antimicrobial stewardship program committee. So committee will comprise that your pharmacist, then IT people and the nurse, and also from the clinical microbiologist and ID physician. So about 6 or 7 people at least you should have a committee. So then they are going to do all these activities, how we are going to really audit using the antibiotic and then infection control and different other issues to be inside this program. So it is just that antimicrobial use is directly proportionate to the emergence of antimicrobial resistance. That is what one line equation that you can think. So is the more prevalent, mostly as we have realized in the hospital and infection or hospital associated infection than the community associated infection. That's clear. But now we have seen also in the community the resistant infections are also there. It is increasing. It is a very serious threat because of the spillover from the hospital to the community. So it's not that it's a community acquired pneumonia or community acquired infection. He might not have infection, resistant organism is not. Most of the time we see 10 to 15% almost coming with this infected multiple drug, MDR organisms. So that we have to be very serious about that. And then the highest rate of antimicrobial resistance also to be highest rates of antimicrobial use. So that if you are using antimicrobials, then the hospital is having highest rate of resistance. It is equally parallel. So this antibiotic use is going to create a longer duration of stay in the hospital if it is not appropriate. And that longer duration of the stay in the hospital going to increase the risk of complication, morbidity, mortality, and also spreading the infections across. So this is just resistance to different microbes, Staphylococcus, Enterococcus, and gram-negative, and then Pseudomonas hospital. So it has been seen that mortality rates are exceeding with the Enterococcus mostly more than 30% most of the time. But it differs from hospital to hospital. So general, this is the ICMR report. And mostly the MRSA definitely having higher mortality than MSSA. And this is, sometimes we have to give importance to that. Unnecessary also, we are killing our beneficial or protective flora or bacteria by giving this antibiotic. So what are the role of this beneficial bacteria or the protective flora habitat harboring inside our body? And this is a very important also consideration to think before we use this antibiotic. And now this, as I said, before 18 years, maybe 10 to 20 times or the 20 course of antibiotic has already been received by any children, and this is a huge burden on it. And then definitely if somebody is exposed, likely to develop more antimicrobial resistance to those children and then adult. And antibiotic affect our resident microbiota and may not fully recover after a course of the antibiotic. So naturally the microbiota is also coming up a very big way, and every time we use this antibiotic and going to change your internal environment we have the lot of organisms, probably they're good for your health, and we do not know exactly now. A lot of recent advances are coming on microbiota and how they are helpful, how they are keeping your health fit, and what are the uses. And by using this antibiotic, we are destroying this environment, internal environment, and it is causing a very serious health effect. And maybe these are associated with the other non-communicable diseases like diabetic and irritable bowel syndrome, allergic, asthma, and so many other diseases that we cannot really have a causal association established. So these are all now this very important thing that we are treating one patient with antibiotic, but this will also have an impact on the effectiveness of the other patients also, because they are also indirectly exposed and transmitted and resistant organism going to that. So we have to be very careful in that also. It's not individual. It is, we are going to look about the safety of the other patient where you are using the antibiotic, because emerging resistant and spreading to the other patients, that is also our concern. And adverse impact also, this antibiotic misuse is not only affecting the associated people around in the hospital, is also affecting the society or community, and which we ignore most of the time. So therefore, this antibiotic misuse across the country, or maybe we Indian people are not following any guideline or any policy for using the antibiotic. We are not very serious about this. I think this is the time now to think about, and it should be, I am not sure how it should be, make a mandatory policy for this, and we have been talking this for many years, 10 to 20 years we have been on this job for implementing the stewardship program in the internal hospital, and to have a policy and antibiotic use, and who are the persons that can prescribe first line of antibiotics, second line of drugs, and then multi-drug resistant in the hospital. Now, if anyone, suppose in a hospital you have opened up the infectious disease clinic or specialist, if you are going to teach any surgeon, no, your antibiotic, you should change antibiotic. So he is going to look at you, you are going to teach me, I have been working here for last maybe more than 20, 30 years, and now we are going to teach what antibiotic to be given. This is the conflict now many in hospital going on. So this, you are not going to change your behavior, you are not going to change or to understand what antibiotic should be given, what are the policies, who are the people, how it should be, how it should be monitored. And there are many things. Probably still we have to learn. Each and every hospital should organize this program, and those who are associated with the infection, directly dealing with the treatment, management, prescription, so they should be given very strong message that this is how the hospital policy is, you have to follow, and each and every hospital should come out with their antibiotic policy, antibiotic based on their antibiogram susceptibility test of their own ICU and hospital setting. If not, probably they can have the regional policy if any hospital, and if you think of probably maybe 4 or 5 medical colleges here and the hospital, we can draw all this, pull all the data and have a regional antimicrobial data to share, and to develop a antibiotic policy that these are the antibiotic really going to have first line or second line, this antibiotic is going to be useful for this kind of disease. That would be nice. Otherwise, each and every people will work independently and is not going to solve the issues. So there are many things, and how. So this most important thing is the appropriate culture we don't have before giving the antibiotic. We do not have what organism really we are dealing with. It is just on assumption, empirical, you are giving this, and then you are not sure if it is a Friday or Saturday, then microbiology department is closed. Now Sunday you cannot do anything, Monday will come, and then they will look up to this or this organisms. So okay, this is what, and Monday we will go in the evening, you will know, okay, this having these organisms, and then change the antibiotic. By the time you will lose 3 or 4 days. So most of the time, many factors are involved. So how to augment this system, culture system, even in the Sunday culture, you have to have some mechanisms to have the report, and you have to have the mechanism to transmit that report to the particular surgeons or the physicians that yes, this is what the organism is. Now immediately you have to change, you have to take action for this. Otherwise we are very casual and then okay, it will come and then we'll see. This cannot be really, this cannot work further to deal with this emerging infectious diseases. We have to be very serious about this. And then when to stop antibiotic. After starting, are you looking for 48 hours or 72 hours to relook whether it is really appropriately used, what are the parameters, and then whether it needs to be changed the antibiotic. So is there any policy for that? All the antibiotics that patients are getting, who are the person, who is going to look for? So there should be a teamwork. There should be, or maybe it's now all individual people. If my patient, I have to look into. Nobody should touch. This is when I will tell someone to change, nursing staff or resident to change the antibiotic, then only. Otherwise, nobody can go and intervene to change the antibiotic. And that is also risky. If you change, tomorrow patient dies. See, you change the antibiotic and the patient died. And my patient, they are going to create a fight in between. There are legal, ethical issues are involved into it. So you have to develop a very strong policy which are legally sound and ethically sound. So this is what our most of the institutions should have this, and a clear guideline also is there, but not very perfect in the ICMR that we know, and these are all theoretical to educate the people and educate the hospital personnel or hospital the healthcare workers, doctors, nurses. We also conduct the training program for all infection control and different other prescription habits and audits and all that. And this is what the 30% rule also, you see that 30% hospital in patients are at any given point of time receive antibiotics. So these are all when it is not even required, but yes, 30% of the antibiotic are prescribed inappropriately, 30% of all the surgical prophylaxis is inappropriate. So 30% hospital pharmacy costs are due to the antimicrobial use. And then 10 to 30% antimicrobial cost can be saved by using the ASP, antimicrobial stewardship program. So it's a very important factors, and we have to have a balance that appropriate use and unnecessary or misuse or abuse of antibiotic, that is really, you have to look into seriously into it. And this is a teamwork in the hospital. I have not gone into detail because of the lack of time. Just I have given you overview to understand and to bring out a seriousness and where we are heading, how we are going to how we are dealing this domain, and where really we are going to head in future. This is a very serious threat for us, and a global threat for everyone. So I think thank you very much. These are all the principles for rational antibiotic use. I think every institution have their own how to rationally use the antibiotic, and there are few steps are there, and then if you follow, and we have our antibiotic policy at AIIMS Bhubaneswar also. This is this updated on 2024, and thank you very much for your kind patience hearing. Thank you.
Thank you, Dr. Biswas, for your nice and elaborate talk. And you have told everything regarding the policy of antibiotic use, how it is misused. But the thing is that everybody has got a right to survive. So the microbacterials or fungals have also right to survive. That way they develop resistance to the antibiotic. Otherwise, they will also be vanished from or extinguished from the society. So we have to take care of everything, because there are also some good microbacterial which are useful for us, and they have to be protected. Anyway, you have to, in the initial stage, you have shown a map where India had the highest number of antibiotic resistance, more than 30%. That means in India, you can find that most of the people are misusing antibiotic. As you have rightly pointed out, that people take, when the doctor prescribes for 7 to 10 days, people take for 1-2 days, fever disappears, then they stop the antibiotic. So inadequate treatment, improper use of antibiotic, all these you have highlighted very nicely. And I think this is very useful topic and useful for all the physicians and been discussed repeatedly. Still the misuse of antibiotic has not been reduced or not been stopped. We have to be very alert in future to combat this problem. Thank you.
Thank you, sir. Thank you very much.
Any question from the orations? We usually don't question.
Chairman oration, usually we don't encourage questions. You can discuss in the free times. Thank you.
Okay, thank you very much, Dr. Biswas, for your talks. We end this session. Thank you.
Thank you so much, sir, for sparing your valuable time and for such an insightful talk. I request now our chairpersons to please stay on stage and felicitate our Executive Director, sir, Professor Dr. Ashutosh Biswas, sir. I would now request our organizing chairman, our scientific chairman, and Devanand sir to please, sir, felicitate the chairpersons.
Oh, acha. Chalo.
Thank you, sir. Next, we have a session on rheumatology. To chair this session, I request Dr. S.K. Mahapatra, sir, Professor Dr. Jyotiranjan Parida, sir, and Dr. Soumyaranjan Tripathi to please come on dais. Please arrange the chairs. I request the chairpersons to introduce and invite our speaker.
So after a marathon and prestigious oration by Professor Ashutosh Biswas, and also as Professor Anupam Dev said, the new frontiers in medicine, we will be now discussing new frontiers in rheumatology. So I welcome you to the second session on rheumatology, which is again very important. And we are very fortunate to have Professor Rohini Handa here, who is a national luminary and an international personality and an intense researcher. We are again very delighted that he has a soft corner for Orissa. Whenever we request him, and also at the request of Professor Biswas, he has agreed to come here, although he is extremely busy in his own domain. So Professor Handa, you know, is a very known figure, 40 years of experience. He is MBBS, MD, DNB, FM, FICP, so on and so forth, Glasgow. Ex-HOD Rheumatology, AIIMS New Delhi, Senior Consultant Apollo Hospital, Delhi. Recipient of Prime Awards including the J.C. Patel and B.C. Mehta Prize, Dr. J. N. Berry Award. Published more than 330 review articles, book chapters, papers, abstracts, and many, many more. I will also take 1 minute of yours, sir, to know about your other achievements. I will be happy to speak here. Professor Handa is professor and senior National Department of Rheumatology, Indraprastha Hospitals, New Delhi, India. He has held several distinguished positions in illustrious institutions. He was Professor of Medicine at All India Institute of Medical Sciences, New Delhi, Dean of the Indian College of Physicians. When I received my FICP from your hands, sir, when I received that FICP, Chair of International League of Associations for Rheumatology, President of Asia Pacific League of Associations for Rheumatology, and President of Indian Rheumatology Association. I should not introduce further. If I speak anything else, just like showing a torchlight to the sun, there are many things, and he will be speaking on new frontiers in the treatment of rheumatoid arthritis. I welcome you, sir, for your topic and to address on this subject. Thank you very much.
Chairpersons, ladies and gentlemen, at the outset, I would like to thank AIIMS Bhubaneswar for inviting me to speak at this meeting, and I would also like to acknowledge the Director, Professor Ashutosh Biswas, and this is a picture which is a throwback to the times when we were working together at AIIMS, New Delhi, and this is on the eve of my voluntary retirement from the institution, and it's also a pleasure to see Professor Naval Kishore Vikram here, and many other friends, and I think I've been to Odisha many times, and it's almost like a homecoming to me. My brief this morning is to talk about rheumatoid arthritis, and I would like to begin with this saying by Confucius, who said, "Acquire new knowledge whilst thinking over the old, and you become a teacher of others." And this is true of the talk that I am going to give. While we talk about new knowledge, I think it's only right that we dwell upon old wisdom. When we talk about arthritis, this is the smorgasbord, and in terms of commonality, it is. I would also like to welcome Professor A.B. Day, another distinguished colleague. I think Dr. Biswas has assembled together a galaxy of old colleagues. Old friends together. And we worked on the same floor, the same department for many years. And I was actually, for Dr. Day, showing this picture, which was on the eve of my retirement from the All India Institute of Medical Sciences. But anyway, and before we start talking about rheumatoid arthritis, we actually need to look at the smorgasbord of arthritis, and from the perspective of the community, the commonest arthritis that you encounter is osteoarthritis. But when you talk about the inflammatory arthritis, it is rheumatoid arthritis which tops the list. And for the students and the residents, the number of joints that are affected, that actually helps in deciding what disease you are dealing with. And rheumatology is not high-tech, it is high-touch. Single joint involvement, you need to think of two diseases, infections and crystals. It could be septic arthritis, or it could be tuberculous arthritis in our country, and crystals. And when you have 2, 3 or 4 joints being affected, you call it polyarticular disease, and the most important differential diagnosis is spondyloarthritis, the flagship disease of which is ankylosing spondylitis. And then of course gout could be monoarthritis, sometimes oligoarticular, and rarely in the elderly polyarticular. And when you talk about polyarthritis, which is involvement of 5 or more than 5 joints, you have rheumatoid topping the list, and then you also have psoriasis and the connective tissue diseases, and we're going to talk about rheumatoid arthritis today. And if you look at the making of a diagnosis in rheumatology, three things go into the making of a diagnosis, and the font size is more by design than by accident. History, examination, and investigations. And you need to be extravagant with your history. You need to be generous with your examination. And in a resource-constrained country, you need to be parsimonious with your investigations. So it is, at the end of the day, a clinical diagnosis, and as Osler said, listen to the patient, he is telling you the diagnosis, and we rely upon pattern recognition, and I will run through the different patterns of arthritis for the benefit of the students. Rheumatoid arthritis is a diagnosis made on the bedside when you have a patient coming to you with bilateral inflammatory polyarthritis involving the small joints of the hands and feet. The DIP joints are spared and the joint swelling is boggy. So you actually don't need any investigations, and you need to listen to the patient, examine the patient, and the phenotype is dominated by small joint involvement. In osteoarthritis, you get bony swelling, the Heberden nodes, and this is in contradistinction to the boggy swelling, and you actually need to feel the joint to understand that. And then you talk about spondyloarthritis, where you have oligoarticular involvement, asymmetrical large joint, preferentially involving the lower limbs, and you have inflammatory back pain. And I would also like to remind the students that the gender distinction in ankylosing spondylitis is getting blurred. When we trained, it was 8 or 9:1, and now people say that women are as much affected as the men, and the gender distinction is about 2:1, and for non-radiographic SPA it may actually be equal. The pattern of psoriatic arthritis, it's more heterogeneous. You have a varying phenotype, asymmetrical involvement, symmetrical involvement. Then you can have arthritis mutilans, involvement of the spine, DIP joint involvement, but what is a giveaway is the dactylitis. So if you have a swollen digit like this, you actually are pretty sure that you're dealing with psoriasis, and you need to make a search for skin lesions in hidden areas, or you're dealing with reactive arthritis or spondyloarthritis, and these are examples of dactylitis that I've shown. Gouty arthritis, dramatic in presentation, lower limb involvement more, and these are episodes of pain, and this is something which, in contrast to other rheumatic diseases, more common in males. Lupus, the joint involvement mimics rheumatoid arthritis with the additional features of a photodistributed rash and fever. Fever is extremely uncommon in rheumatoid arthritis, and this is the prototype of lupus. And when we talk about rheumatoid arthritis, the phenotypic distribution is small joint involvement, bilateral, hands and feet being affected. And then you have the classification criteria, which are a strain on your memory. No clinician can ever remember. You have now criteria for everything. You have scoring system for everything. So you have to remember that the classification criteria are meant to be subservient to your clinical judgment. Classification is different from diagnosis, and it's a trade-off between sensitivity and specificity. And if you need to homogenize your patient population, have a study between AIIMS Bhubaneswar and AIIMS Delhi. You need to have classification criteria, but on the bedside, in the clinic, you actually need criteria for diagnosis, and nothing replaces the reasoned judgment of a seasoned clinician. There are some caveats in the diagnosis of rheumatoid arthritis. One should be extremely reluctant to entertain a diagnosis of rheumatoid arthritis unless hands are affected. Single joint involvement, you need to rethink your diagnosis of rheumatoid arthritis. DIP joint involvement, uncommon, and asymmetrical involvement, you need to think of psoriatic arthritis. And this is a test, and as Professor Biswas was talking about antibiotics, used, misused and abused, so this is a test widely ordered and equally widely misinterpreted. Rheumatoid factor, and as you can see, rheumatoid factor is not the exclusive preserve of rheumatoid arthritis. You have multiple conditions, and we have the country's leading geriatrics expert here, Professor Day. 5% of healthy elderly individuals will have rheumatoid factor positivity, and unless you give credence to their clinical history, people with nodular osteoarthritis of the hands will get a label of rheumatoid arthritis. Infections can trigger rheumatoid factor positivity apart from immunoinflammatory conditions, and that's the reason why it's called rheumatoid factor and not the RA factor. And then we have antibodies beyond rheumatoid factor which add to the specificity but not to the sensitivity, and you have different serologic subsets of rheumatoid arthritis. Dual positive, single positive, and actually serology does not influence treatment. Whether it is ACPA positive or RF positive or seronegative, the treatment remains the same, and for clinicians, these are the common pitfalls. Failing to consider a diagnosis of rheumatoid arthritis when rheumatoid factor is absent, basing a diagnosis of rheumatoid arthritis on tenuous serologic abnormalities, frequently repeating rheumatoid factor, and ordering ACPAs without even ordering a basic rheumatoid factor. There is only one time that you are well placed to repeat your rheumatoid factor, when the patient is getting restless. When the lady says, "Doctor, दवाई कितने दिन खानी है?" Then you say, भाई को टेस्ट करा लेते हैं, अगर ख़त्म हो गया ब्लड से बंद कर देंगे. So it's more the art of medicine than the science of medicine that you motivate the person to continue, and serology seldom if ever become negative. Now, having iterated the old wisdom, let's talk about the new frontiers. The last 20 years of rheumatoid arthritis have been dominated by the 20th letter of the English alphabet, the letter T. We talk about 3 sets of T's: time to treat, treat to target, and last but not the least, the targeted treatments. And this is what has actually dominated the field of rheumatoid arthritis and indeed rheumatology. Rheumatoid arthritis is now believed to be a time-critical illness. Early treatment fetches you the best evidence, and this is a graph which shows you the probability of DMARD-free remission, and in patients who are instituted treatment early versus patients who start treatment late, the curves begin to separate out, and so also radiographic outcomes which are much better when treatment is started early. The reverberations of delayed treatment are felt decades later, but I would also like to mention it's never too late to treat rheumatoid arthritis. In our country, patients present late, and there is nothing like a burnt out rheumatoid arthritis. The fire continues to smolder inside. You can certainly de-escalate your treatment. Then you are goal driven, and the goal is either remission or low disease activity, 80% at the end of 3 months, which brings us to the fact that subjective impressions have given way to objective measurements, and you do a joint count. There's no science in this. Just look at the tender and the swollen joint counts. These are the 28 counts. You put it into a mathematical formula and you get a few indices, and you have smart apps and calculators available, and you get a score which helps you to decide, is your patient doing well or is your patient not doing well. So eminence, eloquence and experience are all giving way to evidence. And I'll not go into the details of the scoring systems, but then you can categorize your patients into low disease activity, moderate disease activity or high disease activity. But I think the single most important thing that has catapulted rheumatology today to the frontline specialties is the advent of targeted treatments. The biologicals, they make a difference between existing and living, and more about this later. Let me first talk about the standard workhorse of a rheumatologist. These are the drugs that we utilize to treat rheumatoid arthritis. The anti-inflammatory drugs, important for abrogation of inflammation and relief of pain. The patient is not bothered about your science. He needs relief. And in early active arthritis, before your DMARDs kick in, you need anti-inflammatory drugs. Glucocorticoids, disease-modifying drugs, targeted treatments, and this is the Hall of Fame. Practically, the treatment revolves around these four drugs, with methotrexate being the numero uno. Old is gold and gold is never old. So what has not changed is the drug. What has changed is the way we use the drug. The starting dose is 15 milligrams. You escalate to a point of disease control or drug tolerance. And if the patient is not getting better, you graduate to parenteral methotrexate. And in doses more than 15, you then split the dose. And this is extracting the best out of methotrexate. Moving from dogma to pragma, all this theory about counting your grams of methotrexate, that was more in dermatology literature, 1.5 grams. Actually, you don't need to do that. You need to monitor your liver function. Surveillance liver biopsy not recommended. Folic acid, whether you take it on the same day or other days, makes no difference. More complicated your regimens, less your adherence is going to be. So taking it 2 days before, 1 day after, put yourself in the shoes of the patient. So you ask the patient to take folic acid every day. Well, this is a point of debate. Should you use single DMARD, multiple DMARD? Actually, it doesn't matter. What matters is disease control. And unlike probity in public life, what matters is the end, not the means. And most people now say that optimally used methotrexate can help you to achieve disease control in 30 to 40% patients. Less responsive, you go on to add other drugs. Well, if anything came close to being called a panacea for rheumatoid arthritis, it was this drug, and no prizes for guessing this one. Glucocorticoids, the Pudia story, used, misused, widely abused. And these are examples of, the drugs are not bad, they are indiscriminate uses. And we in rheumatology have now taken a cue from infectious diseases, and we talk about steroid stewardship, much like antimicrobial stewardship. In the context of rheumatoid arthritis, you dichotomize your patients into early disease versus established disease. Early disease is a duration less than 6 months, where the rationale is to bridge the gap between institution of DMARDs and the onset of action, low dose, 5 to 10 milligrams, 6 to 8 weeks, and then you taper it off. With established disease, you have well demarcated indications. Pregnancy, where glucocorticoids are allowed, so also hydroxychloroquine and sulfasalazine and the anti-TNFs. Exacerbations of rheumatoid arthritis. refractory rheumatoid arthritis, in order to maintain a quality of life, extra-articular rheumatoid arthritis with ILD, vasculitis, and late-onset rheumatoid arthritis, the well-known Gloria trial, and these are some examples. This is rheumatoid vasculitis. You can see a wrist drop. You can see digital gangrene. This is the scleral melt. This is where you require glucocorticoids, pyoderma gangrenosum, rheumatoid ILD, extra-articular rheumatoid, organ-threatening rheumatoid needs glucocorticoids. And if you have a single joint which refuses to behave, these are two examples. You use intra-articular steroids rather than escalating your systemic treatment. And now I have spoken to you about the fact that rheumatoid is a clinical diagnosis. I have spoken to you about the fact that methotrexate is the anchor drug, but you're more aggressive with methotrexate. Let me talk about the targeted treatments before I finish. The advent of these treatments marked a transition from serendipity to specificity. These were designer molecules, targeted specific pathways, and for the students, the concept is not difficult. You have three things. You have a cytokine. It has to attach to a receptor which is complex to a cell. You could block the cytokine using monoclonal antibodies or receptor constructs. You could target the receptor. You could target the cell. And with the nibs, the site of action moves inside. We revel in making it complicated. The concepts are not difficult. The details are. And these are the different agents that you utilize. And these are the biologicals. The one check marked in green are available in our country. And the important thing is, one of the questions that students ask is, what do biologicals achieve? And they reduce signs and symptoms, improve physical function, but importantly, retard radiologic progression. We were taught that erosions do not heal, and with biologicals even erosions can heal. And if I have to use the analogy of coronary artery disease, you have a drug which lowers cholesterol, a drug which cuts myocardial infarction, and yet one which has a survival advantage. So akin to that you have the biologicals, and this is what people say about biologicals. Formerly, when religion was strong and science weak, men mistook magic for medicine. Now when science is strong and religion weak, men mistake medicine for magic. And for the students, we move to simplicity. These are number plates. Anybody who drives knows that this is a commercial vehicle, this is a diplomatic vehicle, this is the broad arrow system of the Indian Army, and this is the green vehicle. And similarly, the nomenclature is, if you pick up MABs, it's monoclonal antibodies, septs are receptor constructs, NIBs are JAK inhibitors. When you spot a U, it is humanized. Z is chimeric, murine plus human. Zoo is humanized. And these meaningless four words, and they actually use the word meaningless, it talks about biosimilars. JAK inhibitors, you have two available in the country. Obatacitinib will come later this month or early next month. And this is tofacitinib. Helen of Troy was the face that launched 1,000 ships. And this is the molecule which has hundreds of molecules, and in fact people think that it has replaced methotrexate, and I want to debunk that thought process by mentioning that targeted treatment should only be used when you have suboptimal response or intolerance to conventional synthetic DMARDs. Methotrexate is irreplaceable according to the current state of knowledge, and JAK inhibitors are going the way antibiotics went in our country. Are they biologicals? No, they are chemically synthesized drugs. Are they a replacement for methotrexate? No. Are they first-line drugs? The answer is an emphatic no. Can you use them without screening for latent tuberculosis? The answer is a vehement no. And can TOFA be combined with biologicals? And the answer is again an unequivocal no, unless you are doing it off-label use. How do you sequence drugs in rheumatoid arthritis? And this is an algorithm based upon the resource setting where you work. Start with methotrexate, up your methotrexate to the point of disease control. Suboptimal response, combine disease modifying drugs, methotrexate with leflunomide or hydroxychloroquine, can use sulfasalazine. Suboptimal response, time to add JAK inhibitors, can be added to methotrexate or can replace. Suboptimal relief, you can go on to biologicals with subtle nuances. Patients at risk for DVT, coronary artery disease, you may prefer to use biologicals first, earlier than JAK inhibitors. How do you handle flares, which are a fact of life? Escalations are rapid, de-escalations are slow. In impending flare, when the patient comes, you up your treatment quickly, but de-escalations are slow. And rheumatoid arthritis treatment is a continuum. Containment is rapid, maintenance is prolonged, reduction is slow, and sustenance is indefinite. And you could come down to just 2.5 milligrams of methotrexate in a week. What should you not do? Repeating rheumatoid factor at every visit, and this is something which keeps me in business, but is something should be decried. People get panels done. जी 100 टेस्ट हो रहे थे, उसने कहा ये करा लो, and एक टेस्ट is rheumatoid factor, it comes as positive, the patient is bereft of any symptoms, and then they make a beeline for the rheumatologist. Good for your practice, but bad science. In such a situation, in a patient who is bereft of symptoms, you need to observe the patient, then institute treatment, because serologic positivity may antedate clinical disease. Which way is the science headed? This is the universe of camelids. Last year was dubbed as the year of camelids, and camels are very important in the economies of many countries. And there was a serendipitous discovery of heavy chain only antibodies in the llamas, and these have been now utilized. We have ozoralizumab, which does away with the light chains, heavy chain antibody, complex to albumin. The cost goes down, the penetration is more, and this is perhaps going to be the way things will shape up. You have better designs and you have the power of computational biology. I can spot Sakir there in silico design, and he's a whiz kid in these kind of things. Then you have artificial intelligence playing a role in imaging and playing a role in histology. And where we are spoilt for choice, we have now a problem of plenty. We actually may not need more molecules, but we need archers with better skills like Krishna of Mahabharata, which is where personalized medicine is going to come in when we talk about personal protocols versus the standard protocols for everyone. And while the science of rheumatology may have changed beyond recognition, the art of rheumatology is immutably constant. Putting the patient first. The patient does not care how much you know, unless he knows how much you care. And that fundamental essence, when a patient is in pain, is what makes you a good rheumatologist. And I would like to end with these key takeaways, that the diagnosis is clinical. Serology helps you to guide but does not decide for you. You measure disease activity and titrate treatment accordingly. Be judicious with your targeted treatments. And ladies and gentlemen, we've come a long way in the treatment of rheumatoid arthritis. The past was cloaked in despondency. The present is brimming with confidence, and the future shines with optimism when we talk about the disease that is rheumatoid arthritis. Thank you very much for your kind attention.
So thank you, sir, very much. It is just like a teacher teaching. There are many doubts, and it is very lucid and highly educative. Very magnificently you described everything, and you hypnotized the audience. Now, if there are no questions, I have a question, sir, to just a clarification. You said about phenotyping of diagnosing with this counting the fingers and joint pains and swelling. Now, suppose you take a case with seropositive and seronegative. I think there is no need, as you said, of doing anti-CCP and a rheumatoid factor, because whether seropositive or seronegative, we can go with the conventional DMRDs. But in many cases, when there is seronegative cases you are treating, there is a variable response. The response is very, very poor. Now, how to address that problem?
Actually, what happens is that we need seronegative. The universe will continue to shrink as knowledge advances. Some of these are psoriatic arthritis, where the skin lesions may come up later, or may be so inconspicuous that the patient may not volunteer attention. But description of these could be sarcoidosis, could be other reasons, or could be even vasculitis. You could have Sakir speaking on small vessel, and you could have Wegener's patients presenting with RF positivity. So you need to revisit the clinical picture time and again. Even if you have time before pieces fall in place, you don't deny treatment, you treat the patient for what you see. And then seronegative is a diagnosis that is open to revision. And you keep your mind open, and years later you may change your seronegative diagnosis to something else. And sometimes it could be IBD presenting with articular symptoms, and 2 years later you get a label of Crohn's. So seronegative arthritis is a lesson in humility, that you don't get the better of nature, and it should always be open to revision by the same person again. So that's important.
Thank you, sir. Thank you so much. Anybody from the audience?
Dr. Parida is a veteran. He does an annual update, state of the art every year.
Would you kindly clear what the latest concept of remission according to ACR or Euler? Latest concept of remission.
In rheumatoid arthritis, the remission is multidimensional, and you have three concepts. You have clinical remission. आपने जोड़ को हाथ लगा के देखा, synovitis नहीं है, no swelling, no tenderness, ESRs are normal, and you have defined criteria. No tender joint, no swollen joint, acute phase reactants are normal. And then you have immunological remission, where serology should become negative, which seldom if ever happens. And then you have radiological remission, where you use the fifth pillar. So we were all grew up with inspection, palpation, percussion and auscultation. And then we added a fifth pillar, insonation. And Dr. Dave would remember Jagat Narula in cardiology. So he wrote a very famous editorial on the fifth pillar of clinical examination, insonation, ultrasound. So remission is clinical, which is what we practice, which is what Euler ACR criteria talk about. And then you have serologic remission, which so far is not possible by and large. And then you have radiological remission. And what we in India do is clinical remission. Imaging remission, if you try to achieve, sometimes the pill burden for the patient may go up. And at the end of the day, you realize that trying to, have the ultrasound Doppler not show any signals in a polysymptomatic individual is the surest recipe of making the patient change the doctor.
So thank you very much, sir, for your kind, elucid and very simple educative talk. And please make it convenient to visit Odisha as and when you need for these academic progress in our state. So with a great applause, we will convey our heartfelt thanks.
So moving on to from the Shashi Tharoor of rheumatology, Professor Rohini Handa sir, to the whiz kid of rheumatology, Shakir Ahmed, my dear friend. So Shakir is currently Associate Professor Rheumatology Clinical Immunology at AIIMS Bhubaneswar and is Editor-in-Chief of Immunological Research and is a co-convener of APLAR's Special Interest Group for Digital Health and Telemedicine, and so also the convener of IRA SAME SIG for Digital Health. And he has 100 plus indexed publications, reviewer for more than 50 journals, and editorial board of more than 10 journals. So actually I know his hobby is publishing and looking after publishers. Thank you, Shakir.
Thank you. First, I would like to thank the organizers for giving me this opportunity. And it's always a challenge after hearing a great orator like Handa sir to be the next speaker. To be able to maintain that is not possible for me. So please bear with me. For this talk, our SR Dr. Avarna helped me with pictures and a few slides. When we talk of rheumatology, I always start with this quote. This madam was a great writer of the 19th century German writer, and she said that we don't believe in rheumatology until we experience it firsthand. Same for, and especially for vasculitis. Unless you are looking for vasculitis, you will think this is sepsis, this is something else. So until and unless you look for it and you find it, then only you'll know that this is actually what vasculitis is. So I'll tell about, I'll just show 8-9 cases just to give you an idea what is vasculitis, what do we mean by small vessel, and little about mimics. The ACR definition, that is the American College of Rheumatology, they say there has to be inflammation and damage of blood vessels. Inflammation means there will be immune infiltrates in the vessel, and damage, that intimal layer will be broken, which obviously there will be ischemia and organ or tissue damage. So let us consider this boy, 16-year-old, who presented with abdominal pain and diarrhea. 3 days, there was a bounding pulse, and gradually he went into shock. Fluid challenge did not work. He had to be started on NORAD. Respiratory rate was high. He had bilateral crepitations. Hemoglobin was low. Total count was low. Platelet was also going low. So what this is telling us is that this is unlikely to be vasculitis. What? Because the counts are all low. In vasculitis situation, we expect the TLC to be high, the platelet to be high. In a sepsis scenario, it can be either way. It can go high, it can go low. Often we see this, we think this is vasculitis, but in such a scenario, most common is always the infection. And whenever we see palpable purpura like the last picture, definitely it is vasculitis, but it is not a primary vasculitis. It is a vasculitis maybe because some drug issue, drug related, or the infection. And sometimes they may even cause blistering and ulcerate also. And another thing the residents should remember, palpable purpura is equal to vasculitis. Non-palpable purpura, though classically we think of it as thrombocytopenia, even vasculitis may present with non-palpable, especially if it is long-standing, they have taken some steroid or some other medication. So patient comes late, we may see as non-palpable purpura also. Consider the same scenario, maybe a slightly younger boy who had some respiratory tract illness and coming with similar picture, but here the vitals are stable. There is no sign of any sepsis. Then what will be the most common diagnosis, most likely diagnosis? This can be a Henoch-Sconlian purpura. Henoch was a teacher, Sconlian was his student, and together they have described it. Nowadays it is called IgA vasculitis. And here, as we can see, this is a vessel. The vessel is thickened and there is RBCs inside it, and all around. This is a skin biopsy. We can see the retipegs here. In the skin biopsy there is infiltrate, and even the vessel is affected. And when we do a immunofluorescence, we try to stain for various antibodies. Out of antibodies C3, C4, IgA will come positive. That is why nowadays it is called IgA vasculitis. This is another picture, classical picture I am showing you of vasculitis. What we see here is that upper part of the picture we can see the vessel wall, the intima media adventitia, we can see it clearly. Though there is infiltrate of various immune cells, but here if we see this area, we can see it is more heterogeneous. Here this is very well defined, this is much more heterogeneous. So this means some kind of necrosis have come here, and since it is all pink, this is a form of hyaline necrosis. Another example, higher magnification, here we can see lower part, it is more well defined, but here this area is looking very vague. We cannot make out the cell boundaries. So this is a classical picture of showing fibrinoid necrosis, one of the gold standards for any vasculitis. So the most common primary vasculitis, after we have ruled out infection, drugs and all, is IgA vasculitis. It is mostly benign and self-limiting. The most difficult part is you have to explain to the parents that you do not need to treat this. Sometimes when they are very vehement, we give a little bit of steroid, maybe 10 milligram, 12 milligram of prednisolone. That is sufficient for it to go away. But even if you don't do that, this blisters, the palpable purpura is not going to harm the child. Only indication of treatment is if the creatinine starts to rise, or if there is something called abdominal angina, which indicates a abdominal vasculitis. So what do we mean by small vessel vasculitis? Any idea what is a large vessel, what is a medium vessel? All the branches of aorta, until they enter an organ, is a large vessel. So the radial artery, the ulnar artery, till here this is a large vessel. And we know pulseless disease is classically Takayasu. In Takayasu we will not get pulse in the radial artery or the ulnar artery. So these are all large vessels. Obviously in the hand we don't have an organ, but once this radial artery and the ulnar artery, they form the palmar arc, that is when they become medium vessels. So until they enter an organ, here the organ you can think of as the hand, they are large vessel, and once they enter into the organ, suppose into the kidney, the renal artery enters and it will branch into the arcuate arteries. The arcuate arteries, these are the medium vessels. And when they become very small and they enter into the tissues, they lose their adventitious layer, then we call them as small vessels. Small vessels are mostly three types: the arterioles, the capillaries and the postcapillary venules. This lady we can see, she had a very tender swollen vessel on her forehead. This is actually one of the anterior branches of the superficial temporal artery. And we have ultrasound, sir was saying in his talk that nowadays in rheumatology ultrasound is becoming a very important investigation. We have what is called a hockey stick probe we can see, and we can find something what is called a classical halo sign. You can see there is halo sign basically means there is thickening of the wall and the blood flowing is within this, and there is a halo around the flow of blood. This is a very classical sign, but it is very often misdiagnosed unless you know how to set the PRP setting, but that again is a different story. This is a very though in India we do not expect to see much of GCA, but it is not it may be rare, but we are still finding a few cases here. Then medium vessel, as I have said, medium vessels are once the branches have divided into arcuate arteries supplying the fingers like digital arteries, so they will cause digital infarction, or they will cause skin infarction, usually bigger size, and in the kidneys you can see the arcuate arteries, they will develop classically microaneurysms. So if these things are there, the most common diagnosis is polyarteritis nodosa. Other medium vessel vasculitis is the Kawasaki disease, which is found only in infants. So in middle-aged person, males, most common cause, primary cause is pain. But more common than that, it will be sepsis related, infective endocarditis. So these are the things we need to rule out. Multiple people have said during the inauguration, the mother of all subspecialties is medicine. So unless your medicine is very strong, you will falter in rheumatology. So another case, she was a woman with hypothyroidism. She had an acute hand drop involving the right wrist. Clinically, there was nothing, no skin rash, no fever. When we did the NCV, there was severe axonal sensory and motor neuropathy with asymmetrical. 3, 4, 5 nerves were involved, but it was manifesting only, motor manifestation was in the right wrist with hand drop. dsDNA was high, complement was low, and the ENA showed Smith and nucleosome, which are very specific for SLE. Though no clinical feature is there, but serologically she is SLE. This was the patient initially when she came to us. You see, she cannot extend her arm at all. We went ahead and we gave her 7, it should be 7 doses of cyclophosphamide as per the NIH protocol. And at the end of 6 months, we can see there was complete resolution. Avarna sitting there, she was doubtful about the improvement, but that is why I told her to keep a video at the beginning, and at the end we can see that there is complete resolution. So it is not that all patients with lupus develop vasculitis. Only 1% of lupus patients will have systemic vasculitis, though many of them will have a skin vasculitic rash. Around 10% have skin vasculitic rash, but only 1% has lupus vasculitis. What are the features? The platelets will be high, the TLC will be high. Usually in lupus we expect cytopenias, but when we see the opposite, CRP is high, platelets, TLC is high, then we have to think lupus vasculitis. And rarely, as we have seen in this case, we may get lupus vasculitis without the classical features of lupus. Then why do we get mononeuritis multiplex in small vessel vasculitis? If we remember our microanatomy, the blood vessels are supplied, the nerves are supplied by very small blood vessels, which are called vasa venorum. And these vasa venorum are affected, and there are skip lesions. One of the classical features of primary vasculitis is skip lesions. That is why one nerve will be affected here, 2 nerves will be spared, again on the feet another nerve will be affected. So you get different nerves being affected as mononeuritis, which we call mononeuritis multiplex, means multiple mononeuritis. Then again in the kidney, we see it as glomerulonephritis because the glomerulus is basically a tuft of capillaries, and when the capillaries are affected, that is also a form of vasculitis. Again, the capillaries in the lung may be affected and they may rupture, causing bleeding into the lung, which is called a diffuse alveolar hemorrhage. So these are the conditions which may be life-threatening, and we have to be very careful. Sometimes we can get saddle nose here. You can see there is a drop in the nasal bridge. That is also a feature of small vessel vasculitis, though there are other differential diagnoses. Handa sir already has shown a picture of episcleritis, and sometimes this may even lead to globe perforation if the scleritis becomes worse. So another case, this was a lady of around 26 years. She came to us 2 years ago with epistaxis, and she had nasal discharge as well as ear discharge. And when we looked into the ears, the ENT people said there were tympanic membrane perforation. And what we can see here, I'm not sure how clear it is, there is congestion in the gums. This is a classical picture of what is called a strawberry gingiva. She had a nasal peg because of the epistaxis, and we can clearly see that there is a left-sided palsy. So ENT infection is one, but since it is so extensive, both the ears are affected, epistaxis is there, and we can see there is leg ophthalmos. So definitely left-sided facial nerve palsy. And when we looked at the investigations, TLC is high, platelet count you see. This is a very important marker of vasculitis. If the platelet count is so high, then no direct evidence of renal involvement, ESR, CRP were high. then obviously first thing we are thinking of was it infection, fungal infection. A CT was done by the ENT people. They have seen that the sinuses are full, maxillary sinuses are full, sphenoid sinuses are full. So definitely pansinusitis is there. All the sinuses, these are the ethmoidal sinuses. Ethmoidal sinuses are full. Sphenoid sinus is full. So she did not have any cough, but we went for a chest X-ray. In chest X-ray we can see a classical consolidation with a cavity. Then we went ahead with a CT scan, and you can see how extensive this is. So this is a classical case of one antibody is positive, that is called PR3. PR3 is the most common antigen which leads to C-ANCA positivity. What is C-ANCA? ANCA is anti-neutrophilic cytoplasmic antigen. So what we are seeing, the nucleus is not stained. The nucleus appears black. Only the cytoplasm is affected. And this is only the cytoplasm, so this is called C-ANCA. This is called a P-ANCA or perinuclear. So the staining is only perinuclear and the whole cytoplasm is not stained. So this is P-ANCA, and her P-ANCA was, her C-ANCA was positive, which is PR3. Even a nasal mucosal biopsy was done to rule out fungus and all. I'll not go into details, but it was reported as vasculitis with granuloma. So definitely this is a classical case of ANCA-associated vasculitis. The name, original name was granulomatosis, one person's name and granulomatosis. But we are not supposed to use that name. There is a lot of confusion. Some calls it granulomatosis, some calls it granulomatosis with polyangiitis, some call it ANCA vasculitis, and a recent suggested name is even PR3 vasculitis. But whatever name you use, these are some of the names we should not use. These people were Nazis, though some of our textbooks still use these names. Gradually, if you see modern textbooks, they have omitted these names. They are all Nazis who have been convicted by the Nuremberg trial that was held in Germany after the end of Second World War. So ideally, these are the names. Like for reactive arthritis, there is a eponym that should not be used. But what this tells us is that vasculitis, small vessel vasculitis, comes as a bolt from the blue. And it can affect anything and everything from the eye, the ENT, the digestive system, abdominal angina. They can present with diarrhea. You think this is a patient having GI infection and coming with dysentery. But that may be actually a GI vasculitis. Skin, obviously, we are attuned to. But a patient coming with that kind of lung, first thing obviously that will come to our mind is tuberculosis. But if they have like classical ENT features, eye features, then we have to think, is this actually tuberculosis or something else? Most of you know Tony Fauci. The actual name is Antonio Fauci, but friends call him Tony. His name is there, always the second author of Harrison's textbook. What did he do? He first realized that ANCA vasculitis is something which is possibly more dangerous than a malignancy. And so he took a drug which was used for malignancy, which is basically cyclophosphamide, and he started to give these people. That is how Fauci became famous. Ultimately, he entered the NIH, and now he has been advising almost the last 6-7 US presidents. In Second World War itself, nitrogen mustard was used as a type of chemical warfare, and soldiers had to use gas mask and all that to be safe from it. From nitrogen mustard we got cyclophosphamide, which is maybe the only good thing which has come out of it, and this is still the primary drug to be used for small vessel vasculitis. Alternative, we have rituximab, but remember, in rituximab failure, cyclophosphamide will work, and vice versa. It is not that if rituximab doesn't work, cyclo will not work. If cyclo fails, then rituximab may work. If rituximab works, cyclo may work. But we have to be sure of the actual dose. Another case, 12 years of rheumatoid arthritis, classical deformities. She presented with gangrene of these fingers. classically these people have multiple comorbidities. They will have hypertension, they will have diabetes, and we don't, sometimes it is difficult that is this because of the diabetes, is it because of the rheumatoid vasculitis. But if upper limb is involved and the diabetes is controlled and all, this is much more likely to be rheumatoid vasculitis. Here we can see there is a nodule in the eye as well as the sclera is looking blue. Why is the sclera looking blue? It has thinned out, which is called scleromalacia. And if we do not treat this, the eye will rupture and vision will be lost forever. So, there is a Scott and Bacon criteria. Basically, Paul Bacon was there in Birmingham. He saw the work done by Antonio Fauci in US, and he took up the same concept in the UK, and he tried to see that instead of giving daily oral cyclophosphamide, can we give like a pulse cyclophosphamide. He started the concept mostly in rheumatoid arthritis. He also, rheumatoid vasculitis, he also defined the criteria for rheumatoid vasculitis, and that is how we started having pulse cyclophosphamide. And he was also a visiting professor at SGPGI. During our first year, I had the good fortune of attending rounds with him. Unfortunately, he is no more. So, what is seen nowadays is pulse cyclophosphamide is much safer than oral, and each vasculitis has a specific protocol. It is not like we'll give a urolupus protocol to each and everyone. For ANCA-associated vasculitis, it has to be the UVAS protocol. For lupus vasculitis, it has to be the NIH protocol. Rheumatoid vasculitis, there is a Scott and Bacon protocol. For elderly with vasculitis like PEN, there is something called a cottage protocol. So we need to know how to use cyclophosphamide correctly. Otherwise, what I have seen is people give inadequate doses of cyclophosphamide and call it cyclophosphamide failure. 8th case. Again, this is a 46-year-old male. I'll not waste too much time. You can see there is a skin ulcer, possibly a medium vessel vasculitis, a tongue ulcer, and eyes are affected. And these were the counts. Platelet was normal, hemoglobin was low, and ultrasound showed left epidermoorchitis. Epidermoorchitis is a classical feature of PEN, polyarthritis nodosa, which is a medium vessel vasculitis. So we can see one manifestation of medial vessel vasculitis here and one manifestation of medial vessel vasculitis here. So we should remember that the classification system is not a watertight compartment. Small vessels may affect medium vessels also. There are reports of ANCA vasculitis affecting aorta, causing aortitis. So it is not that small vessels will limit itself to small vessels. If we look at the classification system, we can see there is overlap. ANCA can go from here to here and rarely even to large vessel. And never forget to look at the urine. Urine will give you much clues about glomerular nephritis. I'm not sure how much time I have, but just we all read about mesangial proliferation. What is mesangial proliferation? If you see a normal glomerulus, it is like this, nice and clean. But you can see this is very congested. Normally, there should be 4 mesangial cells in a tuft. These are just 4 cells should be there together. But if we see here, here maximum 4 cells will be together, but here we can see many cells are there together. So this is called a mesangial proliferation. Similarly, again compared to the normal, we can see the capillary loops. The capillary loops are inside nice and clean, but here we can rarely see the capillary loops. Normally one capillary loop should be lined by single cell, and if the capillary loops have multiple cells inside, that is called endocapillary proliferation. And this, you all would be aware, this is called a crescent, where the normal Bowman space is occupied by something else. If it is filled by cells, it is called a cellular crescent, which means active vasculitis is going on. And if it is filled with fibrin, it is a fibrous crescent, means it is already damaged. Last case from my side, this is a 40-year-old male who presented with erythematous tender rash. There was right foot drop, though we don't have a video here. Low-grade fever was there, and even little finger, some weakness, and multiple cutaneous infarcts we can see here. So he had hypergammaglobulinemia, ESR, CRP were high, nerve conduction confirmed our diagnosis of mononeuritis multiplex. But this was not ANCA vasculitis. This was small vessel vasculitis because of HIV. HIV came positive. So always rule out these things first. What are the differential diagnoses? In our scenario, most common possibly are bacterial endocarditis, tuberculosis and HIV. They can mimic all vasculitic manifestation. Tuberculosis we know causes end arteritis, so that is also a form of vasculitis. Then others, drugs very commonly, and the vasculopathies like APLA, APS syndrome or any other clotting disorder. I don't think I have time to discuss these things. We have talked of mostly the post-immune. There are vasculitis with immune deposits like cryoglobulinemia, arterial vasculitis, and we have also not discussed variable vessel vasculitis, though we see a good number of bed sets. We do not have time to discuss the criteria, and nowadays there are so many criteria. Unless you are subspecializing in rheumatology, it may not make sense to go into so much of depth. So coming back to the summary, I was supposed to talk on the approach. First thing we have to remember is small vessel vasculitis. It comes as a lightning bolt. So we have to be very careful. We have to suspect it early. Very often where we suspect vasculitis, it turns out to be something else. Where we don't suspect, it turns out to be vasculitis. When you are sure that the vessels are involved, differentiate whether this is a vasculopathy, is it a thrombotic manifestation, or is it something active vasculopathy. Then look at the anatomical diagnosis. Is it a large vessel where you get absent pulses? Is it a medium vessel where classical findings are like hypertension or skin infarct? Or whether it is small vessels where you get like the scleritis, the ENT manifestations, the hemorrhage in the lung, or other manifestations. Then remember, the most common cause of small vessel vasculitis is drugs and infection. Those must be ruled out. ANCA may be positive even in sepsis, even in the case of tuberculosis, ANCA may come positive. So just because the ANCA is positive, that doesn't mean that this is ANCA vasculitis. Once you are sure that this is a primary vasculitis, make sure this is a immune deposit disease or a post-immune. Post-immune, that means there are no immune complexes. Then only we make a diagnosis of post-immune or possibly ANCA vasculitis. Remember, around 15 to 20% of ANCA vasculitis is ANCA negative. ANCA vasculitis we have like PR3 vasculitis, we have MPO vasculitis, we have renal limited vasculitis, we have undifferentiated vasculitis, and we have ANCA negative ANCA vasculitis. Like we have seronegative rheumatoid arthritis, we have seronegative APS, we also have ANCA negative ANCA vasculitis. So absence of ANCA will not rule out ANCA vasculitis. And as Handa sir told in his talk, that we are moving away from steroids, especially in the scenario of small vessel vasculitis. The dictum now is no steroids beyond 18 months. We have to taper down to the minimum amount of steroids by 6 months, and all steroids should stop by 18 months maximum. And there are drugs coming up like Avacopan, which completely eliminate the use of steroids. Till now Avacopan is not available in India, but this is going to the future, because most of the deaths in ANCA vasculitis is not because of the vasculitis nowadays, it is because of the infection, and most of that infection is related to the steroid. That is why the world is trying to move away from steroids, have a steroid-free induction and maintenance. Thank you.
So thank you, Dr. Sakir, for your lucid talk. I think because of the paucity of time, we have to move to the next speaker and we'll take the questions once at a time. So the next talk is on lupus. I think rheumatoid arthritis is the prototype of inflammatory arthritis. Lupus is the prototype of systemic autoimmune diseases. And to talk on this, I will invite Professor Dr. Pradipta Sekhar Patra. All of us know him. He is a very energetic speaker, and he is a professor and head of the department of DM, Department of Immunology and Rheumatology at AIIMS and SOM Hospital. And he has around 23 national and international publications in index journals. And Dr. Pradipta to talk on lupus and how to approach the treatment.
Thank you, Dr. Jyoti, for the introduction, and also I will thank Dr. Dev for giving me the opportunity to come to this institute. So, though I am staying in front of this AIIMS Bhubaneswar, but I never come. My wife is working here at AIIMS Nuclear Medicine, so I regularly come, but I never come to this auditorium. So, first, after the rheumatoid arthritis and vasculitis, my talk is on recent advance in management of lupus. So, when to suspect a lupus? If the young female with inflammatory arthritis seronegative, pedal edema due to the proteinuria, serositis like pleural effusion or pericardial effusion, or young female with malar rash, photosynthetic rash, or any young patient with young stroke, unexplained fever for prolonged duration with leukopenia or thrombocytopenia, and any young female with AIHA or thrombocytopenia, you need to do ANA. That should be by the HEP2 or indirect immunofluorescence, not by the ELISA. So after diagnosing what is the bread and butter of the lupus, what treatment you should give is the hydroxychloroquine. So what dose you should give? The dose is 5 mg per kg body weight. If you increase the dose, there is some retinal toxicity. So what that 5 mg dose comes from? So this is the 5 mg dose. They have seen if you lower down the dose less than 5 mg per kg, then there is more of flares, and if you increase the dose also more than 5, there is no extra benefit. So from this trial they came to the conclusion of to give the 5 mg per kg, so to give the every lupus patient until unless there is no contraindication. Now coming to the steroid. Before going to the steroid, just I will tell what is the genomic action, what is non-genomic action. You want non-genomic action because it is the immunosuppressive effect. In non-genomic, non-genomic is mostly by the pulse steroid, methylprednisolone pulse steroid. It acts quickly within the minutes. Whereas genomic action, either trans-repression or trans-activation. Majority of the immunosuppression action comes from your trans-repression activity, not by the trans-activation. Trans-activation leads to the more of side effect. So you can see this y-axis. If you increase the dose more than 100, the non-genomic action starts. Even if you go more than 500, the non-genomic action will already be saturated. So there is no point in giving more than 500 mg of pulse in a patient of lupus. It is all equal, either you give 250 or 500 mg. Now oral tablet. Prednisolone you can see once 50 mg, more than 50 mg, already there is saturation of your genomic action. If you give 80 mg of oral steroid, there is no need to give 80 mg. It is already given the 50 mg which saturates your cytosolic glucocorticoid receptors. So there is no point in giving more than 50 mg of steroid in a patient of lupus. So why I am coming this? Because nowadays there are coming a lower dose of steroid in a case of autoimmune diseases. Not that 1 mg per kg body weight to every patient or pulse of 15 mg per kg body weight to every lupus patient. So what is the steroid? So prednisolone dose above the 50 mg per day approach the ceiling of cytosolic glucocorticoid receptor saturation with limited additional anti-inflammatory benefit, and it increases the more of side effects. Now, non-genomic action, it is mostly due to your pulse therapy, which does not carry any side effect. Because that is short technique. You are giving pulse steroid, then you are coming down lower down the steroid. That is 40 mg of steroid. So, non-genomic action, it doesn't carry any prolonged side effect. Only this genomic action which carries the prolonged side effect. So, now time you give pulse therapy, now you come down the lower down steroid, that is 40 mg of steroid. What is the adverse effect of the prednisolone when you increase? You can see there is hazard ratio. When you give more than 5 mg, the hazard ratio is increasing exponentially. And cardiovascular effects more than 10 mg of steroid. Then yours, again, the 1 mg of prednisolone increases the 3% of increase of risk of damage. So every milligram of prednisolone, oral prednisolone, carries the adverse effect. Now osteonecrosis, more than 20 mg of steroid, it causes osteonecrosis. So that is why this 2023 EULAR recommendation, they are coming a maintenance dose of less than 5 mg, not 7.5 mg, which was there in the 2019 recommendation. Because of this side effect, because of this adverse effect, 2023 recommendation is telling you maintain the dose of less than 5 mg, or you can stop later on. Now coming to the lupus nephritis. So lupus nephritis, there is a recent guideline comes, that is 2024 ACR nephritis, whereas ULAR it is 2023. What is the 2024 recommendation says? When you should do the biopsy, if there is more than 500 milligram of proteinuria, even in the absence of the active sediment. Initially, it was suggested that 500 milligram proteinuria with active sediment go for the biopsy. Now they are telling if more than 500 milligram, even in the absence of active sediment, you can go for the biopsy. And biopsy is must do to avoid the mimickers like infection or NSAID-induced nephropathy or IgA nephropathy. These are the mimickers we should, that is why biopsy is mandatory, and before biopsy you can start the pulse steroid therapy. Prompt kidney biopsy for the diagnosis and classification, and prompt treatment of the glucocorticoid, and you should not wait for the biopsy report to come and start the treatment. Now what is the dose of steroid you should give? As I mentioned, 250 to 1000 milligram, but preferably 250 to 500 milligram for 3 days, followed by oral prednisolone, that is 0.5 milligram per kg. It is not that 0.75 milligram per kg. You can start with the 40 milligram per day, because your genomic action starts saturation after the 50 milligram of steroid. That is, after pulse, you come down to the 0.5 milligram of steroid, that is maximum up to the 40 milligram, and taper the steroid dose to the less than 5 milligram per day, not the 7.5 milligram. It is the 5 milligram per day. Now what if you give, why there is after the pulse, why you should give the 40 milligram, not the 50 milligram? Now it has been seen that more than 40 milligram there is more of infection. This is a good meta-analysis. They have seen that this 40 milligram of steroid, if you give more of 40 milligram, then it causes more of serious infection and adverse effects. Now, what you will treat after the biopsy plus class 3 plus 4 plus or minus class 5. Now, it is a triple therapy, not the dual therapy. Triple therapy means glucocorticoid plus mycophenolate plus belimumab or CNIs. CNIs which is available in India is tacrolimus, not the voclosporin. So now the ACR is telling voclosporin with MMF you prefer if there is proteinuria of more than 3 gram per day. MMF plus belimumab you will prefer if there is proteinuria less than 3 gram per day. If this triple therapy is not available, you can go with the steroid with MMF or steroid with your cyclophosphamide, that is ELNT, not the NIH protocol. NIH protocol they have not mentioned in this ACR guidelines. So either you go with the triple therapy is better than the cyclo dose, that is in the NIH also. Triple therapy they have mentioned about the mycophenolate acid plus CNIs, that is tacrolimus or voclosporin. Alternative is your cyclosporin plus belimumab. If there is proteinuria less than 3 gram, then you can prefer belimumab over your cyclosporin. Now why this triple therapy comes into the picture? Initially we were trained with the dual therapy, because now they are thinking when you delayed the most efficient therapy, it causes more of nephron loss. So you hit it first, then you can taper down the steroid as early as possible. So even there is no lupus nephritis, no nephritis, there is gradual podocyte or nephron loss with the aging. If you not treat properly, then there is early patient is high risk to go to the CKD. That is why they are coming into the triple therapy is preferred over your dual therapy. Now triple therapy as an induction. What is the points for, what is the points against? As I mentioned, lupus nephritis default is severe disease, and it increases the morbidity and mortality and more chances going to the CKD if you will not treat it aggressively. Second, even the recent trial like BLISS, lupus nephritis or Aurora, they have seen in a placebo there are only 20 to 30% are responding to the dual therapy, whereas rest are failure. And both belimumab and voclosporin based on the RCT they have been approved for all patients of lupus nephritis. What is the points against? Because of the high cost and risk of considering particularly long-term use of CNIs, like it can lower down your GFRs. Now coming to the whether in India it is voclosporin is not available, whether MMF with tacrolimus versus cyclophosphamide high dose, which one you will prefer and why? This is a meta-analysis which studied eight randomized trial. They have included around 700 patients. Here they have seen this MDT like mycophenolate mofetil plus tacrolimus is preferred over your NIH in achieving complete remission. Now, when you will give high dose cyclophosphamide, these are the indication you should consider the NIH high dose in patient of high risk of kidney failure. On presentation, reduce GFR because you cannot use CNIs in those cases. Histological presence of crescents, interstitial inflammation, fibrin node necrosis, and patient of already, because this bliss lupus nephritis or aurora, they have excluded the severe patient. That is why you cannot extrapolate the data of severe lupus nephritis on those studies. And that is why you, when the GFR is less than 30, you should consider the NIH protocol, not the ELNT. Now, what is the evidence of data? Bliss lupus nephritis, they have studied belimumab versus placebo and dual therapy along with the standard of care of either mycophenolate mofetil or cyclophosphamide. Here they have seen 43% of response to the belimumab in comparison to 32%. So belimumab is preferred over the placebo in these studies. Then aurora, again it is oral voclosporin. Here it was 41% versus 23% in the placebo. So what is the comparison? Here you can see this bliss lupus nephritis, they have included dual therapy like mycophenolate plus cyclophosphamide, whereas your aurora one, they have not included any cyclophosphamide arm. So both the groups, they preferred like belimumab or your voclosporin is preferred. You can add on as an induction therapy. Now, resolution of proteinuria, you can see comparison with the aurora one versus your belimumab. This voclosporin, they reduce the proteinuria as fast in comparison to your belimumab. This is a subgroup analysis of belimumab. Here you can see when there is low proteinuria, the belimumab is preferred. When there is high proteinuria, belimumab should not be given. In those cases, you should prefer the voclosporin. And aurora, because CNIs are, you can think of that it can reduce your GFRs, and UPCR, it can persist over 3 years. You can see the proteinuria maintaining and EGFR also maintaining. It is not that any long-term side effect due to your voclosporin. Now, what points favors the belimumab? What points favor the voclosporin? If the EGFR less than 45, you can choose the belimumab over the voclosporin. If the EGFR is more than 45, you should choose the voclosporin or tacrolimus. Low level of proteinuria, again, you should choose the belimumab over the voclosporin. High level of proteinuria, because CNIs, they stabilize the podocytes. That is why whenever there is high level of proteinuria more than 3 gram, you can choose the voclosporin. And what is the voclosporin? Voclosporin, you can see this binds with the cyclophilin A and also competitively inhibits your calcineurin, and it has 2 roles. First is it inhibits the dephosphorylation of NF receptors and synaptopodin. So that is why here it stabilizes the podocyte, and here this decreases the production of the T cell mediated response. That is why it has 2 functions. One is T cell mediated response, and it stabilizes the podocyte. That is why it has very dramatic response to the proteinuria. Now coming to the class 5, pure class 5 proteinuria. Initially we thought whenever there is nephrotic range proteinuria, you should treat with the immunosuppressant. Now they are telling if there is more than 1 gram of proteinuria, you should come with your immunosuppressant. Okay. Again, here the mycophenolate plus your calcineurin inhibitor is preferred over your cyclophosphamide, and if there is proteinuria more than 3 gram, you should give your calcineurin inhibitor, not the belimumab. And how long the maintenance therapy you should plan in a lupus nephritis? This ACR, they are telling it is at least 3 to 5 years. Whereas in ULR, they are telling at least 3 years, and KidGo, they mentioned about more than 3 years. That means this immunosuppressant, you should continue at least 5 years. Because of the recent recommendation of ACR, they are telling at least 3 to 5 years, you should continue your immunosuppression therapy even after achieving the complete remission. This is a 2023 guideline. What extra point you should remember? You must add ACE inhibitor. Consider your dapagliflozin now, because dapagliflozin again a renal protective. It is having anti-proteinuria effect like in diabetes kidney disease or in CKD. Now this dapagliflozin, if the standard of care is failure, you can add on with SGLT2 analog. And if there is associated thrombotic microangiopathy, you should consider adding the anticoagulant. And what is your target? At 3 months, there should be 25% reduction proteinuria. At 6 months, more than 50% reduction. At 1 to 2 years, the proteinuria should be 500 to 700 milligram per day. And if there is altered GFR, GFR should come down with 10% of baseline. This is the standard care of therapy now. So SGLT2 inhibitor may be considered in a patient of lupus nephritis with reduced GFR below 60 to 90 with proteinuria of 500 to 1 gram on top of SC inhibitor during the maintenance phase, and it is not causing any hypoglycemia. Now coming to the CAR T cell therapy. When you should see the CAR T cell therapy, this CAR T cell, this is a like autologous implantation. So you remove the blood sample and isolate the T cells. Then you insert these antibody binding cells to these T cells. That is, then it can multiply and amplification of CAR T cell in vitro. Then you can again insert to the patients. So what it causes, it mainly attack the CD19 B cells. That is a pathogenic B cells they will attack. What is the data? This refractory lupus nephritis, which is not responding to any of the therapy, they have seen that it reduces the proteinuria, it completely normalizes your anti-DHA level and C3, C4 level. And another paper also, anti-CD19 CAR therapy for refractory systemic lupus. And here they have seen 5 patients. They have given also rituximab failure. They have tried with your CAR T cell therapy, and you can see all the 5 patients were in the remission phase. Now other targeted therapies are like either obinutuzumab, belimumab, already we have discussed, telicicept, anifrolumab, it is anti-interferon receptor, upadacitinib, and deucravacitinib is small molecules. That is, it inhibits both T cell and B cells. Another your target is your plasma cell, that is your telicicept. These are all phase 2 clinical studies, though that is why I am not going into the detail. Upadacitinib and deucravacitinib, mainly deucravacitinib is response to the skin part of your lupus management. Now the cutaneous lupus. Though SCQS is a standard care of therapy, along with you can add methotrexate or mycophenolate or dapsone. Sometimes chronic DLE-like lesion you can prefer thalidomide also. Other biological therapies like belimumab also preferred along with your standard of care of therapy. Apart from that, methotrexate, anifrolumab, also TULIP-1 and TULIP-2 study that we will discuss. And skin involvement, you can see this, belimumab helps in lowering down of steroid in a case of refractory cutaneous lupus. And classy response, this is TULIP-1 and TULIP-2, that is for anifrolumab, it can lower down the steroid requirement. This is sustained glucocorticoid dosage reduction in both in TULIP-1 and TULIP-2, they have seen like it drastically required the dose of steroid in a case of cutaneous lupus. Now neuropsychiatric lupus. First, before diagnosing the neuropsychiatric lupus, you should identify what are the other causes like infection or medication, hypertension or renal failure, TTP-like manifestation or depression or any stroke, that you should exclude. And other CNS manifestation, either it can be focal or diffuse, because focal you should treat with the anticoagulant, diffuse you should treat with your immunosuppressant. This is again the symptomatic therapy. Specific therapies like either focal you should go for the antiplatelet, or diffuse you should go for the inflammatory therapy and address other issues like infection, hypertension or metabolic abnormality. Now the hematological management. Mostly autoimmune hemolytic anemia, either it is AIHA or microangiopathy hemolytic anemia. AIHA, when you will suspect, if there is low hemoglobin, rapid decline of the hemoglobin along with raised LDH and indirect bilirubin and increased retic count, then you can suspect your hemolytic anemia. If it is DCT positive, it is autoimmune hemolytic anemia. If it is like DCT negative but cystocytes are there, then you can call it as a microangiopathic hemolytic anemia. So first you have to diagnose whether it is a hemolytic or it is autoimmune, or what antibody, whether it is a cold or warm antibodies. So hemolytic, what are the features of hemolytic? Like increased retic count, increased LDH, increased indirect bilirubin. If DCT is positive, you can call it autoimmune. If there is IgG is positive, it is warm immune mediated autoimmune hemolytic anemia. Now what is the treatment? Steroid dose. If it is failure, if you are not able to come down the lower down of steroid like 15 mg, or it require high dose of steroid, then you should start the second line therapy such as either azathioprine, mycophenolate or rituximab. Sometimes you can go for the splenectomy. Now the thrombocytopenia. Thrombocytopenia either due to the peripheral destruction, which is the most common. Second part is reduced production from the bone marrow. So peripheral destruction either due to the ITP or antiphospholipid or TTP, where reduced production either antibody against the stem cell or drugs or a megakaryocytic thrombocytopenia. Most commonly we got the ITP. So when you should treat, if there is platelet count 20 to 30,000, you should use the steroid dose therapy, and maintenance therapy also is indicated because they are more of relapse. Rituximab, azathioprine, mycophenolate, cyclosporine, any of the agent you can try. If there is refractory, you can go for your IVIG also. This is a treatment of non-renal. This is 2023 EULAR recommendation. Most common is you should focus the patient on sun protection, no smokings, balanced diet, and if the patient of like antiphospholipid, you should give the consider of the anticoagulant. Oral anticoagulant like your apixaban or rivaroxaban should not be given if the patient of arterial stroke or triple positive. You should not give oral anticoagulants such as apixaban or rivaroxaban. In those cases, warfarin is the choice. Then what is your target? Your maintenance glucocorticoid should be less than 5 milligram, and you should achieve either remission or low disease activity. So even if it is 100 patients, it can be managed. Thank you.
So on behalf of our three chairpersons, we convey our heartfelt thanks to all the three speakers. They have very done extensively, very well. It was a very extensive talk also. But the organizing committee pressing hard, there is a constraint of time. So there will be only one question for each speaker.
I have got a comment and question for Dr. Sakir. In fact, we worked together for last 5 to 10 years. And I don't know why he was introduced as the Shashi Tharoor, I realized today. Anyway, that is what are the comments. Second thing, he did a very nice thing in bringing all those scientists' names, teaching the youngsters how these people have worked so hard. But one question to you, this typical removing the names being Nazi or something, but I was reading a neurology book, lot of diseases are named after neurology. Plenty. But why this Wagner's or Ritters? Is it a correct thing?
Yes, sir. If you look at even recent textbooks like Harrison and all, these names will no longer be mentioned. From our...
but why?
Because they are they did war crimes. They killed millions, not millions, but hundreds of people. They did experiments like...
official.
Yes, sir.
One thing, Dr. Sakir, you have explained very nicely case by case, but you have not touched upon CNS vasculitis, which you encounter. Can you just detect and how to prevent CNS vasculitis?
Primary CNS vasculitis is a different cup of tea. That is more of an autoimmune disease, and a lot of new antibodies are being described for it. But the only way to diagnose a primary CNS vasculitis is by doing a brain biopsy.
Brain biopsy?
Brain biopsy. Unfortunately, most of centers are not doing a brain biopsy. So possibly that is being underdiagnosed.
But how can you suspect clinically?
So that is very difficult. They will present just like acute encephalitis syndrome. They will have high-grade fever and all. Sometimes the neurologists, they will do lots of antibody, and because of the antibody positivity, they will refer to us. But unless we have a brain biopsy, we can never say definitely that this is because of the...
Young persons with recurrent strokes, being hospitalized as encephalitis or some brain strokes, they ultimately come and is diagnosed as CNS vasculitis by the neurological centers. Is there anything to prevent further episodes?
So there is one specific entity called DADA2 deficiency. In DADA2 deficiency, they come with cytopenias and recurrent strokes which may occur at a very young age. And the drug of choice there is anti-TNF. Anti-TNF is known to prevent that recurrent stroke.
Thank you very much. Anything you want to add? Thank you.
So you can close.
Thank you for such an amazing. I would now request our chairpersons to please felicitate our speakers with memento. I request Dr. Sakir Ahmed sir and Dr. Pradipta Patra sir to be, and Dr. Rohini Handa sir to please come on stage.
पहले हम दिल्ली में तो रहते थे 53 साल मुझे सब कुछ याद है कैसे भूल सकता हूँ
After this wonderful session, we proceed to our next session, which is on diabetes and metabolism, artificial intelligence and medical disorders in pregnancy. Our chairpersons for this session are Professor Dr. S.N. Swain Sir, Professor Dr. Namita Mahapatra Madam, and Dr. Satish Pradhan Sir. I request them to grace the dais and introduce our speakers for this session.
Welcome to the session of diabetes, metabolic disease and medical disorders in pregnancy. In this session, the first speaker is Dr. Naval Kumar Bikram. Kishore. So Naval Kumar uplifted to Kishore. So he is the professor and head Unit 2 Department of AIIMS Medicine Department, and in addition, he is the Associate Dean of Examinations in AIIMS. So very important post in AIIMS. And he has 200 publications and being awarded in different national, international scenario. His choice of work is in diabetes, metabolic syndrome, insulin resistance, sarcopenia, and NFLD. So Dr. Bikram, he is to speak on GLP-1RA, delivering beyond. So beyond controlling hyperglycemia, he will tell what more it can do. So this newer drug, tirzepatide, has come, and which is working dually, and GLP-1 and GIP, and his is an anti-obesity drug approved by FDA. And this is the newer drug, and the other drugs are anti-hyperglycemic, and this is working on obesity. So I think he will better not to halt in between and make a time gap, and I wish Dr. Naval Bikram will give his prestigious speech. Dr. Bikram.
Thank you, sir. Thank you for the kind words, and it's always a pleasure to be here, and at the outset I thank the organizing team to invite me for this wonderful conference. So I'll be talking about GLP-1 receptor agonists. What do they, how do they act beyond controlling the blood sugar? They were basically developed to treat diabetes, but new discoveries or new findings that they have several other benefits were seen in those clinical trials which were undertaken, and now the management of sugar or diabetes is not a very prominent use or a feature for GLP-1 receptor agonists. Now the other things are more important, and they are being given more importance, and more molecules are coming in this area. Initially there was a single agonist, now they are dual agonists, and now we are also going to see triple agonists and several other oral forms. So this nowadays they are the blockbuster weight loss drugs. There is no doubt about that they are the most effective drugs available in the management of obesity. They basically mimic the action of GLP-1, an incretin hormone, and which enhances the glucose-dependent insulin secretion and suppresses the glucagon release. So this is the basic mechanism how they act, and that is why they do not cause hypoglycemia. These are the drugs which do not cause hypoglycemia and can be used. That is why this property of GLP-1 RAs has been useful, and that's why they have been used in individuals who do not have diabetes as well. They slow the gastric emptying, promote satiety and weight loss. So these are the mechanisms how the weight loss is caused by GLP-1. So first I'll be talking about the weight loss benefits. As I said, it increases the insulin secretion, which is glucose dependent, improves the insulin resistance, and increases lipolysis. Now decreases the gastric emptying and GI motility, so that you feel full after a meal for a longer time once you take these medications, and that is why you don't feel like eating more frequently. And this can be one of the adverse effect also. Some individuals may have excess bloating, excess abdominal feeling of abdominal distension. However, it subsides over a period of time. The second is it acts on the central nervous system, and it increases the satiety and decreases the appetite. And now the way it acts, the places in the CNS it acts, so this decreases appetite. So something which decreases your appetite, increases your fullness, is the best drug. And the main side effect of this is excessive nausea, which can happen in individuals, and that is because of its action on the nucleus of tractus solitarius, on which by one of the pathways it acts. It also leads to decrease in the liver fat. So this is just a summary of few initial trials with semaglutide. So semaglutide was a drug. There's a step trials, step 1 to 4. As you see, there is significant decrease in the weight in various trials. So first one was weight management, and step 4 the sustained weight management, and other one was weight management in type 2 diabetes. So I'm not going to go into details of these trials, just to say that good trials with adequate follow-up show that they lead to significant weight loss. And this I am just talking about a single drug, which is semaglutide. Apart from weight loss, whenever we lose weight, we tend to lose the lean body mass also. It's desirable only to lose fat, but you tend to lose the lean mass also, and that is something which is not good. But in this slide, what we see is that the weight loss which was achieved by semaglutide, there was much more loss of fat as compared to the lean mass. So there was some preservation of lean mass, and that is what is desired. So you lose only fat, not the lean mass. And in addition, this is more particularly important for Indian population, because in Indian population we accumulate fat mostly in the visceral abdominal area, that is the visceral fat, which is the major culprit. BMI may not be so high, but once you see your waist circumference or your waist to height ratio, that will be quite high. So we tend to accumulate we accumulate fat in the abdominal area, and this was shown by that there was change in the visceral fat area also by this drug. So this is something very important, because weight loss happening with generalized weight loss, but not much of abdominal fat is lost, then benefits may not be too good. But if you lose abdominal fat, that is something very, very beneficial. The beneficial effects of the GLP-1 in polycystic ovarian syndrome, this has also been used. There are a few studies where it has been used, and the main benefits are primarily because of, one, causing weight loss, second, improvement in the insulin resistance, and also decreases the hyperandrogenism. Reproductive dysfunction is also improved because it recovers the estrous cycle, improves the ovarian morphology. Due to lack of time, I haven't shown here all the trials where it has been seen. This is just the mechanisms how it is helpful in PCOD. Now coming to the cardiovascular benefits. Now after it was seen that it is a very good drug for diabetes and it causes weight loss, and now the third question, whatever the question has to come for every new drug for diabetes, is that what are the cardiovascular outcome? Without a cardiovascular outcome trial, no drug is approved by the FDA. So CVOT are must. Now, and this group of drugs also have been shown to have various beneficial effects on the heart. They have anti-inflammatory action, They have antioxidant effects. They reduce the cardiovascular events and decrease the risk of heart failure and ischemic damage. So all these mechanisms have beneficial effect on the heart, as well as they have some beneficial effects on the blood vessels in general. They improve the endothelial function, improve vasodilatation, decrease the blood pressure and prevent the atherosclerotic plaque formation. So these mechanisms can lead to beneficial effects in hypertension, enhance the nitric oxide production for better circulation, and prevent plaque buildup or prevention of atherosclerosis. So cardiovascular benefits have been seen in various studies. Out here, it's in the picture form. So this is one of the few trials, leader trial, which was with liraglutide, and over a period of time we see that patients with a cardiac event, and it was seen over a period of time that there was significant, the hazard ratio was significantly lower in the group which used GLP-1, that is liraglutide. And death from cardiovascular causes, also there was significant decrease in the hazard ratio. And this about those are step trials with semaglutide, what I have had shown earlier, and this was the significant change in the cardiovascular profile, that was decrease in the blood pressure, decrease in the CRP, decrease in the triglycerides. So there are several other trials which I have not enumerated here regarding the cardiovascular benefits of those trial with dulaglutide also, FP-glinitide also. So suffice to say that they have shown cardiovascular outcome benefits. Now heart failure, they may be helpful in heart failure also. The potential mechanisms may be that they decrease the atrial enlargement and decrease epicardial fat. That is an important mechanism. Improve the myocardial glucose metabolism, which is impaired in the individuals with the heart failure, and decrease the cardiomyocyte apoptosis. And they also may have beneficial effects for remodeling and increase in the endocardial cell GLP-1 receptor activity. So they may be beneficial in both situations, that is heart failure with preserved ejection fraction as well as heart failure with reduced ejection fraction. And there are a few studies also in favor of this. Now coming to the renal benefits, renoprotective benefits of GLP-1 receptor agonists. So the major organs, the heart, the kidneys, and the brain. So they, as I mentioned earlier, they have anti-inflammatory, antioxidant properties. So they improve inflammation, improve oxidative stress. They also enhance natriuresis. And they also, studies have also shown that they may be helpful in preventing podocyte loss, mesangial dysfunction, and improve endothelial dysfunction. So all this will decrease the renal injury, and which leads to renal fibrosis. So decrease in the renal injury and improvement in renal fibrosis and glomerulosclerosis. So this would lead to protection of the kidney from the ill effects of diabetes as such, or even in individuals without diabetes but having other metabolic dysfunction or obesity. Now, in patients with diabetes, the conventional treatment that is given to decrease the plasma glucose and decrease the blood pressure, that is the conventional wisdom in type 2 diabetes, that apart from sugar, blood pressure also has to be controlled equally well to prevent diabetic kidney disease. That is the one. That is how we protect the kidneys. But GLP-1 receptor agonists, on the other hand, they may act through several ways. All of these improve the blood glucose as well as decrease inflammation, weight loss, decrease atherosclerosis, and vasodilatation. So all these factors, all these effects which GLP-1 receptor agonists have, they may further prevent the further kidney damage. The evidence of renal benefits Here I have enumerated a few trials. The leader trial, again, it showed over a period of almost 4 years follow-up, there's decreased occurrence of new onset macroalbuminuria. So the composite renal outcome was decrease in the new onset macroalbuminuria, decrease in the estimated GFR rate, and progression to end-stage renal disease. So this is generally in the trials considered as a composite renal outcome. So the Rewind trial over a period of 5 years, and the Amplitude O trial, that is FP glinetide, it was about 2 years. It was shown to reduce the composite renal outcomes, and in the SUSTAIN with the semaglutide, again there was decreased risk of new or worsening nephropathy. So these trials, which were generally done for diabetes and for weight loss, and these were also the findings which were seen in these trials. Though these studies were not powered actually to look for renal protective benefits, but yes, renal protective benefits were seen in these trials. Now coming to the GLP-1 receptor agonists and neuroprotection. Now, if it's having so many benefits, anti-inflammatory, antioxidant, it improves blood flow, improves circulation, it should have some benefits in on the CNS as well. Yes, theoretically, definitely. And some animal studies, though right now observational studies and preclinical or the animal studies have been done, which show that they lead to decrease in the beta amyloid and tau protein, decrease neuroinflammation, improve the insulin signal transduction in the brain, and decrease the neurotoxicity and neuronal apoptosis. So they improve the neurogenic and synaptic plasticity. So these are the effects of GLP-1 receptor agonists which have been seen in the animal studies and animal studies of Alzheimer's, or the animal models of Alzheimer. And some observational studies have been there in which improvement in cognition or stopping or decrease in the deterioration of cognition over a period of time, let me put it that way, has been noted that the users of GLP-1 over a period of time, the decrease in the cognition was halted, and these are observational studies. So it may potentially have an important role there. However, till now there are no randomized clinical trials in human available to definitely show that this has benefits on neuroprotection, and hopefully we may see such trials in the future as well. And of course, one other major organ is the liver, and decrease in the liver fat. Although I haven't put that here because that itself has a lot of data is there. And liver fat, of course, the decrease in the liver fat is by virtue of mainly improvement in the weight, the blood glucose, improvement in the lipids. And few studies have shown that it may improve the fibrosis also to a larger extent. But again, the data for improvement in the liver fibrosis in patients with NAFLD or now MASLD is much robust with the SGLT2 inhibitors. SGLT2 inhibitors, empagliflozin. The data is there. It definitely shows biopsy-proven data that there is improvement in the liver fibrosis over a period of time. But with the GLP-1 agonist, that in these trials, the data has shown that definitely there is decrease in the liver steatosis and some improvement in the fibrosis, which was assessed non-invasively but not biopsy-proven. So, in summary, GLP-1 receptor agonists have several benefits beyond glucose control. No doubt about it that they are the most effective pharmacotherapeutic agents for managing obesity right now. Unfortunately, we don't have too many of them available in India. We only have one available in the oral form and one injectable as of now, liraglutide, which is available in the injectable form, and semaglutide, which is available in the oral form in India. But in India, the approval for liraglutide and semaglutide is for the management of diabetes. It is not for the management of obesity as of now, right? And now recently a dual agonist, as it was mentioned, it was a dual agonist. I haven't touched the dual or triple agonists in this at all. The dual agonist, that is tirzepatide, it is a dual agonist, GLP-1 and GIP-1 both, and that has been launched on Thursday by Eli Lilly, and which is still not available. It may take few weeks for it to be available. Now, efficacy in reducing major adverse cardiovascular events has been demonstrated in several cardiovascular outcome trials. There is also some evidence to support improvement in the renal outcomes, and neuroprotection, it remains still to be seen. It has been seen in animal study, whether that translates into human trials and in human beings, well, that needs to be seen. So, are GLP-1s the solution to multiple problems? Well, time is going to tell. Some evidence is there that it is a solution to multiple problems, but furthermore, we don't know. With that, I'll end my talk. Thank you for your patient hearing.
Thank you, Dr. Naval Bikram.
Would like to thank Professor Dr. Naval Bikram sir for coming all the way from New Delhi to present his lecture here. We would present him with a memento and uttariya. I would request our organizing chairman Dr. Anupam De sir and our scientific chairman Dr. Rasmiranjan Mahanti sir to be present on stage.
So good afternoon. The next topic is, am I audible? Technology in diabetes, innovations and advances. And to speak on this, we have a very dynamic professor, Dr. Jayashree Swai. She is the professor, Department of Endocrinology and Metabolism, AIIMS and Sam Hospital, Bhubaneswar. She is presently the secretary of Orissa Endocrine Society. She has many awards to her credit. Oration in MEDICON 2025, Outstanding Woman Contributing in Women's Health by ACP India 2024. Best Publication Presentation Award, Distinguished Mentor Award, Best Research Paper Award 2023, Best E-Poster, Excellent Teachers Award, and she has many publications in national and international journals. So over to you, Dr. Jayashree.
A very good afternoon, everybody. Thank you, Chairperson, for this nice word of introduction. My topic is technology in diabetes, innovation and advance. So I will discuss the continuous glucose monitoring, AID, insulin delivery system, automatic insulin delivery system, smart pen, virtual diabetic clinic, remote patient monitoring, personalized diabetic coaching and behavioral therapy, digital diabetic biomarkers, along with that artificial intelligence and machine learning. These two are most important. So before going to that, we all are moving towards the digital world. We should know something about the digital health, digital medicine and digital therapeutic. If you know the digital health, It is all technology used for this health related purpose. That is, no clinical evidence or regulation is needed for the digital health. The example of the digital health is that telehealth and wellness or lifestyle apps, these are included on the digital health. No clinical evidence or regulation is needed for digital health. Coming to the digital medicines, the product used to measure or intervene the health care is digital medicine, and it must have some clinical evidence like wearable sensor that transmit the data to the healthcare provider is the digital medicine. But if you look to the digital therapeutic or digital technology, it is the product used to prevent, treat and manage the disease. It must have some clinical evidence and regulatory clearance is there, that is from FDA or European societies. So example of that digital therapeutic is FDA approved cognitive behavioral therapy app. So to understanding between digital health versus the digital therapeutic or technology, digital therapeutic is clinical validated evidence based intervention and AI driven diabetic coaching, CGM integrated therapy, and it always requires this FDA or European approval, and measurable clinical improvement is there with the digital therapeutic. Whereas in digital health, the outcome is only focusing on the general well-being of the patient. So why we need, what do you mean by this definition of the digital therapeutic? It is the software driven intervention used to treat, manage and prevent disease, and it enhances the self-management through artificial intelligence, real-time data monitoring and personalized coaching, and it improves the accessibility, efficacy and the patient adherence, and it enables continuous monitorings and predictive insights are there with the digital therapeutics. Why we need this digital technology or digital therapeutics? We know all the challenge, the burden of diabetes are increasing, and simultaneously this A1C is uncontrolled throughout the world. And the main cause of uncontrolled diabetes, A1C in type 2 diabetes is non-adherence to this treatment. So we need digital therapeutic or technology to address the challenge, improving the medication adherence by the smart reminder or personalized behavior coaching, or enhance remote monitoring and proactive care is needed to adherence of a treatments. After that we will achieve our glycemic control. That's why we all need digital therapeutics. So coming to the evolution of digital diabetic management, so in 1980 to 90 we have our introductions of the home glucose monitoring. Around 2000s, that is digital logbook is with us, and early mobile database apps are with us. After that, in 10 to 15 years, AI powered coaching or CGM or insulin pump were coming to the field. But now we are in this era of closed loop insulin delivery, AI driven analytics on digital therapeutics, what is approved by the FDA. So this is the pictorial representations of this development in this diabetic technology, from that of the telephone based service to that of the AI and machine learning over this period of this 100 years. So if you look to the diabetes technology development over the period of these years, first we have this insulin pump and continuous glucose monitoring in the year of 1960. After it has been developed to insulin pump integrated with the continuous glucose monitoring, and followed by hybrid closed loop system, and followed by advanced hybrid closed loop, and now it is in the year of this 2022. Now we are going towards the era of full developed artificial pancreas or bionic pancreas. It will come to us within these few years. So before going to that CGMS, I would like to discuss something AI and machine learning in the diabetic care. AI recognize this glucose fluctuation. It predicts the hypo and hyperglycemia before it happens, and machine learning, it gives personalized diabetic care. it adjusts the insulin dose based on the individual response, and it recommended personalized meal and exercise plan. So in the real world, AI diabetic tools are DreadMed Advisor Pro, which is basically for the insulin optimization, and we have IBM Western Health, which analyzes these patients, diabetic patient data for this better patient care. These two are the well-known apps for this AI and machine learning. As I have discussed, AI, apart from that glucose level fluctuations, prediction of the glucose level fluctuations, it also predicts meal and activity recommendations, meal quality, quantity, time of meal, and optimal meal time. It will alert for the optimal meal times, and activities, physical activities recommendations will be predicted by AI according to their continuous glucose monitoring systems. And similarly, these are the Vitra Health, Blue Star by the WellDuck are these apps for the meal and activity recommendations, and DreadMed is for the insulin recommendations. These are these softwares now available at present. So coming to this machine learning, it is the main important thing is the data analysis followed by the personalized treatment plan, and along with that it is the it identifies the best medication combinations to each patient, and it detects these hidden correlations between the diet, stress and glucose levels, and the best platform for the machine learning diabetic care is the Omeda Health Care, which we are using frequently. So coming to our most important thing is continuous glucose monitoring systems and a smart wearable. It is CGM is a sensor-based devices that continuously track the glucose level. It has benefit over the traditional monitoring, and it eliminates this finger prick testing, and it provides these real-time glucose trends, and these most important CGM devices which is available in this market at present. These are newer one is Dexcom G7, Freestyle Libra 3, Medtronic Guardians Connect, and recent one is the Medtronic Guardian Simple. It is these four are available in 2024 in this market for the continuous glucose monitoring, and this is newer one. Then coming to some basic about the CGMs. There are three types of the CGM. One is real time, another is intermittent scan, and another is professional. Then what is in the real time? In real time it measure and displays the glucose level continuously, whereas the intermittent variety it measure continuously, but it display when it is swiped by the reader or by a smartphone. If you look to the professional CGMs, it is not owned by this patient. It is clinic based, and the patient will wear that CGMS for a certain period, that is 7 to 14 days. So it is among the three, the best one is the real time CGMS. And the real time CGMS, it includes the sensor, a transmitter, and a devices, a receiver. And the advantages of the real time CGMS is that it alarm hypo and hypo. It transmits the data continuously without the need for the additional action, and it eliminates finger pricking, and also it transmits data to the other member, family member, caregiver, and the physicians. If you look to this intermittent scan CGMS, it has sensor, no transducer, it is and receiving devices is there. It is there is no alarm for this hypo and hypo, and it requires this direct patient scanning. Only patient will able to visualize the blood glucose monitoring, no other persons. So the most important thing in this development of the CGMS is wearable technology for continuous glucose monitoring. It is the newer development, and it is the benefit of that is glucose. It monitors the real-time glucose monitoring and reduce the need of this fingerprint. And this wearable CGMS is available in this market as Dexcom 7, which is you can wear it at 10 days, and Freestyle Libra 3. where no calibration is required and high accuracy. By applying these wearable CGMS, studies are there, data, we have lots of data, that is reductions of the A1C by 0.5 to 1% over the period of the 6 months. So coming to this automated insulin delivery system, it is just closed loop system that automatically adjusts the insulin dose based on the CGMS reading. CGMS feed the glucose data to the insulin pump, and AI calculate the insulin dose, and along with that AI it deliver, and insulin pump deliver automatically that amount of the insulin. So it is the basis of the future artificial pancreas, and we are moving towards the fully automated AI driven artificial pancreas within these few years. So coming to another important thing is, we have come a long way in insulin injection, from glass pen to that of the pre-fill insulin to that of the smart insulin pen, and smart insulin pen connected with the CGMS. Smart insulin pen combined with a insulin pen and combined with a smart app in this mobile or any other devices, and it will also connect with the continuous glucose monitoring system. It record, store data of the insulin injection, recommended doses, and as well as display the glycemia and related the data for the paired smartphone apps. The benefit of that smart pen is that you can apply it to the type 1 and type 2 diabetes. In type 1 diabetes, those who are in the pediatric age groups, it requires the supervision of the caregiver, and you can connect with the CGMS. This is the prototype of the app which was displayed in the screen. So the benefit of that smart pen is that you can deliver 0.5 unit, which is not possible in any other pen in the pediatric age groups. So it monitors the insulin temperature also. And another important thing, this pen is compatible with any other insulins, which is like Novopen, Himalog, Fias, from these different company cartridges are there. So you can prescribe this thing to the all age groups. So coming to this digital type 1 versus type 2, how the technology is different, how our aim are different. In type 1 diabetes, the main aim is the glycemic control through insulin management, and the solution will be digital applications of these automated deliveries, AID and AI powered glucose tracking. Whereas in type 2, it is only this lifestyle modification and medications. Non-adherence is the important cause. So digital coaching and AI based medication reminder is the most important thing in the type 2 for in the digital therapeutics. So coming to this pregnant lady, that is AI has a definite role for glycemic controls. It can track the diet and exercise. It can give the exercise recommendations and the tools for that. Diabetic care tool for the pregnant lady, maybe the my sugar pregnancy mode, and studies are there. With the application of this tool, we can reduce this maternal complication by 35%. So again, in pediatric age groups, we need this digital help, and it is very helpful. And this platform like Sugar Pixel we can use, and by digital trackings, there is improvement on the treatment adherence by this 40%. So these are the special situations like type 1, pregnant, and the pediatric age groups. And we all know about the virtual clinics, and we have experienced this COVID-19 pandemic. So need not to say more about this benefit of virtual diabetic clinic in every setup. And coming to the gamification of the diabetic care, we each a person here need, if you do something good, we should praise that persons. That is called the gamifications. Reward. It is a game-like process. We are rewarding for a good things. So this app may be Sugar Fit or Sugar Better, by which this personal care will improve. So the next important thing is this personalized digital coaching and behavioral therapy. It is FDA approved, and only medications will not solve the problems of the type 1, type 2 diabetes, and so also in type 1 diabetes, this lifestyle modification is also essential part. And how this digital therapeutics or digital technology is helping, AI based system offer real time guidance on food, exercise and medications. The example for that AI based system is NUMS behavior based weight loss program, and by which so many success stories are there and clinical evidence are there, and digital coaching programs reduces this A1C by 0.4 to 1% over the period of the 6 months. So coming towards this end, remote patients monitoring is very much essential. Here we can reduce the hospital visit by for 30 to 50%, and in remote monitoring we can monitor the blood pressure, we can have tracking of blood glucose monitoring, and simultaneously we can detect these complications like the diabetic foot ulcer by remote monitoring these patients. And so many apps are there. Omada Health is the most important app for these remote monitorings. And the last slides regarding this technology is diabetic biomarker in diabetic management. So the apps, we have so many wearable devices by which we can know the heart rate variability, which predict the stress induced glucose spikes, or devices which predict the skin temperature and sweet glucose level, which indicate the metabolic status of these patients. So digital biomarker enhance the predictability accuracy, and it prevent the hypo and hypoglycemia of the patient. So to show the future directions in the digital diabetic management will be fully automated artificial intelligence driven insulin dosing will be with us. Integrations of for non-invasive glucose monitoring will wearable patches, it will come to us. And there are so many challenges and so many opportunities are there in this field. So many regulatory hurdles are there, and simultaneously this expanding market adaptations are also a issue. Ethical issue is another concern. Still we are expecting we will have this fully automated AI driven insulin pump, and also this non-prick patch in non-invasive glucose monitoring patch with us in this recent few years. So thank you for your patience hearing.
Professor Jayashree for such an extensive talk on digital health, digital medicine and digital therapeutics. So I think we can take questions.
Is there any questions on the floor? If there is no questions, then the lunch is nearby. And I thank Dr. Vikram, Naval Kishore Vikram, for his outstanding speech on how GLP-1RA is exhibiting its property in cardiorenal and neuro benefits, and Jayashree Swai for his artificial intelligence and machine learning in smart insulin pen and real-time CGM, and also non-invasive patch and everything in a technology in diabetes. So thank you both the speakers, and we end the session now.
So thank you so much, speakers and chairpersons, for such a brilliant session. I would now request our chairpersons to felicitate our speakers, Professor Dr. Naval Vikram sir and Professor Dr. Jayashree ma'am. And Dr. Anupam De sir. Scientific Chairman Dr. Rasmi Ranjan Mahanti sir and Sujata Devi ma'am to felicitate our chairpersons. Thank you, speakers and chairpersons. I now invite all faculties and delegates for lunch at the dining hall opposite to the... Good afternoon, everyone. We are back with a post-length session. Our session now is on neurology, cardiology, and geriatrics. To chair this session, I call upon the dais Professor Dr. Kasinath Padihari sir, Professor Dr. Ambika Mahanti sir, Professor Dr. Subhranshu Patra sir. I would now request our chairpersons to please introduce and invite our speakers for the session. Our first speaker is Professor Dr. A.B. Dey sir.
Good afternoon, everybody, and welcome to this post-lunch session. Me and my colleagues, Professor Kasinath Padihari and Professor Subhranshu Patra, all of us are from the AIIMS. We thank the organizers for this opportunity. The first speaker of this session is Professor Aparajit Ballabde. The topic that has been assigned to him is Approach to the Management of Dementia, the New Hope in Monoclonal Antibodies. It is in fact also an honor to introduce Aparajit, who is a batchmate of mine. We have studied together. He did his both MBBS and MD from SCB. Subsequently, he migrated to AIIMS New Delhi as the faculty in medicine, served there almost for 40 years. He got influenced by one of his senior colleagues, Professor Binod Kumar, whom we often used to see as the only geriatric specialist of the country, but he got motivated and kept on working. After his medicine job, he took over, developed the department of geriatrics medicine. I remember the day he had invited to the auditorium in AIIMS, where Dr. Ramdas was the health minister, and he worked very hard to bring up that institute, which is almost sort of one of the best in the country. He has several funded and non-funded research projects and published extensively on various aspects.
Sir.
It is a must. The time is there. He assisted in the WHO in developing training protocols and strategies, implementing the integrated care of older people, that is ICOP of the World Health, and now he is the consultant health aging in Southeast Asia Regional Office, CIRO, WHO. And after his superannuation from AIIMS New Delhi, he has been working in one of the geriatric centers in the New Delhi itself. And this is all about him, but you will all listen to him. But before that...
So before sir delivers his talk, we'd like to welcome you, so with a token of appreciation for coming all the way from New Delhi to Odisha to deliver a lecture. I request our organizing chairman and scientific chairman to please present him with a memento in Uttariya.
Thank you, Ambika. Ambika and me got 862 out of 1400 in MBBS, same mark. So this is our connection. And then he joined army, and many years later we again crossed our path sometime in Delhi, and life has been repetitive since then. I am a resident of Bhubaneswar since 1971 August. So it's my most treasured places on the earth. But I nowadays get disappointed by looking at the severe modernization and destruction of the city that used to make us feel happy. But anyway, progress is a part of life. This question mark, and then about AIIMS. AIIMS Bhubaneshwar is always a place where one looks forward to it. So 70-year-old AIIMS Delhi welcomes AIIMS Bhubaneshwar now in adolescence to the club, and I hope they will do pretty well. He is the third director. First director Ashok Mahapatra was our colleague, guru, very difficult person but very एक 2 लाइन का स्टोरी बता के फिर टॉपिक. During the dengue epidemic, one patient developed cerebral hematoma. Hematoma. Was admitted with us from casualty. So I told महापत्र साहब इसको करिए, ऑपरेशन करिए, हेमाटोमा ड्रेन करिए. क्या तुमने उसका एडमिशन क्यों किया? मैं कहा मैं थोड़ी एडमिशन किया हूँ, कैजुअलिटी में एडमिशन हो गया, डेंगी का टाइम है, डेंगी है, उसको ब्रेन में अनकॉन्शियस है, भर्ती हो गया. नहीं तुम क्यों किए उसको? मैं कहा क्यों का कोई जवाब नहीं है. ना आई विल रिपोर्ट दिस टू योर HOD. मैं कहा आई विल रिपोर्ट दिस टू योर चीफ ऑफ सेंटर. बैनर्जी साहब को बताऊंगा आप काम नहीं कर रहे हो. एनीवे ही वाज 2 years सीनियर टू अस इन MBBS एंड पहली मुलाकात डॉक्टर आचार्य के भाई के जनेऊ फंक्शन में. तो पहुँचे हम, किदवाई नगर में रहते थे, तो हम पहुँचे आचार्य साहब के यहाँ. एग्ज़ाम देने गया था मैं सीनियर रेसिडेंसी का, मैं और रामनाथ मिश्रा पहुँचे वहाँ. तो एक इंसान आया दुबला पतला सा, वो आके कह रहा कि आज मेरा PN टंडन के साथ ऐसी की तैसी हो गई. तो हम कहा ये कल्चरल इवनिंग में, सोशल फंक्शन में PN टंडन कहाँ से आ गई? कौन है? नहीं, अशोक महापात्रा है. ही हैज़ रिमेन्ड द सेम वेरी हार्ड वर्किंग पर्सन एंड I think AIIMS Bhubaneswar became number 1 AIIMS-like institution only because of Ashok Mahapatra, because of his very strict disciplinary nature and making everybody uncomfortable, including Ambika. Anyway, and then the next head, Ramnath Mishra was a very contender, but then M.K. Bhan Sahab told, no, you have not done any undergraduate teaching. So he told, why did you call me then? After all, मुझे क्या बुलाए क्यों? Then of course Ashutosh Biswas came. Ashutosh Biswas is known to me. ये 2-4 मिनट मेरे टाइम से एक्सट्रैक्ट करके बोलना. ये सीनियर रेजिडेंट बन के पहुँचे यहाँ एम्स में, पहुँचे मेडिसिन डिपार्टमेंट में, पता नहीं किसके यूनिट में थे कि ये उड़ीसा से और एक बोंग लड़का आया है, हमारी बिरादरी का ही बनता है. तो पता चला ये आशुतोष विश्वास है और बरहमपुर का MBBS MD कटक का. एम आई करेक्ट और रिवर्स? MBBS एंड MD बरहमपुर. तो उसके टाइम पर और 2 एक श्रीकांत शर्मा भी आए हुए थे. फिर मैं कॉमनवेल्थ जा ही रहा था कि उस टाइम पता चला कि 2 होनहार बंदे फैकल्टी बन गए, एडहॉक फैकल्टी. एक आशुतोष विश्वास और उसका प्राइम मिनिस्टर का फिजिशियन नबी ट्विग. तब तो हम जा ही रहे थे, इतना मुलाकात नहीं हो पाई, आए वापस आए. आशुतोष विश्वास वॉज पोस्टेड इन JP वाली, लेट डॉक्टर JP वाली, जिनके पास लेट डॉक्टर रीटा सूद नंबर 2 एंड नंबर 3 वॉज डॉक्टर रोहिणी हांडा. और उनका वाली साहब का एक PA था रजानी करके. तो रजानी का खासियत ये था कि आप दुनिया के किसी भी बिल में घुस जाओ, रजानी फ़ोन करके पकड़ लेगा. तो ये बीच, और वाली साहब को रोज़ उनका 1000 काम होता है कराने के लिए, तो आशुतोष और नबी चाहिए और रजानी विल फाइंड देम. मतलब कोई फुर्सत नहीं कि निकल जाएंगे उनके. बट देन एनीवे ये लोग सब 8-10 साल एडहॉक रहे, इनकी पर्सनालिटी की ऐसी की तैसी हो गई एडहॉक रहते रहते. बट देन फॉर्चुनेटली बाय गॉड्स ग्रेस आशुतोष विश्वास हैज़ डन ग्रेट. ही हैड मेड JP वाली सी मोस्ट ऑफ द साउथ ईस्ट एशिया रीजन. ये सब उनके लिए डॉक्यूमेंट बनाता था, वो जाते थे WHO एक्सपर्ट बन के जाके. वो डिस्क्राइब था डॉक्टर हांडा का कि कंट्री जेंटलमैन समुद्र के किनारे बैठ के जूस पी रहे हैं, और काम किया था किसने ना, आशुतोष विश्वास. फिर इन्होंने डेंगी का बनाया, गाइडलाइन बनाया. वो WHO CO वाले ऐसे करेंगे नहीं करेंगे. मैंने कहा तुम ना करो, मैं ही गाइडलाइन छाप देता हूँ. छप गया, आशुतोष विश्वास ने छापा है. मिनिस्ट्री में सबका फेवरेट इन्फेक्शियस डिजीज वेक्टर बॉर्न है आशुतोष विश्वास. सो व्हेन ही बिकेम डायरेक्टर आई थॉट ही गॉट द राइट रिकॉग्निशन फॉर हिज लीडरशिप एबिलिटी, एंड आई एक्सपेक्ट आपके दिग्दर्शन में, आपके लीडरशिप में विल बी डूइंग वेरी वेल. सो वेलकम टू द क्लब एंड thanks for making me great darshan of Lord Jagannath. Thanks to Mrinal Kanti Das who organized that. But seeing Lord after about 5 years was a great opportunity. So thanks to everybody. Now I'll start about the topic. I put the question mark because I'm not so sure whether this map is any good. क्यों नहीं, फिर आगे मैं बताता हूँ. It's a dementia is basically a disorder of late life. So यहाँ पे बहुत सारे लोग हैं इस ग्रुप में हैं. It's a disorder of cognition and behavior. Mostly in late life, it's not a disease of younger people. So these are the something basics about cognition. It's basically you hear a thing and you read a thing, how you process it. Does age affect cognition? Difficult to answer. And there are a lot of confounders in cognition research in aging, mostly because of early dementia, subclinical disease, but mostly because of lot of physical illnesses that may be present in a person. So these are the things that are lost: speed of performance, mental flexibility and abstraction. You may have seen, younger people may have seen that their grandparents or their parents are very fixed to their ideas. आपका बॉयफ्रेंड या गर्लफ्रेंड उनको पसंद ही नहीं आता है बिल्कुल, बिकॉज ऑफ दिस मेंटल फ्लेक्सिबिलिटी का कमी हो गई. What is not lost? Attention and doesn't decline till about 80. So if you think that the old man is not listening to you, please don't make that mistake. Language and intelligence, it's not affected. So what I will say, if Dr. Biswas does not recognize a young faculty, it's a process of aging. If Anupam De and Rasmi Mahanti do not recognize, he is busy. But if Srikanta Behra is not recognizing a colleague, then he has got a mental health problem, needs to be treated. So that is the verification basically. For Asutosh, all right. For Rasmi and Anupam, बहुत काम है तो भूल गया किसी का चेहरा, चलेगा. So age associated changes may be difficult to distinguish early dementia and depression clinically. So whenever an older person comes with depression, I start with depression and then go to dementia later, just to find out कहीं उसको depression ना हो. So these are the parts of memory, basic neurosciences. I am not going to be dealing with them. Just to complete the thing, the memory and aging, as I told, women has got but much better memory. All middle-aged and elderly husbands will understand कब आपने क्या कहा था सब याद रहता है. So that's all scientifically proven. Higher education, cognition, etc., lifestyle, biology, they affect all memory and aging. So older people have got significant cognitive reserve. We have been planning to do some cognitive reserve research in LASI-DAD. Probably 600 MRIs that we have done, functional MRI, that will give us some idea about how does cognitive reserve decide loss of cognition or not. Aging of brain, all these things happen. All you know that brains become shorter, smaller. So when the drugs that you prescribe, CNS active drugs in full dosage, it is most likely that the older person will become most abnormally behave. So I tell everybody, brain तो छोटा हो गया, start with a 1/4 dose and maybe आधे में काम हो जाएगा. Neurotransmitters get disturbed and also reduced transmission efficiency is also expected. So in some individual these changes have no meaning, but in some people this may lead to some cognitive decline but they do not produce any disability. So significant cognitive impairment, incompatibility, independence, existence is called, and social interaction is called dementia. So if I forget, से आशुतोष विश्वास को ठीक से स्वागत नहीं किया तो चलेगा, पर अगर उसको खूब गाली दिया अभी और कुछ कहूँ तो वो फिर डिमेंशिया माना जाएगा, वो नहीं करूँगा लेकिन. तो so let's consider that dementia causes disability, first instrumental activities of daily living, then activities of daily living. So these are the features of dementia, impaired memory, learning, etc., etc. But the last line is more important. What affects the caregiver is a variety of behavioral problem. In fact, in our country where the older person is generally supported by a family, joint family ho ya chota sa family ho, what matters to the family is the behavioral problem rather than the cognition of note nahi pehchana, bhul gaye तारीख, उसमें कोई खास फर्क नहीं पड़ता. So these are the causes of dementia. Just focus on the other side, irreversible causes. First three causes are important. Alzheimer's disease, Parkinson's disease, then dementia of Lewy body at some end are the vascular dementia, multi-infarct as well as Bis-Wagner syndrome, etc. And these are the reversible causes, but whether HIV, PML, neurosyphilis are reversible or not, that is a different story altogether. But what we see is hypothyroidism, B12 deficiency are very common causes, and in older people who have got some history of head injury, subdural hematoma may be an important cause. In my all these 3 decades, I may have seen 1 or 2 patients of brain tumor may be presenting as acute onset cognitive decline, but generally होता नहीं है, देखते नहीं actually. So the commonest cause of dementia is Alzheimer's disease, followed by vascular dementia. It is 85-15 in West. Coming down to Japan, it becomes 50-50, and in our country probably 65-35. But let's understand, as we now understand that we know that lot of vascular diseases are occurring in the population, heart attack, stroke. So some of the dementia may be because of small infarcts that may not have been detected earlier, not actually going to Wiss-Wagner syndrome of numerous multiple infarcts, but maybe even 2 or 3 critical infarcts will be good enough to make a person totally disabled. So this is all about Alzheimer's disease, about less than 1% and 60, and then goes on increasing. 3.5 million is an old figure, the right figure I'll be telling now. But what is important that the second part of my presentation, that is the monoclonal, is related to this vascular amyloid and neurofibrillary tangle because of tau proteins. So these are the two primary abnormality in the brain which people are thinking of kind of targeting. So 3 phases, initially only higher mental function, then focal deficits come up, then global neurological dysfunction where the person is totally bedbound. Typically 6 to 8 years, but with better care and treatment, people can live longer. Most people of Alzheimer's disease die of infection and injury, and sometimes because just that the brain has become too bad to sustain a long life. How we make a diagnosis of dementia? Management was my forte, so that's why I thought I'll deal with it in a separate slide. We diagnose dementia by doing if somebody comes off with a complaint or memory complaint or behavioral problem by the family, we do a screening test called DART, D-A-R-T, DART. DART is Indian. MEDICON is available generally for the Western people and very common also. DART is a simple test. You ask the person to repeat 3 words that you have named earlier, 3 different words. Then ask the person, name as many vegetables, birds, animals or whatever of one type in 1 minute. Time it. If it is less than 12, that means there is a defect. Then ask the person to recall the 3 words that he had or she had told earlier. If that is done, that means the test is negative, and the 4th one is drawing a clock. The clock drawing has been given a lot of importance in WHO circuit, but if you are doing a tele-consultation, which is now very common, probably clock drawing will not be required. You can do the first 3, and if the 3 are all right, even 2 defects make that you need to go to for greater investigation. So what are the further contribution by MMSE? It's very difficult to get MMSE in research now or clinical practice because it is IPR protected. Initially it was free in our earlier days. So we depend more on HMSE, which has been Hindi Mental State Examination developed by Mary Ganguly, my good friend, product of CMC Vellore, works as a professor of psychology in psychiatry in Pittsburgh University. She did this work, Hindi Mental State Examination, through an NIH project in Ballabgarh area of Haryana, and from that this scale evolved. This is available on the in public space. One can download it, do it. Scoring is also there. But what is important that scores above 28 are normal. 30 is the maximum score. Between 25 and 28 are mild cognitive impairment, and below 24 are abnormal. We do something called CDR, Clinical Dementia Rating Scale, developed by Washington University. The score is 0 for normal, 0.5 for mild cognitive impairment, 1 and above for dementia. After doing this, if one has got a facility services available for neuropsychological testing, AS3 is the common test that we do in AIIMS and many other places in the world. ADAS is a common UK tool that is used in UK, and then testing of ADL on instrumental activities of daily living, very common in geriatric practice. For that we have one scale by Mathuranath et al. From NIMHANS, IADL of elderly. So that is Basically, when you ask the person that are you independent in activities like daily living or instrumental, that gives a fair idea of social existence or independent existence. But before that, we must exclude other psychiatric illnesses in past and subacute kind of a delirium, that the acute delirium which has gone over for some time. But anything that goes beyond 6 months, if the person is delirium for 6 months, we'll consider that as a dementia rather than delirium anymore. And then we'll try to find out the causes of differential diagnostic causes that I have told in the previous slide, that the reversible and irreversible ones. So this is how things go. Probable dementia, definitive diagnosis, and possible dementia. This is actually more of a clinical brain stressing by clinicians, but in clinical practice, the person is sitting in front of you in about 10-15 minutes. You probably make up your mind what is going on. But something important here, supportive evidence for possible and probable dementia are this, and what excludes is acute onset, focal signs, seizures, gait disorder early in the course of disease, excludes possibility of dementia or Alzheimer's disease. But we know that most dementia patients over a period of time develop gait disorder. We have 2 publications on this. So obviously, if they start falling, and or if the Parkinson's disease is the cause of dementia, probably gait disorder will be common at the early stage also. So this is the latest diagnostic criteria for diagnosis and staging of Alzheimer's disease. I am showing this slide because this is all related to monoclonals. So if somebody is interested, can read it. The criteria are basically clinical, biochemical, imaging, and there is no diagnostic test for the Alzheimer's disease as of today. So these are the features of cognitive problems in Alzheimer's disease and dementia. All these things can happen one by one with other. Starting with memory loss, we put a lot of our money on memory, but other things are all important. But if somebody has got a demonstrable memory loss, probably diagnosis is pretty clear that there is something grossly wrong with the person. I have seen patients who just can't speak, loss of language or recognize self and others, and some people only have got very difficult behavioral problem like this, and from that we try to guess whether the person may be heading towards dementia. There is an entity called minimal behavioral impairment. As I told, dementia has got 2 components, cognition and behavior. So there is a behavior pathway that some people may develop very subtle forms of this problem and go on to progress dementia at a later date. We have got 1 publication on that we followed up some patient with minimal behavioral impairment, demonstrated, and then see what was happening to them. So this is the kind of a workup that is required. We are now working on a heavy metal screening project. CSF is rarely done because I personally feel that doing a CSF in a old person with cognitive impairment really doesn't add up to anything, because most of the things done this way will give a fair idea as to how we are doing. The last line is FDG PET, amyloid imaging and tau imaging. For a diagnosis of definitive biological Alzheimer's disease, all 3 must be done in a single patient in 3 sittings, and all 3 should be positive, which becomes a very important logistic issue of getting a PET machine, patient remaining in the machine for 1 hour on 3 occasions, and with this, and most importantly, whereas FDG and tau are available in commercially available, amyloid ligand is not available. The German producer suspects that if they sell it to India, Indians will make its replica and stop buying there. So they have only permitted Professor C.S. Bal of our nuclear medicine, one of the most eminent professors from Odisha in nuclear medicine in the world. He has got permission to do it for research purposes. But as I retired, that scheme, that project also died a natural death. So as of today, we do not have amyloid imaging because more of a commercial problem rather than an interest to buy it. So what is the treatment? Symptomatic treatment through these drugs available in market, ribastibine, donepezil and galantamine, and then we have memantin. The HRT is never advised nowadays, and all these drugs are, you can just think of to make a list complete, but in my humble opinion, rivastigmine and donepezil are two good drugs that works memantine only for cognition problem. They have no impact on progressive disease or any disease modification. So these are the non-pharmacological methods which has gained lot of importance because drugs are failing. So we try to develop that. One of our PhD had done this, occupational therapist, he did a PhD from KGMU, trying to use some of the techniques and see what is happening. But you know, most of these boys and girls, they cheat, so I cannot really say that this was really effective. But let's understand, if the brain is decaying, atrophying, whatever you may do, sometime or other, all this will fail. So protect the patient is the most important thing, and family caregiver support is also equally important, because it's the caregiver who is carrying the burden of dementia rather than the patient. And so we need this kind of services in the system, and also self-help group and caregiver support groups. We did some work. Why it is important for us that in this March afternoon I am talking of this. You can find the name of Rasmi Ranjan Mohanty somewhere here. कहाँ गया? कहाँ चले गए भाई रश्मि मोहंती? ये लाइट है. Anyway, you can find out Rasmi Mohanty here. Rasmi Mohanty's name here. Very much there. Okay. So कहाँ गया रश्मि? हाँ पैसा वसूल. Okay. So this is a part of our diagnostic assessment of dementia and longitudinal aging study of India project funded by NIH. AIIMS Bhubaneswar has been one of our permanent partner in doing the 2 waves of the study. Nowadays, of course, you cannot have other institutions through NIH funding because of the FCRA restrictions. But Rasmi just escaped before I could know that a restriction has come up, because not knowing the rule is the accounts officer AIIMS's problem, not my problem. So we did this work. This is one of the most quoted and definitive study in prevalence of Alzheimer's disease, dementia in our country. I am using the term dementia, not Alzheimer's. In community field work, one cannot make a diagnosis of Alzheimer's disease. So it is estimated that about 7.4% of older people have got dementia in our country, with lot of differences in age gradient, education gradient, sex, urban, rural difference, cross-state variation, and an estimated 8.8 million Indians were considered to be having dementia in 2020 when the project ended. First wave of the project ended. We have completed the second wave of Lacidad, and probably in about a year's time we will be also possible to say us what is the incidence of dementia in India, as to how many of those who had Lacidad wave 1 normal had now become demented. So we will be able to say in 5 years' time, this is the incidence of dementia in India. So that we are waiting for the analysis to come, because to make a diagnosis of dementia, we have to do a clinical dementia rating scale assessment of the data developed or collected by the field worker by a team of 2 psychiatrists, Mary Ganguly and Matthew Burgess from NIMHANS Bangalore, and then look at the data, and 10 more graders will have make the grading that this is dementia or not, and then that will come out. And we found that the burden is very unequally spread. Please note that here is Odisha with 7.1% prevalence rate. This is Odisha. 9 है. उसके ऊपर वेस्ट बंगाल है. Maximum is J&K. But we do not take J&K as a right case, because we did all our work in the valley, and doing a field research in valley during the current time is very difficult. This was of course before, this happened before 2019. But still then working in valley is very difficult. So I say that I feel that the draining area of AIIMS Bhubaneswar, that is West Bengal and Odisha, have got one of the highest prevalences of dementia, even more than that of Kerala. Kerala कहाँ पे यहीं पे है? 7.6 point something in Kerala. So Kerala has got more aging population. Not highest, one of the highest. बंगाल ऊपर रहता है, उसके पीछे में। इफ यू हैव ममता बनर्जी है चीफ मिनिस्टर तो डिमेंशिया ज़्यादा वहाँ होगा ना। वो ठीक है, जो भी है, आई एग्री। सो टॉप 2 में आता है उड़ीसा एंड बंगाल. बेसिकली आई एम टेलिंग द ड्रेनेज एरिया ऑफ योर हॉस्पिटल इज having a lot of people, older people with dementia problem. And then we looked at 2011 census, in which we found that Odisha comes number 5 in the list of proportion of older people in the population. Number 1 is Kerala, number 2 is Tamil Nadu, number 3 is Karnataka, number 4 is Punjab, and number 5 is Odisha. If you exclude Himachal and Uttarakhand, small states with a lot of population migration, so thought that probably 5th largest population aging state is Odisha, and this much of prevalence of dementia. So you have got a major problem in this state regarding this. I asked this question to what is this, Satpathy, MP, ex-MP, my good friend. Why? Tathagat Satpathy. I asked Tathagat Satpathy, why your people have got lot of dementia. I asked this question to many people. Why people live longer in Odisha despite a dysfunctional healthcare system, despite so much of poverty. Why people are living longer? In Kerala, you can say people are living longer because there everything is good. Human index is good. People are rich, state is poor. Health system working fine. So all are educated. So that's not true for our state, where the poverty is very high and the large population of our segment of our population is not educated. So he did not have the answer. I asked this question to some demographers. So they thought probably there is something biological. So I asked a Mahendra Kumar Thakur of BHU. He told maybe वो जो आप लोग पखाल खाते हैं उसमें जो ईस्ट है वो ईस्ट शायद रेस्वेराट्रोल बना रहा है, उसका प्रोडक्ट जो है वो एंटी एजिंग है. एंड आई एग्री विद दैट. I agree with that. Something in our पखाड़ो that you have done some research recently, अखबार में छाप दिया. तो अभी आया था ना, अब कल परसों आया था पेपर में. मैं कहा चलो यार, somebody has taken our idea that something in the 20th March was World Pakhalo Day, and AIIMS Bhubaneswar has done some research and found something in that. But I agree with that. It improves longevity, but how much effect it has on cognition, I don't know. So probably AIIMS Bhubaneswar has to show some path, and we have done another analysis of LASIDAD, in which we find that Odisha is one of the highest people of frail older people in the community. That is another topic. So next invitation I will present that paper. अभी से जुगाड़ भी कर दिया मैंने. Anyway, so all dementia are not Alzheimer's disease. Let's be very clear. And my feeling that large majority of dementia that you see in Odisha or in India are not Alzheimer's disease. They are just what? There will be last slide. So how much most research focuses in AD, including research for cure. In 1995, Bill Clinton told NIH that you find a cause and treatment for Alzheimer's disease. So for that, in next 30 years, still continuing, the funding of cognition research has taken a huge jump, and that's why the LASIDAD project, etc., etc. So now, for the aeroplane ticket and taxi, monoclonal antibodies in treatment of dementia. कहना था भाई, पैसा तो दिया है आपने. So there are 3-4 agents have been tried. This is the first one, aducanumab. डॉक्टर हन्ना ने बताया जिसके पीछे मैब होगा मोनोक्लोनल होना है. So this is human monoclonal antibody. These are the mode of action. Basically trying to reduce amyloid deposit in the brain. There have been 2 large trials, ENGAGE and EMERGE, and trials have been done in many places, many countries, randomized double-blind trial. And to show the result, this is the picture like what happened, really matching, nothing much to difference. Please see that this CDR is 0.5 or less. That means they had mild cognitive impairment, not dementia. So these are the people who had some cognition issue, and they were tried with this drug. Good result, 0.012 in EMERGE style, not so much in ENGAGE, and there are changes in MMSE not very significant, and significant problem of adverse side effect. All these drugs have got FDA approval, not on the basis of clinical trial, but on the basis of radiological investigation, evidence of reduction in amyloid in the brain. But in 2024, Biogen thought it's not doing good business, so they stopped it. There are quite a few non-profit agencies in the world, like World Dementia Council, who are pushing for use of monoclonals in dementia. It's a big market business, so World Dementia Council, I am a member of that. So in the first meeting itself, I understood the aim is to not to look after dementia care, but to sell of monoclonals. The aim that humanized molecular, how they work, there is a big trial, Clarity trial. Then we have got this study on lecanemab in Alzheimer's disease. Again, this is the result. This is the dosage. Just have a look at it. Same story, changes in amyloid burden on PET was the endpoint. With this, I wanted to see what is happening to the CDR scores. And total population was 859, placebo 875, randomized control. All good work, no problem whatsoever. The Angrez always do good research. All those bad research are never published. So they are all kept under the, they are just thrown out. Or study this thing 001, 001, 001. No difficulty in getting statistical significance. I am not doubting their scientific honesty. They are all. That's why they are being reported and published. And but what happened? Adverse events are too much and just been tried out. So nothing yet. So this is the status as of today, not available in India. Some countries have already approved to use. The caregivers are very worried that this should be started so that you have some relief from dementia or prevent dementia. This is the third drug. They have been marketed and same story, amyloid, and these are the features where it is done. Primary outcome was to look at change in ADRS scale at 76 weeks. So the changes have to be seen looking at tau PET and amyloid PET based diagnosis scans. This is how things are done. And these are primary secondary outcomes. And again, statistics adverse events are pretty high. So again, this has been tried out, still not available in India. Maybe sometime later in the year we will get it. So there are a lot more drugs in the pipeline. The white men and women are running against time to have developed some drug for dementia. But before I end, a word of caution. Lancet Commission has been working on dementia prevalence and prevention and care for last 10 years. From time to time, every 2 years, they make some predictions as to what the preventable risk factors and modifiable risk factors are. At this point of time, there are 14 of them. So 45% of modifiable risk factors are these. So you can imagine hearing loss, HDL, LDL, depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, obesity, lot of work for Dr. Naval Vikram, social isolation, air pollution, visual loss. They account for 45% of dementia in our society. So if you are looking at a cure or care or prevention, probably our focus would be in these 45% rather than an unknown illness whose diagnosis is yet to be, whose pathology is yet to be understood. The two main pathways, tau pathway, amyloid pathway, and we have worked sometime on glucose metabolism pathway. Even diabetes or pre-diabetic state has some linkage through FOXO pathway, FOXO protein pathway, that there may be, especially for people like countries like ours, probably the diabetes path probably will come out as an important point. Still work is going on. So probably if we maintain if we follow Naval Kishore Bikram in the right path, you will reach me in good mental state. Okay. So to conclude, dementia is a clinical syndrome with AD as the prototype. Cognitive decline of aging is affected by modifiable risk factors, which are very important for us. If as you cross 40, the young guys sitting on the back side, please look at that. फ्रंट लाइन वाला का तो सोशल आइसोलेशन पोल्यूशन किसी और कुछ रहा नहीं करने के लिए और हियरिंग एड. Curative treatment is a distant goal. Probably in my lifetime this will come. I am hoping so. The term dementia has been replaced by major neurocognitive disorder in DSM-5, and actually dementia is a challenge for the society and for the science and the caregiver. And it shows the limits of modern medicine. From 1906 to 2025, in 120 years, in terms of a cure, attempts have been made, but no definitive step yet. So it is a hope, monoclonal antibody are for the hope for the future, but not of today. And I thanks AIIMS Bhubaneswar for giving these opportunities to this great institution in the making. I hope under the leadership of Ashutosh Biswas will reach there.
Thank you, Professor Aparajit. But however, this has been given as a topic for discussion here. Alzheimer's, the role of monoclonal antibody. So I think a lot of people are here who came post-lunch after the duty in the morning hours. They are the people, young people, who will be treating us, some of us or some of those Alzheimer's. And monoclonal antibody has already been tried. I think we cannot completely rule it out.
I am not ruling it out.
You are discussing the secondary dementia or something.
I am not ruling it out. I am just telling to make a diagnosis of Alzheimer's disease as per 2024 definitive criteria that you start the monoclonals. It's a 24 quintals of ghee and Radha will dance. Very difficult.
So that
having
would be
a PET scan done in 3 persons have been.
I got your point. Yes.
So to make a definitive diagnosis, the cost is prohibited, side effects are very high. So I feel a day will come, not the monoclonals, but day will come, we'll have a tablet or capsule like statin or something like that.
Got it.
That will give us the relief rather than every week
but still,
for the whole lifetime.
Still with your permission, can we ask somebody
Oh, yes,
if they
yes,
got
no
any
problem.
questions?
I have no issues.
Youngsters, yes. Yes?
किसको कहना है पूछो भाई क्या पूछना है You are not the youngster, Daksa. पीछे youngster आ रहा है You'll never had dementia. You consider yourself young.
My question is that how to predict at least 10 years ahead or 5 years ahead when I am going to have dementia. In marker
Wait for Lacidad Wave 2 results. Because you will have a same people seen between 2017 and 18 and then now 23, 22, 23. We have got some productive, follow-up data on people, the same scales used, same markers. We will be able to tell you what are the...
It is not a question, but it is just a speculation that what Professor Mahanti told, that the young people will care us, not like that. They have to protect themselves from dementia. Because what happened, the mechanical devices, the machines, vehicles, made us to diabetes and made us physically invalid. Similarly, the digital devices are going to make them mentally retarded. That means decline. I think it will, nowadays we see diabetes in the very young age. They will see that dementia will occur at very young age. This is my speculation. So unless the young people cunningly, judiciously use the digital devices, they are heading towards a young age dementia. This is my speculation.
Okay, thank you. Professor Ashutosh.
There are not much of young, so maybe...
You are young in front of my eyes.
Thank you, sir.
I was additional your senior resident. You remain young forever.
Thank you, sir, for your compliment and wonderful talk. I have a few just point to understand. The prevalent that you have shown is 9 to 10% is alarming.
7.4%, but it will be 9 to age.
Yeah, 11%, 60 plus, and then working in this 60 plus means 10. So it's really I am 60 plus. So I'm looking. I was thinking when I'm going to have the ADs and all that. So and you told various symptoms and signs. Just I was trying to go through, but
That your faculty will say if you are showing some signs or not.
So, sir, just one point. Now we are discussing about the precision medicine, personalized medicine, and genomics, proteomics, multiomics, and different things. And one medicine is not for all nowadays. So you have to personalize whether this medicine really is going to work for him or her and going to have a side effect or not. So that mechanisms coming as a personalized medicine through this all genomics, proteomics, So in this, there is a public health challenge. It's a great, serious problem for us and everyone going to be older, and then gradually, if the 60 plus, maybe 80 plus, 30% or 20, you have not shown that. You have written 60 plus, but maybe more in that group.
Yeah, there is another slide. I could not show that.
And
there is a slide which says age group wise prevalence.
We are very happy to know that modifiable risk factors are 45% or 47%, that if you have a hypertension, diabetic, obesity, and there are so many other, if you control that, probably 45% will be eliminated. If you are going to not to have a diabetic, not to have a hypertension, I don't think we can prevent that much of those. So whether these are association or really hypertension, obesity is really causal association. That is my question. If you sum up all this, 50% are eliminated, then is really causing. Now I would like to know also, everything is governed by gene. How I talk, what is my behavior, what is my skin color, everything. So what is the genetic linkage of this, and can you have that kind of genetic gene therapy for any kind of that research coming up, or you are the stalwart in this field?
I'm not the stalwart, I'm just a simple worker.
So genetic approach to have a gene therapy, you have shown the monoclonal antibody therapy, that's fine, but it's not proven yet, and you have to wait for, I think, long to see the effect. P-value have shown less than 0.05 in many publications, but yet to have that into our India, I'm not sure. So is there anything that we can, and what is the role of AI? AI is coming, AI is the future of medicine. So can anything that one of our participants says, any prediction that any future model that we can predict, really examining this all the markers or anything? Yes, you are going to, after 10 years, 20 years later, you are going to have AD or anything. So that would give really warning signs for him, and to not to have those all 45%, 47% of these now have to be very strong to prevent the dementia.
Sir,
so
can I
that
answer this question for?
Yes, sir. Thank you.
Let me
Sir, the topic that was given to Aparajit was Alzheimer's and monoclonal antibody.
No, my topic was approach to dementia.
Okay. And next part was the monoclonal. Sir, this question,
I have done my job
very well.
Not well, to my best of my possibility.
That's right. He has done a lot of studies, whole country, and of course Odisha. The questions you are raising, I think we have to sit down after few months to look at preventable causes, genetic studies. But whatever he said, he is a little pessimistic. People have studied, it has got some effect of monoclonal antibody in the world, and side effects besides, it can arrest or delay the process as on today, early Alzheimer's, not late or something, all those cases. That is what the literature says. I think, Aparajit, you have to come again after some time, 3 months, 6 months, when the AIIMS.
Just to answer a few comments. आशुतोष विश्वास एंड नबी तुईक जब भी डाटा देखते हैं ना, उनको पुराना अमेरिका में सीखा हुआ क्लिनिकल एपिडेमियोलॉजी याद आ जाता है, वेदर इट इज़ ए सेमिनार प्रेजेंटेशन और एमडी प्रेजेंटेशन और व्हाट एवर इट इज़. तो मैं तो मॉडिफाइबल रिस्क फैक्टर इज ए कॉज और नॉट, ये आप ही जवाब दोगे, या आप स्टैटिस्टिक्स वाले हो, पब्लिक क्लिनिकल एपिडेमियोलॉजी वाला, आप कहोगे उसको. जो लैंसेट कमीशन ने कहा मैं वो दिखा दिया. नंबर 1, लासीडैड वी डिड 2700 होल जीनोम सीक्वेंसिंग, including that of normal people and also Alzheimer's dementia people. We have repeated, not repeated, we have added another 1800 to the list in the second wave. So we have about 4,000 or so whole genome sequencing data available in public domain since 1st of June. And also we have got biomarkers, you name it, we have it. Metropolis lab has done biomarkers, some hundreds of biomarkers, whatever was available. And also we have stored blood for future, अगर और कुछ कहीं निकला तो उसको भी टेस्ट कर देंगे. We have looked at 7 protein molecules, amyloid, tau PET, NFL, blah blah blah, 7 protein molecule in baseline and in follow-up, and there to see how it is changing. That paper is under publication at the moment. But unfortunately, not much of interest has been shown by Indian researchers in looking at this data. This is available in public domain. It's not that anybody sits over it. Like Lassi, not much of interest has been shown by Indian researchers on this data. So, sir, maybe फिर मिलेंगे, आपको बताएंगे आपका रिस्क फैक्टर. Okay. Thank you, sir.
Hello. Now we'll move to the second topic of this session. It's heart failure with preserved ejection fraction with special reference to geriatric population. So to deliver the talk on this, we are having with us Professor Prashant P. Joshi. He is an executive director and CEO AIIMS Nagpur. He is ex-professor and head of AIIMS Nagpur IGMC with 40 years of experience as medical teacher, consultant physician, agent and administrator. He has more than 200 research publications in top prestigious journals like JAMA, NEJM, BMJ, Lancet, WHO Bulletin, JACC, American Journal of Tropical Medicine, and also he is having chapters in APA textbook of medicine. His name is featured in top 2% most influential scientist in 2023 Stanford University list. He received COVID Warrior Award by Honorable Governor of Maharashtra and by IMA.
Thank you very much. I think we can stop there. A very profuse and
just
introduction. We can stop.
Okay.
So we'd like to welcome you. Sir, we'd like to welcome you with a token of appreciation with a memento and Uttariya. I would like our chairpersons and organizing chairman and scientific chairman to come on stage.
Okay. I can start now, I think. After a very elaborate and a very lucid talk by the very senior Dr. Day, my topic is heart failure with preserved ejection fraction. Special reference to geriatric population. Now, heart failure, when we normally talk, we talk about heart failure with reduced ejection fraction, but this is a heterogeneous group, heart failure with preserved ejection fraction, whose prevalence and incidence is in fact increasing, is highly under-recognized, unreported, and undiagnosed. We all know definitions, this I will not go, but why focus on heart failure is because the management is very important, because hospitalizations due to heart failure are increasing. Similarly, the cardiovascular deaths are also increasing. Now, heart failure is a disease of elderly. We know India is experiencing an escalating epidemic of cardiovascular disease, heart attack, paralytic strokes, essentially driven by lifestyle changes. And the prevalence of heart failure, very good studies are not available, but it increases as the age advances. Overall, it's about 2%. More than 65, it goes to about nearly 5 to 10%. So very high prevalence in elderly. We know heart diseases, hypertension is increasing, diabetes is increasing in epidemic proportions in India. And these are the factors which actually cause heart disease, which ultimately culminate to heart failure. We can skip this slide. we know the overall prevalence or the universal definition of heart failure. Heart failure with preserved ejection fraction is when the ejection fraction is more than 50%. In addition to that, signs and symptoms of heart failure are present. There is some structural and functional abnormalities in the heart. So basically, heart failure is divided into these three types depending on the ejection fraction. Heart failure less than 40% is heart failure with reduced ejection fraction. More than 50% is heart failure with preserved ejection fraction. And between 40 to 50% is heart failure with mildly reduced or mid-range ejection fraction. And we know the causes, basically the cause of heart failure with preserved ejection fraction is what was previously called diastolic heart failure. But one should understand that diastolic heart failure is not synonymous with diastolic dysfunction, which is a normal process of aging, is not synonymous with heart failure with preserved ejection fraction. Heart failure, diastolic dysfunction is usually always present in patients who have heart failure with reduced ejection fraction. And diastolic heart failure or diastolic dysfunction need not be associated with symptoms initially. So any problem with the heart which causes prevention of relaxation, hypertension, impaired relaxation in diastole will result in heart failure with preserved ejection fraction. The various causes have been listed out here. But what is very important to understand is that heart failure with preserved ejection fraction, as I've just said, is highly under-recognized and undiagnosed. One should realize that more than 50% of patients who have heart failure with preserved ejection fraction. And more than 50% of patients who have heart failure with preserved ejection fraction have more than 5 comorbidities. So it is associated with multiple comorbidities. And what are these comorbidities? Hypertension, diabetes, chronic kidney disease, atrial fibrillation, anemia, coronary artery disease is present in heart failure. More than 50% of patients have more than 5 associated comorbidities. Another very important feature is that heart failure with preserved ejection fraction outcomes. People tend to believe that heart failure with preserved ejection fractions have better outcomes as compared to heart failure with reduced ejection fraction. That is a myth. That is a myth. Patients who have heart failure with preserved ejection fraction actually have similar prognosis of patients who have heart failure with reduced ejection fraction. And it is therefore very important that we need to diagnose heart failure with preserved ejection fraction early so that intervention can be started, and accurate and proper diagnosis therefore becomes critical to improve prognosis. And as I've just repeatedly said, that heart failure with preserved ejection fraction is not synonymous with diastolic dysfunction. There is a simple 3-step diagnostic pathway for diagnosing heart failure with preserved ejection fraction. Signs and symptoms of heart failure should be present and an ejection fraction of more than 50%. And there should be an objective evidence of a structural and a functional abnormality of left ventricular dysfunction and raised left ventricular filling pressures, including increased natriuretic peptides. We can skip these slides. We always know that one of the important cardiac biomarkers for diagnosis of heart failure is BNP, which was previously called brain natriuretic, but is a misnomer. It's a B-type natriuretic peptide, which is secreted from the left ventricle because of a left ventricular failure. It has both diagnostic and prognostic implications and very high utility in diagnosing a patient who presents with breathlessness to know whether it is because of heart failure or lung disease or other cause becomes very important because it has a very high negative predictive value, which means if your BNP is normal in a patient who presents with breathlessness, you could, or acute onset of breathlessness, you practically ruled out heart failure. But one should understand the pitfalls in heart failure with preserved ejection fraction. Though it has a high negative predictive value, in heart failure with preserved ejection fraction, nearly 20% of patients of heart failure with preserved ejection fraction will not have elevated BNP. There will be a number of reasons quoted for it, and one of could be because of obesity. In obesity, the BNP levels are disproportionately lower than thin people. So normal BNP in an emergency setting actually rules out heart failure, but would not definitely rule out heart failure because due to preserved ejection fraction. And BNP levels actually go on increasing. That's what the prognostic indicator, that it goes on increasing as the NYHA class, functional class, increases. Other tests like myocardial biopsy is rarely needed in heart failure, but sometimes for the diagnosis of heart failure with preserved ejection fraction, one may require more rarely would require some more advanced investigations, hemodynamic studies, and exercise echo may sometimes be indicated, but otherwise they can be done clinically diagnosed. Endocardial biopsy is very rarely needed. We know this is a very important slide that stage A is patients who are at high risk. They have simply diseases like hypertension and diabetes. Pre-heart failure stage B, which have structural heart disease but no evidence of heart failure. Stage C is when they have symptomatic heart failure, and stage D is when they have a refractory heart failure. Now, there are various causes for risk factors for development of heart failure with preserved ejection fraction. Increasing age, as I've already mentioned, heart failure as such increases as age advances, but more so heart failure with preserved ejection fraction. Gender differences, females are in fact having 2 times the prevalence of heart failure with preserved ejection fraction as compared to males. Diabetes, obesity, obstacles, obesity causing sleep apnea, hypertension, COPD, and all sorts of other diseases are risk factors for development of heart failure with preserved ejection fraction. Let me quote a study in which I participated called the Inter-CHF study, which was conducted in India as well as in Africa, Asia, and other Middle East countries. In India also it was conducted. It was conducted in my center, not at AIIMS but in government medical college. In India we had 850 to 58 patients. What is very important that ischemic heart disease, hypertension, and other causes are important, but even in India, nearly 7 to 8% have got valvular rheumatic heart disease as a cause. Coming to the treatment of heart failure, there has been a paradigm change in the management of heart failure. Way back through 3 centuries ago, it was bloodletting which was considered panacea for all treatments, including heart failure. And very strong statements there that bloodletting is the least equivocal remedies. It's good evidence when properly administered. In most cases, so immediate and striking, such were the confidence in which bloodletting was thought to be a panacea for all illnesses. And then in the early 1980s, we had digoxin and furosemide. When I was a resident, we just treated patients of heart failure with digoxin and furosemide. And we know that 2 to 3 centuries ago, when William Withering, riding on his horseback, used to give foxglove to patients who had dropsy, epidemic dropsy, who had edema feet, not knowing that they had heart failure, that they improved. Unfortunately, this drug, which has been there for ages, if it is subjected to the randomized control trial now, would not fail the tests of randomized control trial. It has been relegated to 2B indication. It has gone back, though it was a first-line treatment previously. We had only that to treat at that time when we were residents. So digoxin, because it has got a lot of side effects and because the therapeutic and the toxic ratio is very less. Now, if you look at what has happened in the history in the treatment of heart failure, heart transplantation is the ultimate treatment, and we know that our first heart transplant was done by Christian Bernard way back in the 1967 in South Africa. We always thought that now the treatment of heart failure would be heart transplantation. It is still not picked up. So what is important that what paradigm changes have occurred in the treatment of heart failure is not surgical, but medical. And standard therapies like angiotensin receptor neprilysin inhibitor ARNI, ACE inhibitors, ARBs, beta blockers, SGLT2 inhibitors, mineralocorticoid receptor antagonists have been shown in the last 3-4 decades, last 2 or 3 decades, by well-conducted randomized controlled trials to improve survival in heart failure. I remember in early 90s and late 80s, ACE inhibitors came, and it did make a difference in the management of heart failure. Then came ARBs. Beta blockers, which were considered contraindicated when I was an undergraduate and a postgraduate, not to be used in patients of heart failure. And 3 drugs, bisoprolol, metoprolol, carvedilol, have actually shown that the excessive compensatory sympathetic activity which occurs, stimulation which occurs as a compensatory mechanism in heart failure is ultimately deleterious. And beta blockers have been definitely shown, these 3 which I am talking about, to improve survival in heart failure. Very recently, SGLT2 inhibitors have emerged a very important drug in the management of heart failure. Not only of heart failure with reduced ejection fraction, but heart failure with preserved ejection fraction. Even mineralocorticoid receptor antagonist, if you remember the first trial, the real study which showed that spironolactone worked, improved survival in patients who had heart failure with reduced ejection fraction. The FSS study which actually showed eplerenone improved survival in heart failure. These are all mineralocorticoid receptor antagonists. And very recently, the fine art study, that is the finerenone, actually showed improvement not only in heart failure with reduced ejection fraction, but also in patients with mildly reduced and preserved ejection fraction. So there have been a lot of advances in the management of heart failure, especially which is medical and not surgical. Now, if you see the 2-year mortality, which not very long back in the 80s, when only digoxin and furosemide were used, was quite high. And the 2-year mortality with the introduction of such life-saving medications has come down to 5%. 3 years mortality in 1985, reduction from 35% to 67%. This compensatory mechanism, and one of the recent important compensatory mechanisms is the activation of the natriuretic peptide, on the basis of which ARNI, that is angiotensin receptor blocker, and neprilysin inhibitor have been shown to improve survival over and above the use of ACE inhibitors and ARBs. So natriuretic peptide and the development of ARNI and the mechanisms are very clearly shown here, that how they improves the survival. ARNI, that is the paradigm study actually showed that this is very useful, especially in heart failure with reduced ejection fraction. I think with paucity of time, there are various scorings. We'll go through this. I'll skip this slide. One should understand that there are a number of factors which precipitate heart failure, and when you manage heart failure, before labeling a patient as having heart failure refractory, it's very important to find out these factors, treat them, otherwise the patient's heart failure will never get cured. So coming back, general measures are equally important. These drugs, as I've just mentioned, have been shown to be very useful in patients who have NYHA class 2 to 4, which means symptomatic patients, in heart failure with reduced ejection fraction, ACE inhibitors, ARBs, ARNI, SGLT2 inhibitors, beta blockers, and mineralocorticoid receptor antagonists. diuretics in patients who have reduced ejection fraction, but now I'll concentrate more. Digoxin, nitrates, and device therapy, these are some things. And so because of this number of clinical trials conducted since 2021, lot of trials. The Emperor Preserved study, which used empagliflozin in patients with heart failure with mildly reduced or preserved ejection fraction, actually showed that it improved the composite endpoint of hospitalization due to heart failure and death. Similarly, another study, the Deliver study and Preserved Heart Failure study, showed similar results. Unfortunately, the drugs which have been shown to improve survival in heart failure with reduced ejection fraction, like ACE inhibitors and ARNI, have not been shown to be useful in patients with heart failure with reduced ejection fraction. A number of trials have come for that also. So we have management of heart failure with reduced ejection fraction, with mid-range ejection fraction, for preserved ejection fraction. And for preserved ejection fraction, I'll just concentrate. The SGLT2 inhibitors, which were basically first came into the market for patients of diabetes, because it prevents the absorption and reabsorption of glucose and causes glycosuria. But it also reduces the absorption of sodium and therefore helps in treatment of hypertension, and also acts as an osmotic diuretic and therefore useful in patients of heart failure. Now, SGLT2 inhibitors have now been approved for all types of heart failure, whether it is heart failure with reduced ejection fraction or heart failure with mid-range ejection fraction or mildly reduced, or with heart failure with preserved ejection fraction. For heart failure with mildly reduced ejection, for reduced ejection fraction, they have class 1A indication. For mildly reduced ejection fraction, again a class 1A indication. And for preserved ejection fraction, it is a class 2A indication. And I'll tell you why these reasons for that. So for the treatment of heart failure with preserved ejection fraction, diuretics are used as and when they form the cornerstone in the treatment of heart failure with preserved ejection fraction. Next comes SGLT2 inhibitors for patients with ejection fraction more than 50%, and the class of recommendation is 2A and not 1A. Reason being is that if you see mortality benefits independently have not been shown in clinical trials, is a composite endpoint of worsening of heart failure, hospitalization due to heart failure, or death due to heart failure. This was reduced. But if you analyze only the death, it was not shown to be improved. It was mainly worsening of heart failure, and therefore it's still a class 2A indication. Other drugs are there, mineralocorticoid. So this is SGLT2 inhibitors, class 1A in heart failure with reduced ejection fraction. One of the, I can skip this slide because it shows some of these advantages of SGLT2 inhibitors are tremendous. It means it doesn't cause, it is useful in patients for treatment of diabetes. It does not cause hypoglycemia. It causes loss of weight. It decreases the blood pressure. It acts as an osmotic diuretic and therefore improves heart failure. But then it is known to cause some side effects, which was called euglycemic. With a normal glucose levels, patient can go into ketoacidosis. And patients with type 2 diabetes who have a history of diabetic ketoacidosis, these drugs should be used with caution. But these drugs, number of good randomized clinical trials have actually shown that these medications have been used to reduce body weight and also useful in patients of heart failure, especially in patients of heart failure with preserved ejection fraction. They are again class 1A indication in patients with heart failure. Other drugs also are class 1A indication. I'll just say a couple of trials. Emperor Preserved, which showed actually, and again the Deliver study, which again was done in patients who had an ejection fraction more than 40%. Very important study, both of them, and also Preserved Heart Failure study, which actually showed both empagliflozin and dapagliflozin improved the endpoint of worsening of heart failure and decreasing hospitalization due to heart failure and that this composite endpoint was decreased in significant studies. And therefore, empagliflozin is approved for heart failure, any type of heart failure with any ejection fraction. Another very good is the mineralocorticoid receptor antagonist. And when spironolactone was tried in heart failure with preserved ejection fraction in TopCat's trial, the results were not encouraging. It was a negative study indicating spironolactone actually does not help, which is a mineralocorticoid receptor antagonist. But a newer MRA, which is finerenone, in the fine arts study, actually showed that it was a positive trial showing benefit of finerenone in heart failure with preserved ejection fraction. And what is finerenone is basically a non-steroidal mineralocorticoid receptor antagonist, and it is devoid of the side effects of spironolactone which is known to cause impotence and gynecomastia. These are not seen with this, and it has been shown to improve useful in patients who have heart failure with preserved ejection fraction, and it reduced cardiovascular death, total worsening of heart failure events over a median follow-up of 32 months in the fine art study. And that is finerenone has been found to be useful in heart failure with preserved ejection fraction. These are some of the other results, and I will not go into the details. Arni, Paragon heart failure, negative study in heart failure with preserved ejection fraction, whereas in heart failure with reduced ejection, fantastic results. So non-pharmacological measures are very important. What is most important in heart failure with preserved ejection fraction? Because there are multiple comorbidities associated with heart failure with preserved ejection fraction. And it is this multiple comorbidities which are associated with a pro-inflammatory state, which causes increase in resistance of the left ventricle to relax, and therefore cause diastolic dysfunction, and which leads to heart failure with preserved ejection fraction. And therefore, this treatment and management of all these comorbidities which are associated essentially with as the age advances. Now, if you ask me, hypertension, does the blood pressure increase with age? Everyone would say yes, it increases with age. But if you really look into details, it will find that the rise of blood pressure which occurs with age is neither physiological nor is it inevitable consequence of aging. And it is essentially, if you take the blood pressures in the primitive uncultured societies, like Adivasi people who are living in Gadchiroli, which is very close to Nagpur, or if you take the blood pressures in the Pima Indians in the US or the Aborigines in Australia, the blood pressure does not rise with age. The rise of blood pressure with aging, which occurs in rural population, is much less than what occurs in the urban populations, indicating that the rise of blood pressure which occurs with age is essentially driven by lifestyle changes rather than as a physiological. As we grow old, a lot of physiological changes occur in our bodies. Our hairs gray, prostate enlarges, a lot of other changes. But the rise of blood pressure with age is not considered, it's considered to be driven by lifestyle changes. So it's very important that when you treat heart failure with preserved ejection fraction, equal importance is given to all the other comorbidities which are associated. So treatment of atrial fibrillation, treatment of hypertension, treatment of diabetes and chronic kidney disease is equally important in treatment when you want to treat. Now again, coming back to the results of this study which we published, is the InterHeart study which actually showed that in heart failure, the class 1A indication, the drugs like ACE inhibitors, ARBs, beta blockers, aldosterone inhibitors actually have a class 1A indications which have proven benefits in saving lives of patients of heart failure, improving their survival. These drugs are not used in optimal doses in majority of the patients. For example, beta blockers usage in this study actually showed that it was used only in 56% of patients of heart failure, and in optimal doses which have been shown in the clinical trials to improve survival, only 35%. indicating that we know what we need to do to improve survival in heart failure. But if you go to the public, go to practical in the real world scenario, not much is being done what should have been done. So there's a persistent gap in what is done and what can be done. So the poor, I'm just waiting last slide. Poor prognosis despite advances in we know prognosis of heart failure is very poor. 30 to 40% die in 1 year, 60 to 70% die in 5 years. And heart failure, in fact, is more common. It has a higher mortality than cancer. Despite that, we fear cancer so much, not heart failure. So heart failure is one, and then therefore the need for setting up cardiac rehabilitation centers, improving the heart transplant centers, setting up more heart failure clinics all over India, which would help in usage of beneficial medicines which have been shown in clinical trials to improve survival, to improve the prognosis in patient of heart failure becomes very, very important. Thank you very much.
Thank you, sir, for a very nice talk. Now it is open for discussion. We'll invite 1 or 2 questions. Yes.
Okay, thank you, Dr. Joshi. So, you have covered all the newer drugs. But one thing I want to ask you regarding you have told this obesity, diabetes, sleep apnea, these are very high risk factors leading to obesity, type 2 diabetes, sleep apnea. These are all risk factors for heart failure with prejudice infection, diastolic dysfunction. But one more molecule has been tried already, that is GLP-1 receptor agonist, semaglutide, in STEP trial, that has shown that the quality of life, the symptomatic improvement, all are improved. Also the weight reduction, everything is improved in case of obesity with heart failure and prejudice infection. So I think that is one more molecule, because you have covered 3 pillars. So we can add the 4th pillar also.
Yeah, but then GLP-1 analogs, tirzepatide are basically treatment of diabetes and treatment of obesity. So obesity management to prevent heart failure, especially heart failure with preserved ejection fraction, is very important. Thank you very much for a good comment. Any questions? Right. I think let me thank Dr. Ashutosh Biswas and the Executive Director for inviting me, and also Dr. Day and Dr. Mohanty for inviting me here to deliver this talk over here. And it's a great opportunity. I'm coming to AIIMS Bhubaneswar for the first time, and I've enjoyed. I would like to visit and see the other place and how we can take, because AIIMS Bhubaneswar is 8 years elder to us at AIIMS Nagpur, and let us take the good points which are there from here so that I can implement it there. Thank you very much for calling us.
Thank you, sir.
The last speaker of this session is Dr. Sanjeev Kumar Bhoi. Now he has about 140 standard publications, and he is a neurologist. He is now head of the Department of Neurology of this institute. Before coming to this institute, he was working in SGPGI, Lucknow, and he has got a member of many of the neurological societies, as well as he is a reviewer of many of the neurological journals. You can read out them, but before telling that, I personally know him because he was doing PG in my own unit at SC Medical College, Cuttack. He is a very sincere boy, and he is very soft-spoken, very well-mannered, and all the adjectives are possible. And he told that when he joined here, he was a single man in the department. Now he has grown the department to some extent. And on his behalf, I can request the director that he is so soft-spoken that he cannot demand anything. He will just request, sir, please give me something. Though it is his demand, but he will just go and request. So I think the director will take notice of his manner and sanction whatever, and whatever you give, he will give in return. He will not misutilize the things. That confidence I can give because I have been associated with him for 3 years. Now Dr. Bhoi, I request him to tell his, speak his talk, and it is on neuromyelitis optica. And about the topic, in fact, I do not know much about things. When our students we ask, what are the demyelinating diseases? Say multiple sclerosis, neuromyelitis optica, ADEM, all these things. And whatever we have seen, most of them are ADEM. But he has got a spectrum of manifestations of neuromyelitis optica. That is what he is going to tell. Dr. Bhoi, please.
Thank you, sir. Respected director, sir, my teachers, seniors and friends. So, post-lunch, I have given the demyelinating topic. So, let's see how we can solve this problem. So, earlier in 20 years before, when I was a MD resident, only one thing in central demyelination, that is MS. If it is not MS, then ADEM. Another entity was the Indian MS or Indian myelitis. We cannot prove that whether it's a NMO, MOG, so we say it's a transverse myelitis of unknown etiology. So basic teaching was that MS or no MS. If no MS, ADEM, spinal cord, transverse myelitis. So demyelination was over in central nervous system. Peripheral, we know GB syndrome, CIDP, many things. So let's see how in last 20 years it has evolved and in last 2 years. So this is the brief mode of presentation. So coming to the NMO or the Devic's disease, it was the French scientist Devic, from which it was coined, predominantly affect the optic nerve, the spinal cord, and now it is called the brainstem disease also. Neuromyelitis optica means it's the myelitis and the optic nerve. But now we are including the third component, that is the brainstem signs. Second component is the whether it's aquaporinopathy or a aquaporin negative NMO spectrum. If it is antibody is positive, pretty sure that you are dealing with a NMO disease with aquaporin positive antibody. NMO without aquaporin is a NMO spectrum disorder containing the aquaporin negative spectrum. So this was the Devic. Actually, his student, he has done the thesis on the NMO spectrum disorder. At that time it was not NMO spectrum, the myelitis with optic neuritis. When Devic presented his work, same year he has published the thesis, his student, Gault. People thought that whether Gault was the pioneer for Devic's disease or the Devic's per se has coined, or he was given the honorary, the name of Devic's disease. There was no further publication of Gault in subsequent 10 years regarding the NMO spectrum or the Devic's disease. And one thought was there in the literature, the in charge of the thesis in France, he was more in favor of this entity, the nomenclature. Probably they thought that he has coined this entity Devic's disease or the neuromyelitis optica, and it was given to the author Devic. So coming to the how it has progressed in the last almost 20 years, the disease came in around 2006 when the consensus guideline came. Prior to that, the antibody was there, but it was only for the research purpose. Clinical diagnosis came the last 1 decade or 1.5 to 2 decades, and we are now easily you can now go ahead with the diagnosis of NMOSD. Coming to the right side, this is the MOGAD, another entity called myelin oligodendrocyte glycoprotein antibody. So these are both brother and sister. Once you diagnose NMOSD, aquaporin positive, confirm aquaporin disease NMO. If it is negative, either it may be ADEM, MS is ruled out. Why I rule out, I will say in subsequent slide. Next is close diagnosis is the MOGAD. So coming to the MOGAD and NMO, there are two spectrum of the disease. Pathologically they are different. Clinically they mimic same. Outcome is different. So whenever you are getting NMO negative, run for MOGAD. MOGAD came after almost 10 years after the NMOSD. So this was the last, because the topic was given was the update in NMOSD. So 2023 paper came in J Neural, the diagnostic part 1, and the therapeutic part came in 2024, the part 2. In detail, they have given all the how to diagnose, what are the pitfalls or the red flag. I am coming one by one. So NMOSD, you have to diagnose by the core clinical criteria. So if patient comes to your OPD, 2 cardinal symptoms should be there, minimum. One is the optic neuritis, second is the myelitis. So optic neuritis is how is common in the NMO? It may be unilateral, may be bilateral. In MS, it is unilateral. In MOGAD, it will be most commonly bilateral. In NMOSD, most commonly is unilateral, but may be bilateral. So coming to bilaterality, MOGAD is first, second is NMOSD, and singular is the MS. Acute myelitis, paraparesis, quadriparesis, area prostroma syndrome. So there is an area in the brainstem. If there is a lesion in that area, it will produce some vomiting-like symptoms, nausea. That is called area prostroma syndrome. Acute brainstem syndrome. Other area like the narcolepsy, if the thalamus is involved because of NMOSD, then the patient will be having increased sleepiness. And acute cerebral syndrome. So out of these 6 criteria, if one is positive, clinically, the core criteria should be either optic neuritis or myelitis with antibody positive. Pretty sure you are dealing with a aquaporin positive NMOSD. If aquaporin is negative, then you have to require 2 core clinical criteria, at least optic neuritis or myelitis or any other thing. So these are the Wingerchuk criteria 2015, which are following now. So how the optic neuritis is diagnosed? It should be extensively long optic neuritis. Because in MS, it's a unilateral and small area optic neuritis. But in case of NMO and MOG, they are pretty extensive or long segment optic nerve. Optic nerve is 4 centimeter. If it involves more than 2/3 or more than half, then it is more in favor of a NMO or MOG. If it is small segment, MS. Unilateral, MS. Myelitis should be LETM, longitudinally extensive transverse myelitis, not a short segment. What is longitudinally extensive? More than 3 vertebral heights should be involved. More than 3. Short segment is MS, long segment is LETM, is NMOSD or MOG. Area postroma syndrome, the dorsal medulla. Other brainstem syndrome, the periappendymal, because NMO, it is the aquaporin antibody, IgG, it is located in around the periventricular space, around the CSF spaces. So most common area is around the 4th ventricle, 3rd ventricle or the periventricular lateral ventricle. Other is the diencephalic syndrome, as said by the thalamic area involvement, and the cerebral syndrome, less likely. So this is the diagnostic criteria. At least one with antibody positive, you are pretty sure you are definitive NMOSD. If NMOSD negative aquaporin, then you have to take 2 clinical criteria and other syndrome. Coming to the MOGAD, slightly busy slide, but you have to understand how to differentiate NMOSD versus MOGAD. If you are getting antibody, okay, very good. Suppose you are in a setting where you are not able to get the antibody, how to diagnose, whether they are clinically NMO or MOGAD. Clinical one thing, same may be there, but imaging will help to guide whether you are dealing with MOGAD or NMO. In case of clinical syndrome, the vision loss will be more severe in case of NMO, less severe in case of MS. Equally in case of MOGAD. So vision loss severe, first is the NMO, second is the MOGAD. Less vision loss, MS. Second is the myelitis part. LETM both will be there, NMO and MOG. MS out, small segment. But coming to the positivity of the MOGAD, if you are getting a clear positive, so how to do the clear positive? It should be the cell-based assay, not the ELISA or the RIA method. Here in all the local laboratories, they do the RIA or ELISA. So it's not sensitive to detect the NMO or aquaporin or the MOGAD. So always do the live cell-based assay or the fixed cell assay. That is the standard recommendation by the consensus criteria. If they are positive, okay, you are getting MOGAD. Coming to the other brainstem syndrome, same like NMO, myelitis, long segment, optic neuritis, okay. Second point is the optic neuritis, the anterior pathway of the optic nerve, that is suppose 4 centimeter from the retina to the chiasma area, it is 4 centimeter. The anterior portion will be more involved in case of MOGAD. So you can get in the fundus, you will get a papilledema. But in case of aquaporinopathy, the posterior part of the optic nerve is involved, the chiasma area, the posterior part. So you may not get papilledema. So it is a retrobulbar neuritis, the eye finding may be normal, vision loss will be there severe. In case of MS unilateral, mid segment will involve, there may not be papilledema. Papilledema, MOGAD, posterior part in MRI, severe vision loss, each case you are dealing with NMOSD. So again coming to summarizing this NMO versus MOGAD, if it is positive, NMOSD aquaporin, negative NMOSD, and last column is the MOGAD. So because you have to cleanse the diagnosis clinically, many times we may not get the antibody positivity. So these are the differential diagnoses. All the diseases in neurology, the last line is rule out other causes. So in the other causes, there is a huge list is there, including all inflammatory, malignancy, vasculitic, and the other stroke-like illness. So the GFAP, this is the now entity coming, last but the fourth one. In case of NMO negative aquaporinopathy or NMOSD without aquaporin antibody, there the GFAP is very high and they behave separately. This is a new entity now coming. So in that case, the glial fibrillary acidic protein is there. In the CSF, it is very high. Then this is a special entity and they are very poor prognosis. Other differential are infective like viral myelitis, syphilis, borreliosis. It can mimic like NMOSD. Neoplastic vascular can mimic the NMOSD. So these are the differential diagnoses by genetic and metabolic causes. Vitamin B12 all can present like a myelitis and optic neuritis. Other are REST ICP, leukodystrophy rarely. So coming to this slide, this is the time scale. If you are getting a chronic illness, and this side the acute, hyperacute illness. Hyperacute is the vascular phenomenon, or acute vasculitis or pulmonary myelitis. The mid portion is the NMOSD, MOG, and they can further progress in case of paraneoplastic myelopathy or optic neuritis. So coming to the red flag, progressive syndrome, more in favor of MS, very acute, MOG and MO. But not all acute are MOG and MO, less than 4 hour vascular. It should be more than 4 hours to 28 days. Demyelination episode we diagnose clinically by should be more than 4 hours, onset to peak time to up to 28 days. If the worsening continues more than 4 weeks, you are dealing with something more inflammatory like sarcoid or something neoplasm. Partial myelitis, not long segment, you can consider MS. Last is the aquaporin IgG sensitivity. If there is positive, then it is pretty well. The other antibody, now the lab are doing IgM, IgA. No, these are not required. Only IgG is required. If they are positive without IgG, so it cannot be case of definitive NMOSD. Double positivity, so this is a new entity coming. 2 years before, while we were taught that if you are getting antibody of aquaporin, MOG cannot be positive. But now the entity is coming that both can be positive also. But they are giving a caution that you have to repeat again with a different method. Presence of CSF, OCB, more in case of multiple sclerosis, less in case of NMO. Presence of other viral antibody like measles, rubella, varicella can be seen in case of more in MS as compared to the NMOSD. Other red flag in case of MRI, because MRI is the main guider for the diagnosis of MS and NMO. If the MRI is featured in favor of MS, okay, MS. Sometimes we will get the periventricular lesion, may not be Dawson like finger like MS. So we have to take the account whether you are dealing with a more of a MS or more of a NMO. If the lesion persists more than 3 months, enhancement is there, suggests that it can be a NMOSD or a MS. Another thing is that contrast is not essential for the diagnosis of NMOSD or MS. MS, it is helpful, but the thing is that we advise for a contrast study because that will rule out many things. Second is that whether that lesion is an acute lesion or a chronic lesion. The contrast enhancement say it is an acute lesion. If there is no enhancement, then you can say pretty old, it is almost 28 days old lesion. So it is not a mandatory for contrast in the diagnostic criteria, but it is essential to do contrast study. Sarcoid is a good mimicker of NMOSD, and other are the malignancy and chronic infection. Coming to these 3 disorders that I said, aquaporin, NMOSD, MOGAD, multiple sclerosis. Gender-wise, female are more predilection for the NMOSD, almost 9:1 or 10:1. But MS is also more in female, but MOGAD is equal male and female. Children, more than 50% of ADM are MOGAD. But in adult, it can be MOGAD, can be aquaporin. Optic neuritis, it's unilateral, more severe in case of aquaporin NMOSD, less in case of MS. In between is the MOGAD. Area prostoma syndrome, I will discuss a case that is classical of aquaporin NMOSD. CSF, you can get some pleocytosis around 50 to 100 cell, nothing to worry about, and the protein will be high because of the inflammatory response. The optic neuritis, here the problem is that it is more severe and the outcome is very poor. So unless you treat hard and early, in case of aquaporin NMOSD, the vision loss is irreversible. In case of MS, MOGAD, they can be reversible. So if you are diagnosing a case of aquaporin, not treating means you are challenging the patient for a permanent blindness. Second is the myelitis, because they are more severe form, so the recovery is very poor in case of aquaporin as compared to MOGAD and multiple sclerosis. So our aim is that we should not miss an MOSD or aquaporin positive as compared to the MOGAD or MS. Here we will be more lenient, but in case of NMOSD, big causes, if you miss, patient will be disabled. Coming to the imaging characteristic, so these are the imaging finding in case of the upper panel is the NMOSD aquaporin, middle is the MOGAD, and last is the MS. As I said, the optic nerve part, here this area, in case of NMOSD, the tract part and the chiasma area will be more involved. Here more anterior part, so papilledema will be there. Here it will be pachyfocal small segment. And same thing we can get in the MRI. So people do MRI of the orbit without doing the brain. The ophthalmologist outside they do the MRI for vision loss, and that MRI is not classical. What to be done? It should be T2 and a T1 clear sequence with a thin section. Without that you cannot see. And the section should include the optic chiasma part. Coming to the myelitis part, in case of NMOSD, it's a long segment, involves the gray matter and the white matter. You can see the central gray matter is involved in case of first column, that is the NMOSD. MOGAD, it is S-separate, predominantly the gray matter. MS, partial pachyfocal. Here it will be only the white matter tract, lateral column will be more involved as compared to the other two where the more the gray matter is involved. Another thing is clinical is that quadratus coni will be more common in case of MOGAD. The patient will have erectile dysfunction, urinary problem more as compared to the other two. And the recovery of this area is not well as compared to the optic nerve or the myelitis in case of MOGAD. So these are the classical MRI finding in case of aquaporin, MOGAD or MS. The long segment will be there, and the lower panel is the axial section showing the transverse section as described above. So the book picture is like that, and this is the picture we will get in case of MRI. Coming to the brain part MRI, the first panel is the aquaporin. You can get the around the periventricular and the third ventricle, fourth ventricle area, you can get the aquaporin, more deposition of the water molecule. So we will get the antibody there, reaction will be more. In case of MOGAD, it can involve any part of the brain, including the gray matter, thalamus, white matter. MS is classical of the white matter disease. So this is the picture of the NMOSD, MOGAD and the MS. Coming to the management, once you diagnose, how to manage. So acute attack, any patient coming, so you have to give the methylprednisolone. High dose, 1 gram, 3 to 5 days. Acute part taken care. By the time you have to send the sample, it will take some time to get the report. If high suspicion of either you are getting a NMOSD, the report comes, go for plasma exchange. The role of IVIG, they do not recommend IVIG for aquaporin NMOSD. But in India, they follow the IVIG because the plasmapheresis is not available everywhere. But the guideline says methylprednisolone followed by plasma exchange quickly. There should not be any delay. Suppose the patient will improve with only methylprednisolone significantly, we can delay the plasma exchange. But that decision is very dicey. A patient of severe myelitis, severe vision loss cannot improve with methylprednisolone on day 2 or day 3. So if the improvement is less than 50% and by the third day, start plasma exchange. In case of aquaporin negative, the last line you can see, start the immunotherapy after the first attack in case of positive, in second attack in case of negative antibody. You have to wait for the second attack. So what are the points in case of treatment? Time is cord and eye. So if you delay, cord is gone, patient is blind. So Plex should be quickly, plasma exchange should be started. IV methylprednisolone plus Plex, first line standard treatment, rather than only IV methylprednisolone and waiting for the second attack or the non-response. Initial IV methylprednisolone 5 days of onset of optic neuritis, as early as possible you should start. Initiating Plex as early as possible, and you can delay up to 90 days also. So if some patient comes after 1 month, still you have to give some chance that the patient may improve. Not that he has come late, so you should not give the Plex. But here they also caution the patient, no, as the disease has already progressed, the chance of recovery may not be as better as the early institution. Long-term therapy, suppose you have given the acute part, how to behave, whether the patient will recover again or there is no recurrence. Let's see. Guideline says, in case of aquaporin positive NMO, treatment is lifelong. Very difficult to say. Earlier, in the last 3 years, we are discussing in the demyelinating forum, they said 2 years. Now they are telling 5 years. But books say almost it may be 5 years in some cases also. So up to 5 years you have to give the long-term immunomodulation. So what are the drugs available? So the MAPs are coming now. Western literature say give MAPs, but in India we are not getting MAPs. And the cost is very high. The cost of the approved MAPs are more than 10 lakhs. So we cannot offer this to the all patient. So we can try with other which are available drugs here. Last line is the for Indian population, azathioprine or mycophenolate plus oral steroid low dose. That is the bread and butter for the MS, NMO, MOG. In case of double negative, MOG negative, NMO negative antibody, then you have to start rituximab, mycophenolate or azathioprine. So coming to the rituximab, it is not approved by the US FDA. So if you give in US rituximab to NMO, the insurance company will not repay that thing. But in other areas it is easily available, so people prefer rituximab as compared to the other monoclonal antibody. So the protocol is that intravenous methylprednisolone, residual disability will be there, plasma exchange as quickly in case of NMOSD as compared to the MOGAD, steroid sparing, start quickly. Coming to the long-term prognosis, you have to start the monoclonal antibody. So these are the ravulizumab. Eculizumab is already available in India, but highly costly. And the B cell, that is the rituximab. So these are the approved drugs. These are the established drug, but off level where the rituximab comes. And this is the under-evaluated drug, and that is now in the pipeline. So coming to the Indian setting, the standard is azathioprine, the standard dose, mycophenolate, rituximab. When to start azathioprine or MMF or rituximab? The guideline says that start MMF or Ritux whenever possible. Use azathioprine whenever MMF or Ritux is not available. When to switch over azathioprine MMF to rituximab? If there is a relapse is there on these two drugs, azathioprine MMF, or two relapse or more than one severe relapse. So you can give a chance that second relapse. But a patient of NMO having severe blindness, untreated, you have to take the chance depending upon the other scenario. These are the prerequisites for rituximab, the standard for any of the immunosuppression. Contraindication, active infection. So these are the dose for rituximab. We give 1 gram, followed by after 2 weeks another 1 gram, followed by every 6 monthly. Sometimes they say do the CD19 because CD20 is not available, but in other rheumatoid disease they do not do ever CD19. But here they say have to do the CD19. If the CD19 is 0.05 or more is rising titer, then you have to give the dose, otherwise you can wait for the another 6 months. These are the newer drugs. Now in the case, so this is the first case, 21-year female, recurrent deficit from the age of 8 years. Here the patient came at the age of 21, but the disease started at the age of 8 years, that's very early. What are the findings? Bilateral optic neuritis, vision loss, and long segment myelitis, cervicodorsal area involving the lower limb and the upper limb. And there is additional seizure is there. Because in demyelinating we say it's a white matter disease, seizure will be not there. There should not be dementia because there is no grey matter involvement. That is the standard teaching for MS. But aquaporin, MOG, they can have grey matter, so they can have seizure, they can have dementia. So this was the timeline of this girl. From the 2001, she started throwing some neurological deficit till when she came in 2024 last year. So initially she was managed as a case of multiple sclerosis, childhood variety, by multiple physicians, and her disability accumulated gradually and became EDSS 7, means almost she was dependent with the family member. What was the vision? PL negative, totally blind bilaterally. When she became blind? After the 2 years of the onset of illness. So the deficit was severe, and the 2 minutes. So PL negative. So we thought we have to send again for the antibody, and it was became aquaporin positive strongly. So in spite of 12 years of disease, the antibody was positive and patient was accumulating one by one symptoms. We have given the plasma exchange. The myelitis part improved, but the vision didn't improve because already there is a vision loss and the optic atrophy was there. This was the MRI finding of the patient, suggestive of in favor of aquaporin, and the optic nerve was thinned out. So last EDSS was 5.5, so she was slightly dependent because of vision loss. She was dependent for the family member. The seizure was well controlled. So landing point is the long course of NMOSD. After 10 or 12 years, that is having a recurrent neurological deficit. The case 2, 25-year female, she presented with acute onset optic nerve and myelitis with urinary retention. The power in the upper limb was better than the lower limb. Reflexes were brisk. So these are the MRI finding. Long segment myelitis. This is the axial section, and there is no contrast enhancement. Brain is normal. Diagnosis NMO MOG negative. So the problem is that we have challenge for the vision testing. So VEP was done showing 144 P100 latency, means quite prolonged. The standard is 107 to 112. Bilateral VEP is prolonged. So our clinical diagnosis was LETM holocord, subclinical optic neuritis, because she presented with only paraplegia or quadriplegia, no vision loss, but it was subclinical vision loss. So we favor seronegative NMOSD. Last, third case. So again 49-year female, myelitis with optic neuritis this time. Day 7 received IV methylprednisolone. The steroid was quickly tapered by outside doctor. Again came with the severe degree of vision loss. So this was the MRI. You can see the extensive optic nerve involvement on the right side is compared to the left side. Left side was normal, right side was optic neuritis. The MOG came positive. So I want to show that MOG will have a long segment and anterior path will be there. So she was given steroid and immunosuppression. So another study we have done, small study, whether the cognitive impairment is there in case of NMOSD or MOG. So this was our hypothesis, there is no literature. So we have done the cognitive battery test, FAB, lobar function, and P300 latency through the electrophysiology. Here you can see that MOGAD have more latency as compared to the NMOSD. So MOGAD has more grey matter involvement, more cognitive decline as compared to the NMOSD electrophysiologically, not clinically, because the number of patients are very less, 12 and 10. They are all antibody positive cases. As compared to the normal control, this is the decrease in the P300 latency prolongation. And the last case, this is an interesting case. Young lady vomiting, intractable dysphagia, hemiparesis. She was not managed by the outside hospital. Then we shifted to AIIMS BHUBANESWAR. Here the antibody became positive. She was having intractable vomiting and bulbar weakness. This was the MRI finding, area prostoma. As I am selling the poster part of the medulla, this is the area prostoma area. If you are getting a classical MRI picture, then it is pretty sure that we are dealing with the NMOSD. No need for the antibody. Antibody is required for confirmation. Let's see the video of this patient. So this was the baseline. She was in the Rayleigh's tube, bulbar weakness was there, the tongue was atrophied, unable to move, and there was a ocular bobbing. The eye, the first panel you can see the eye movement, sudden jerk followed by upward, and the chaotic movement is there. There is no intersaccadic interval. But after giving methylprednisolone, you can see the improvement within 2 weeks. And the tongue, now she can protrude also. Earlier she was not able to protrude the tongue. So to conclude, NMOSD to be diagnosed by the recent criteria. Don't follow the older criteria where there was no antibody. Early test for the antibody serum, not the CSF. If there is antibody negative, be cautious whether you are dealing with a negative variety or a MOG. MRI, CSF and other electrophysiology is essential. Never forget MOG and the vasculitis as the immediate mimicker. IV methylprednisolone flex with oral steroid tapering. In our setting, azathioprine MMF or rituximab. Newer antibody are available but are expensive. And this is evolving spectrum. In next 10 years, you will get another new antibody positive demyelinating disorder. So you have to be more alert and should be updated. Thank you.
Thank you, Dr. Bhoi, for a detailed discussion about a small topic, but very well discussed. Any of you, if you want to any clarification or any question from the audience? There is no question, so we declare the session to an end.
Thanks.
Sir, we would now request our chairpersons to please felicitate our speakers. I request the speakers for the session to please come on stage. Professor Dr. A.B. Dey, sir. Professor Dr. Prasant P. Joshi, sir. And Professor Dr. Sanjeev Bhoi, sir. Speakers. Chairpersons will be felicitating the speakers. We would request Professor Dr. Prasant P. Joshi, sir, to please come on stage, sir. I would now request Professor Dr. Anupam Dey, sir, Professor Dr. Rasmi, sir, and Devanand, sir, to please felicitate the chairpersons. Thank you, speakers and chairpersons, for such a magnificent session. Now we come to the last session of the day, which is on intensive care, nephrology and gastroenterology. To chair the session, I call upon the dais Dr. Manoj Kumar Chotrai, sir, Professor Dr. Sanjay Jagnin, sir, Dr. Santosh Swai, sir. I would request chairpersons to introduce and invite the speakers for this session. Speaker for the session is Dr. Bharat Pani, sir.
So welcome to this last session of this afternoon. I have the pleasure of inviting Dr. Bharat Paningrai sir for his talk on nephropathy, diabetic nephropathy. So every CKD patient who are above 3 or 4 stage coming to a physician, they opt, sir, will I require the renal replacement therapy as suggested by the nephrologist? So there a physician's perspective comes to role. So we have Dr. Paningrai sir to focus on that issue. Sir, please.
So friends, we will be discussing a topic which is very common nowadays. Every off and on we do come across this problem. So this is regarding current management of diabetic nephropathy from physician's perspective. So, as of now, this is a very important problem. Almost 30 to 50% of these diabetes patients, they do go for the DKD, and it only poses a significant threat to public health, but also is implication for both the economic growth as well as the development. But in recent years, we have improved a lot. We have come across a lot of molecules which help to at least stop the progression of the disease. So before I go, I will just get diabetic kidney disease, because why? There are some controversies with diabetic nephropathy and diabetic kidney disease. So the original terminology was diabetic nephropathy when it came decades ago, because that was in type 1 diabetes having retinopathy and that is more of albuminuria. So the terminology was given as diabetic nephropathy. But subsequently during these years, lot of changes has come, because type 1 diabetes, retinopathy, there is almost a concordance, 100%. Almost, if somebody in type 1 diabetes, somebody is having diabetic retinopathy, means he is also having diabetic kidney disease. But in type 2 diabetes, there is no such concordance. And so now the type 2 diabetes, even at the time of diagnosis, also can be having this diabetic kidney disease. Number one. Number two, there are almost 30 to 35% of the diabetic kidney disease, they do not have albuminuria. So taking all these heterogeneity, now the terminology has been changed from diabetic nephropathy to diabetic kidney disease. So how to diagnose? Because diabetic kidney disease is again a clinical diagnosis. You cannot go for kidney biopsy in all the patients. That is not indicated also. So it is basically a clinical diagnosis. So how to diagnose? You should define a urine albumin excretion more than 30 milligram. That is either you can have a measured by a timed collection, or what is the most important, we do usually the ACR, albumin creatinine ratio, more than 30 milligram, and decrease GFR less than 60, either or continuing for at least 3 months. And again, for 3 months you must do at least 2 to 3 times, because what happens in there are many other situations where you can have albuminuria for a very short time. So that has to be at least excluded. So minimum 2 to 3 times to be done within 2 to 3 months. And so if persist more than 3 months, then you will diagnose this case of diabetic kidney disease. So this is a slide, because this is being shown in every CME everywhere. But why it is being shown? Because you see here there are two things. There is the one on left side, there is the EGFR, and right side is the albuminuria. So taking in the both, that is why, because what our topic is in the clinician's perspective. So how long we will treat the cases, how long when we will refer the patients to the nephrologist. So we should think these are the very high risk category. So this dark red, these are the very high risk category. That's why that we have to take care of. So in those cases, even if we treat, we should also take the opinion of the nephrologist in the very high risk category. So this is only to risk stratify. Coming to so these are the updated KDO guidelines. So again, another thing, this is in 2025, one more that is the risk stratification has come, because we risk stratify in every cases, all the cardiovascular diseases we risk stratify. So here is also in March 2025 itself, KDO has published that how to risk stratify this question. Because when you see a case of diabetic kidney disease, EGFR is, suppose it is 45, so you have to stratify how long, when the patient is likely to go for end stage kidney disease. So here you can go with that. You see, if you just, this is the, you can go to the link below I have given, but here that's, you can see, it's not coming, it will not come now. Yes, what is it? এইটা যে দেখলে এটা তো আসিও সেটা না এটাও সেটা আসিও না like this will come like this. So if you go to that link, this will come like that. So you see, and what is your risk of kidney failure? So again, this risk calculator. If you click this risk calculator, you'll find, you see, that will come. So you put the age, put the sex, put the region, and select, and that will come in the next, what is the real. So if you really put the age here, suppose I will put the age 68, and your sex, it will go female sex, and if you regions, it is a North American or non-Northern. So here, this is a GFR, suppose GFR is 45. Albuminic creatinine ratio, if you select in milligram, okay. If it is, suppose it is 126 milligram. So that will come to, you see, so this will come that this is the risk stratifier. So that means the risk of going to end stage kidney disease, you see, at 2 years is 0.5%, at 5 years is 1.93%. This will think. So in that case, what it says, so the 3 to 5% over 5 years for referral to a kidney. If more than 3 to 5%, then you refer to a kidney doctor. Otherwise, you can treat. 10% over 10 years, again you refer, otherwise you can treat. So this is the risk stratification that has to take care of. How to go again back? Okay, thank you. So coming to the basic, this one slide will show the primary pathological, what are the pathological alterations in the DKD that we know, because there will be a thickening of the glomerular basement membrane, there will be dilation of the mesenchymal cells, development of nodular sclerosis, injury to the podocyte injury, and transition of tubular epithelial cells to the mesenchymal cells, progressive accumulation of extracellular matrix, so presence of tubulo-interstitial vacuole. So these are all the pathological phenotype that will go to ultimately culminate in a kidney fibrosis. So why we really bother? Because all these problems that will lead to finally kidney fibrosis, and there will be end stage kidney disease. So these are the major mechanism of DKD, that is in diabetes. Hyperglycemia. Hyperglycemia leads to all the problems. So you know hyperglycemia, there are two things. Hyperglycemia, there will be age, that is advanced glycation end product, that will lead to again that is rage. Rage means there are receptors, age receptors are there in different cells of the kidney. So this age that interacts with the rage, that leads to various, that is intracellular signaling, downstream signaling, and that leads to various these inflammatory markers, that is the, and more of rash, more of the podocyte injury, and more of this anti-VEGF, more of this that is the TGF beta. So all these things lead to more of fibrosis, and what the pathological mechanisms I have shown in the last slide, all these problems that occur. So this is the hemodynamic abnormality, that means you know this, there is hyperfiltration, and because there will be these in case of this hyperglycemia, hyperinsulinemia, there will be the more of this resistance, that there will be more of hemodynamic abnormality. Hemodynamic abnormality is more of hyperfiltration. So that will be metabolic disorder, as I have shown. The activation RAS system also, the activation RAS, that will lead to vasoconstriction, and again vasoconstriction that constrict the efferent arterioles more, and that will lead to again hyperfiltration, inflammation, and also this pro-fibrotic features. Genetic, epigenetic, we cannot just change the gene. There are certain genetic, but there is no specific gene which leads to DKD, because DKD doesn't cause in every diabetes patients. But there are certain genes which really these persons, they are very much prone for going to the DKD. But epigenetics, hyperglycemia can because these environment factors can influence the epigenetics. And by epigenetic, you see, if you have that epigenetic influence, that will at least change the gene expression. The genes cannot express to a equal amount if the epigenetic factors they do influence. That's the whole factor which hyperglycemia, what happens, that influence the epigenetics. That's why by that they reduce, that by that the genetic exposure, genetic expression is more in these cases. Podocyte injury is also there. There is a mitochondrial dysfunction. Hyperglycemia also causes mitochondrial dysfunction and more of ROS production. So this is the inflammatory factors, fibrotic factors, all these things, and the final endpoint is glomerular hypertrophy and sclerosis. So how to manage? So management of DKD, definitely as we have seen, so glycemic management is the cornerstone, because so we have to optimize the glycemia, and all of us know these are the various trials, these are the very landmark trials, DCCT, Ecopedias, Advanced, these are the various landmark trials that has been shown that our glycemic parameters should be, the HbA1c should be less than 7 to at least prevent these microvascular complications, that is DKD. And ADAEST also, the guidelines also says the same thing, that we have to keep the HbA1c less than 7%. Older patients also, in those cases, we can be little that is lenient. At least in those patients, HbA1c can be at least around 8%. Blood pressure, again, all the recommendations are the blood pressure should be less than 130/80, and the ACE inhibitors and ARB are the definitely first line drugs in those cases, and if needed, you can have it add a dihydropirin antagonist. So lifestyle modification, again, this is very important in all the cases, like in all the, so healthy eating, regular exercise, weight loss, smoking cessation, these are very important. Healthy, out of healthy eating, we say nutrition in CKD is again a vast chapter. So in short, in one line I will tell, the protein intake should be restricted to 0.8 gram per kg body weight, and this is what the guideline says, and the KIDGO guideline, all the guidelines say. And also the sodium intake, should be less than 2 gram or less than 5 gram of sodium chloride per day. So these are the two important things: restriction of sodium intake, that is sodium intake, and also the protein. And with that, we should also give all the micronutrients, that also take care of. Coming to the exercise is also very another important part. You see how exercise helps, because it controls the glucose homeostasis, it reduces the oxidative stress, it improves the endothelial cell damage, it also reduces the RAS activity, and of course it also reduces the muscular kidney axis, and by that it also improves the DKD. So exercise is also and very important. You know, exercise 30 minutes per day for 5 to 10, that is whatever the diabetes guidelines are there, the same thing is also approved for this DKD. Obesity, again, obesity itself is a high risk factor for chronic kidney disease. So when obesity is associated with diabetes, so both the factors they correlate, and the diabetic kidney disease becomes more. So obesity, that is a very high risk factor, more of excessive visceral fat, adipokines, insulin resistance, and this diabetic glucotoxicity, they all lead to more of RAS activity, and these things lead to that chronic kidney disease, low for albuminuria, as all of us seen. And the treatment is SGLT2 inhibitor and GLP based medicines. This slide you must have seen many times. This is what we call the cardiovascular kidney metabolic health, CKM. So this is what the AHA has come out with different staging. But here you see, again, here also you can see in the stage 1, dysfunctional adipose tissue. Dysfunctional adipose tissue is again the mother of all these problems. That is, whether it is a cardiological problem, or it is a metabolic problem, or it is a kidney problem, it leads to all the problems that the different stages of CKM. So if you can, we can manage it from the stage 1, we can at least prevent all these stages. So this is the basis, that is what called the obesity leads mother of all diseases, and obesity leads to all these problems. So coming to the various pillars of DKD management, you see they are again in all diseases, chronic diseases, we are coming with pillars, with combinations. So all the pillars here also we have got 4 pillars. This first pillar is the RAS blocker. RAS blocker that decreases renal hyperfiltration, decreases hypertension, efferent arterial dilatation, suppress inflammation and decreases proteinuria. So all the RAS blockers, that is ARBs and ACE inhibitor. In the second inhibitors, that is second pillar is the SGLT2 inhibitors. That is again hyperglycemia control, improve tubuloglobullar feedback, decrease renal filtration, efferent arterial dilatation, and decrease the albuminuria, suppresses inflammation and fibrosis. Coming to the third, again this is a non-steroidal MRA. That is what called this phenobarbital non-steroidal MRA. That decreases again sodium deabsorption, decreases hypertension, suppresses inflammation, decreases albuminuria. And the fourth one is GLP-1 receptor agonist. That is hyperglycemia control, decrease body weight, decrease hypertension, suppress oxidative stress, inflammation of fibrosis and decrease. So these are the 4 pillars of management of diabetic kidney disease. Now coming to the what are the real RAS blockers. So RAS blockers, the recommendation is that we recommend these RAS inhibitors for people with CKD and moderate to severe increased albuminuria with diabetes. So all these people who have albuminuria moderate to severe, they must be given RAS blockers. But the other recommendation of the kidney international says we recommend avoiding any combination of ARBs, means ACE and ARB should not be combined. And consider starting people with CKD with normal to mild increased albuminuria on RAS inhibitor for specific. So here what happens, RAS blockers are really very modestly effective if the albuminuria is less, if the albuminuria is mild, but that is below 300, 0 to 300, 30 to 300. In this group, effect is modest, but in severe cases, the effect is very good. That's why here they have come out that in this group of patients, if there is hypertension, then you give with RAS blockers, or if there is heart failure, you give RAS blockers. That is their commission. But ordinarily, in the normal things, we all treat with RAS blockers. And continue ACR ARBs in people with CKD, even when eGFR falls below 30 also. So, no need of discontinuing. Coming to the SGLT, to the other pillar, SGLT2 inhibitor, as all of us know, these are the landmark trials. Coming to the Credence trial, to the other trials. So, we have seen in the Credence trial how the canagliflozin that has given that tried, and what that have shown almost 30% risk reduction of the kidney outcome. So it is a 2.62 years follow-up, and they have seen in the Credence trial the renal outcome, primary outcome was reduced by that is around 30% in respect to placebo. And DAPA CKD clinical trial has also shown that also here there is almost 39% risk reduction of the primary composite outcome, that is the renal outcome. And in this trial, you see, all of us see DAPA CKD trial. Here not only this is for diabetes patient, this is also for the non-diabetic patient, and the effect is equal for both diabetics as well as non-diabetic. And the rest is the impact kidney trial. Here also the primary outcome, that is a kidney disease progression or death from cardiovascular causes. Here there will be 38% risk reduction of 28% risk reduction of the primary outcome. Here also in the impact kidney also it is applicable for, because half of the patients were diabetic and the next half were non-diabetic. So it is also applicable both diabetic as well as non-diabetic patients. Now coming to the that is non-steroidal MRA, that is the phenobarbital. Effect of phenobarbital on chronic disease here in type 2 diabetes. Again, this is the Fidelio DKD trial. You know, this is Fidelio DKD, where this is two outcomes, that is the primary outcome and the secondary outcome. Here the primary outcome is renal outcome, and in the renal outcome is Fidelio DKD that has shown almost 18% risk reduction, but the secondary outcome here, secondary outcome is the cardiovascular outcome. Here the cardiovascular outcome, that is also almost that is 14% risk reduction. So this phenodone has shown in this trial, that is both, it is the primary outcome, that is the kidney outcome that is efficacious, and also in the secondary outcome, that is the cardiovascular outcome, it is also effective, both that is the cardiovascular death, cardiovascular events as well as the renal events. Coming to the other trial, that is the Figaro DKD. In the Figaro DKD, just the reverse occurred. In the Figaro DKD, they have shown the primary outcome was the cardiovascular outcome and the secondary outcome was the renal outcome. So that's why in the primary outcome they have seen, and they have taken also patients of different categories. That is more severe category. In the first thing there is more severe categories, but in Figaro DKD less severe categories they have taken. And here in the primary outcome they have found out almost 13% risk reduction in the cardiovascular outcome. And secondary among these, most of the cases were heart failure. And already in the previous speaker has shown how the fine art study that shows in the that is in the heart failure with the preserved ejection, phenodone has shown the positive effect in heart failure. That's why in heart failure, in this patient, in this case also, most of the cardiovascular events, that is the heart failure is the predominant one. And secondary outcome here is the renal outcome. But unfortunately, here you see, there is 13% risk reduction, but it is not clinically significant. Because what happens, this is the, you see, confidence interval that crosses 1. So here it was not significant, the renal outcome. That's why they came out this fidelity pool, that both the studies, came out this fidelity pooled analysis. So they have the summary of research, that is cardiovascular and kidney outcome with phenodone in patients with type 2 diabetes, chronic disease, that is the fidelity was to try. And composite kidney outcome, that also they have come out almost 23% reduction, and hospitalization of heart failure also they have shown also 22%. So the fidelity pooled analysis shows in all the categories there is positive outcome, be it cardiovascular, be it renal. Coming to the fourth channel, the fourth pillar is our GLP-1 agonist semaglutide. So here, effect of semaglutide on chronic kidney disease in patients with type 2 diabetes, the FLOW trial. This FLOW trial came only almost 6 to 7 months, 7-8 months back. That's why most probably all these guidelines which were published in 24, they have not taken care of this FLOW trial. So this FLOW trial came a little late. That's why in this case, in this trial, what I have shown, the GLP-1 agonist, the major kidney disease events in this that have shown almost 24 risk reduction of the major kidney events with the GLP-1 receptor agonist, that is semaglutide. And decline in kidney function was also very impressive, almost 14% risk reduction in the decline in kidney function. So here is a very landmark trial or FLOW trial, that what I want to impress upon you, that among the fourth pillar, this trial shows this is more effective in poor patients who are little obese. So what are the recommendations today? How to use all these agents, whatever we have discussed. So that is the recommendation Kidgo 2025 that says that we recommend treating patients with type 2 diabetes, CKD and an EGFR more than 20 with an SGLT2 inhibitor, class 1. And practice, but this is a recommendation. But the practice point is, once an SGLT2 inhibitor is initiated, it is reasonable to continue even the EGFR falls below 20 unless it is not tolerated. Okay? So this is a practice point. This is not recommendation, this is a practice point. Now the other recommendation is, we suggest non-steroidal mineral corticoid receptor antagonist with a proven kidney or cardiovascular benefit for adults with type 2 diabetes and EGFR more than 25, normal serum potassium concentration and albuminuria more than 30 despite maximum tolerated dose of RAS inhibitor. So here they have given that should be given. But a non-steroidal MRI may be added to RAS inhibitor and HL2 for treatment of type 2 diabetes and CKD in adult. So they have not, recommendation has not yet come, but only the practice point is that you can combine this phenylalanine with other drugs. This is a practice point, but not yet the recommendation has come. Maybe in next year we will find the recommendation. And in adults with type 2 diabetes CKD who have not achieved individual glycemic goal, there you can use GLP-1 receptor agonist. So GLP-1 receptor agonist, again, they have not yet come out to give along with these drugs, but they have seen if because the glycemic control is not good with SGLT2 inhibitor, you can add GLP-1 receptor agonist. But friends, this is the ADI 2025 says, of note, there has not been direct comparison with MRA and SGLT2 inhibitors. At this time, they can be used interchangeably or together for the goal of showing progression of CKD and providing cardiovascular protection. So this is up to you. Decide whether you give that is single drug, two drugs, or combination drug. Healthcare professionals should use their best judgment. So these are the four pillars: ACE inhibitors, SGLT2 inhibitor, non-steroidal MRA, GLP-1 receptor agonist. So a holistic patient care is needed. But I will show. But there are now various studies are coming for the combination of drug. Maybe we will find very soon that how to drug, like heart failure, we get to give all the four drugs within a certain period, starting from the very beginning. This is also will be coming very soon, but there are many studies are coming in favor of that. And this study, this is published in Circulation 2024. What they have seen, they have find out that, you see, they have come out with, this is the actuarial analysis of all the studies till date, whatever have been published, and what they have come out. You see, if you see here, if you give one single agent, SGLT2 inhibitor, you see the risk reduction is hardly 37%. But in the lowest one, if you give the four drugs, they have found the risk reduction is, here you see, almost 58%. Similarly, all-cause mortality, if see in the above, it is only 15%. But if all the four drugs, they have come out almost 33%. So this is the analysis they have given. Similarly, if come the MACE, here also, if the above one, 17%, to it has increased to almost 35%. And hospital heart failure, that is the points, that is 6.4, that is 46%, to it is already 55%. Cardiovascular death, 16%, to it is almost 36%. So they have seen if you give it, and in the second, that is two drugs, three drugs also intermediate. So as you go on adding one by one, you only give all the four drugs, the definitely outcome is much better than the one drug or two drugs. That is the whole analysis. So in summary, for patients with type 2 diabetes and at least moderately increased albuminuria, treatment with combination of all the SGLT2, GLP-1 receptor and NSMRA has the potential to afford relevant gains in cardiovascular, kidney event-free overall survival. So this is the current treatment strategy. As you have seen, we have all the drugs. We have all these drugs, but these are the upcoming drugs. That is the anti-inflammatory drugs, pentoxifylline and baricitinib, anti-fibrotic drugs, pirfenidone, and also the microRNA antagonist and stem cell therapy. These are the upcoming drugs. That is the trials are all going on, but there is no definite outcome. So these are the baricitinib, pentoxifylline, and silnosertib and pirfenidone, stem cell therapy. These are the all molecules are going on. Maybe in future we'll get the results. Thank you.
Thank you, sir. The explanation. We go for the second.
So now the most second speaker is our filing, the Madam Dr. Sarita Behra, professor in MKC Medical College. She is a good organizer. She was the secretary of RSSDI and API. She has done a great job. She is a good organizer. Anything, whatever we speak, it is very less than her qualities of organizing any events. Madam, it's you. She will be speaking on ARDS. Madam, it's your year.
We are coming towards the end of the session of today's whole day CME. Okay. Management. So towards the end of the day, we are coming more and more complex topics, I think, because to say about critical care at the last part of the session, it is really tough because the energy is drained and critical care is, the term says critical. Okay, so and Dr. Dey, he is rightly, when the medicine, all the subdivisions of medicine like cardiology, gastroenterology, everybody is taking part of medicines with them. And nowadays also critical care separate group is there. They are also taking medicines, some part of medicines from us. And in this scenario, Dr. Dey has rightly chosen the topic to keep the subject with us still, because though we are not very much acquainted with critical care managements in day-to-day life using ICU, because some of the medical colleges where proper ICU is not there till now also, and mostly it is dealt by anesthetist and pulmonary physician. I think here pulmonary physician department, they are taking over ICUs in critical care here. Also, okay. So nice that. So in that scenario, today we will discuss about management of ARDS, and coming to ARDS, acute respiratory distress syndrome. So acute respiratory distress syndrome, of course the name suggests, it is a clinical syndrome that causes severe dyspnea, that is a rapid onset, and hypoxemia, characterized by hypoxemia and diffuse pulmonary infiltrate leading to respiratory failure. In our day-to-day practice, whenever we come across such cases, patient having ARDS, suspecting ARDS in our ward, immediately we give a ICU call. Please transport the patient to ICU. And so ICU is the site where these patients to be treated. It is a life-threatening condition and characterized by poor oxygenation and non-compliant lungs, because I will tell in pathogenesis, pathophysiology, associated with capillary endothelial injury and diffuse alveolar damage. 10% of all ICU admissions are ARDS cases, and it carries high mortality. Average mortality is 40%. Coming to etiology, there may be direct lung injury, there may be indirect lung injury. Direct lung injury, though it carries bad prognosis, but most cases we come across in ICU are indirect lung injury, and commonest cause is sepsis. In direct lung injury, we may see cases from pneumonia, aspiration of gastric content, pulmonary contusion, near drowning, and toxic inhalation injury, rare. But indirect lung injury, almost 80% cases are sepsis cases we come across in ICU. Severe trauma, this severe trauma from surgical sections, they will come to ICU. Multiple transfusions, drug overdosing, pancreatitis, post-cardiac pulmonary bypass, some chemotherapeutic agents, some even amiodarone also. It causes this edema, ARDS. Coming to pathophysiology, any subject is incomplete if we don't realize its pathophysiology. So, because I see many postgraduates here, I want to tell for them this pathophysiology. The left side, it is normal, lung alveoli, and there is capillary membrane. In the right side, there is damaged capillary membrane and alveoli. What happens, you can see there will be capillary damage because of ARDS, and there will be recruitment of cells to interstitium. And there also type 1 pneumocytes are there in alveolar basement membrane, in alveolar lining, they get damaged. So first damage occurs to capillary endothelium and type 1 pneumocytes. So there occurs damage to alveoli and fluid comes to interstitium, and then there occurs these macrophages, alveolar macrophages, they get activated and they secrete these pro-inflammatory cells, giving rise to these leukotrienes, PAF and oxidants, even IL-1, IL-8, 6 and TNF alpha beta, these are all secreted and they give rise to, they aggravate further inflammation inside alveoli. So this is the process that causes damage, and there occur alveolar exudates. So alveolar becomes solidifies. Here stages. There are 3 stages according to Berlin classification of 2012. There are 3 stages of ARDS: mild, moderate and severe. So mild hypoxemia, when partial pressure of arterial carbon dioxide by that is fraction of inspired oxygen in inspired air, that is in between 200 to 300, then we say mild. Why we say mild? Because mortality is only, in mild also mortality occurs, so mortality is only 27%. When it is moderate, that is between 100 millimeter mercury to 200 millimeter mercury, this PaO2 by FiO2, then mortality risk increases by 32%. And when it is severe, that is less than 100 millimeter mercury, mortality increases to 45%. So overall mortality in ARDS is around 40%. What are the risk factors? So whenever we deal with ARDS, we can't say which patient is going to be next case of ARDS, but definitely we can, in words, we can see who are the risk factors. Those are prone for ARDS in the, with the background of underlying disease. So those are mostly older age. It is seen that above 70 years, mortality is increased by 60%, and below 70, it is less. So like that, young fellows, there is, though mortality is there, but it is 20%. So chronic alcohol abuse, pancreatitis, pneumonia, sepsis already discussed, and severity of critical illness, these are all the risk factors that determine the prognosis of the ARDS cases. Trauma with Apache score, Apache 2 score, if it is more than equal to 16, there occurs 2.5-fold increased risk of ARDS. What is the clinical course? ARDS, like all inflammation, ARDS, there is a exudative phase, there is a proliferative phase, and there is a fibrotic phase. This exudative phase occurs first week. We can say first week is exudative phase. Next 2 weeks are proliferative phase, and lastly it comes to an end with fibrosis. But that end is not at all a good end. So what happens during exudative phase? Already I have discussed in pathophysiology. There is interstitial fluid leakage. There is alveolar accumulation of this debris, and there occur lung compliant, that alveoli becomes stiff, and there subsequently it gives rise to hyaline membrane formation in alveoli. So when there occurs hyaline membrane formation in alveoli, alveoli stiffness increases, and subsequently there occurs proliferative phase. This proliferative phase is there for 2 weeks. It remains, and in the early part of proliferative phase, still if proper treatment and proper intervention is given, then we may rescue the patient, but as the duration is directly proportional to the severity and bad prognosis. Coming to fibrosis, at the end of the process, subsequently what will happen? There will be fibrosis of the alveoli leading to cyst type, like multiple alveoli, they conglomerate, and they give rise to emphysematous changes. So that is the last phase, and that gives rise to stiffening of the alveoli and fibrosis. So that is subsequently responsible for chronic hypoxemia, and there will be increased pulmonary artery pressure and subsequently gives rise to pulmonary arterial hypertension. This is a picture, radiological picture of ARDS. You can see there is how the lower part, it is mostly seen in lower zone, alveoli dependent part of alveoli are mostly affected. So it is mostly seen in dependent zone, and sometimes we may confuse with whether it is a cardiogenic edema. But unlike cardiogenic edema, there is bad swing appearance as typically says. Sometimes we may not get that, but it is always important to say, to rule out cardiogenic edema before saying it is a case of ARDS. This is the chest CT. That again in the proliferative stage of this is exudative stage of ARDS. You can see so many exudations, it is there in the gravitating down, and that is the exudative phase of ARDS. Coming to management. So my topic was management of ARDS, but before that it is customary to give you brief idea about the ARDS for mostly postgraduates. Coming to management, management remains largely supportive. So there are 5 P's of management. 5 P's of management I will tell. Let me first discuss some things like management should focus on strategies to limit further lung injury. So what should be the goal? We should take over the strategies that will limit further lung injury, because it carries high mortality rate, and high mortality rate still persists with the survivor who faced long-term impairments. Patients are being followed up even up to 60 days, up to 6 months, and even up to 1 year. So if it is not that you have cured ARDS, you have discharged the patient, your work is over. No. You can ask the patient for further follow-up, and that patient can be followed up for 6 months even to see what is the next behavior of the prolonged stay in as a ARDS case. A clinical practice guideline published by these 3 societies, following 3 societies, after summarizing the evidences supporting ventilator and adjunctive measure in ARDS in 2017. These 3 societies were American Thoracic Society, European Society of Intensive Care Medicine, and Society of Critical Care Medicine. Jointly, they analyzed all the trials, and they formulate the guideline in 2017. But medicine is ever evolving. Whatever we knew yesterday, it may be obsolete today. Chloramphenicol we were using during my MBBS days. Now it is not there in book. Quinine was using during my postgraduate days rampantly. Now it is hardly we are seeing quinine is available or not. So that's why medicine is a ever evolving subject. So now we should, whatever guideline was there earlier, it has changed now. So what is the change? I will focus on those things. Before that, let me tell about initial management of ARDS. So what are the goals and limits? So whenever you get the ARDS case, accordingly initiate volume or pressure limited ventilation. Then your target is tidal volume to be kept below 6 milliliter per kg per body weight. Plateau pressure is less than 30 centimeter water, and respiration rate should be kept below 35. So next is oxygenate. So what is the then mode, the goal of oxygenation? FiO2 should be less than 0.6. So normal FiO2 is mostly it is 21 in inspired air, so it should be kept below 0.6. SpO2 should be managed within 88 to 95%. Minimize acidosis. pH should be kept above 7, equal to 7.3, and respiration rate should be less than 35. And consider diuresis. Diuresis is considered because to decrease the pulmonary artery pressure. So to decrease the pulmonary artery pressure, you have to do diuresis, and so but you have to maintain mean arterial pressure simultaneously. Mean arterial pressure should be kept above 65 millimeter of mercury. If you decrease mean arterial pressure a lot, patient will land in hypotension. And some patients who are having earlier already multi-organ failure, hypotension, again in those cases that may be detrimental. So you have to be vigilant regarding these things. So old evidence-based recommendation, these are all the evidence-based recommendation. I can say A grade means solid recommendation. You can blindly follow that. B recommendation is, it is supportive, but not much clinical evidence support that, but it is supportive, can go for it. C recommendations should be judgmental. Yes or no depends upon clinical. It is not supportive, neither very much confirmative. D is not to be given. So these are the recommendations. These previous 2017 recommendations they have formulated after going through several RCTs during that time. But whatever was there, you can see here D is high frequency ventilation and glucocorticoid treatment not to be given at that time. What the says new guideline, let us see. Now coming to, after this last guideline, again American Thoracic Society, its critical care society, again during these up to 2022 September, they took all the RCTs. They took all the RCTs, systemic reviews, and they collect all those with all languages. And they made a systematic review. And they found out the following things and brought a guideline. That was published in 2023 September and came to journal in 2024 January. So those are depends on those systematic analysis where depend on patient centric, intervention centric, comparison centric, and outcome. These 4 points they grouped their director, co-director into 4 groups, and they will analyze these things. New recommendation. So already I have told you about old recommendation. Coming to new recommendation, corticosteroid for patients with ARDS, conditional recommendation, moderate certainty of evidence, that come out again number 1. So corticosteroid, which was debarred in last as category D, now it can be given with conditional recommendation. Number 2, veno-venous extracorporeal ECMO. So veno-venous ECMO in selected patients with severe ARDS. ECMO is the term we medicine people come across during COVID. Earlier I have not heard about ECMO. Truly speaking, I don't know anybody would have heard, but ECMO is there prior to COVID also in some specialized center. But nowadays even SCB, AIIMS, everywhere, not everywhere, some specialized centers, ECMO facility is there. So now guideline has included ECMO in its systematic review. Number 3, neuromuscular blockade. So usually ventilator patients, they are given sedatives, and they are given sedatives for a prolonged time. So what is the role of neuromuscular blockade again? Yes, it is in that neuromuscular blockade has role if given within 48 hours during early severe ARDS. That is also conditional recommendation. Low certainty of evidence are there. Even veno-venous is also low certainty. I will tell why. Next is positive and expiratory pressure. That means if you go on giving only inspiratory oxygen by ventilator, then there will be either there will be volume trauma to alveoli, or after this expiration alveoli will collapse. So you should keep some positive end expiratory pressure in alveoli for proper functioning of the air, this oxygen gas ventilation perfusion. So that is PEP. To use higher PEP without long recruitment maneuver, this long recruitment maneuver is grading selectively increasing oxygen concentration in inspired area. So it is seen that higher PEP without long recruitment maneuver in patients with moderate to severe ARDS, it carries strong recommendation but low to moderate certainty. Recommend against using prolonged LRM. This recruitment maneuver should not be used for prolonged in patients with moderate to severe ARDS, should not be used. So it is strong recommendation, moderate certainty. Next slide is bit blurring because there are so many data. These data are from this practical consideration, precautions, population and intervention. Because these 4 intervention, corticosteroid, ECMO, neuromuscular blockade and PEP. These 4 are new to the newer guideline. That's why it is seen that if in population it is better corticosteroid less than equal to 300. It may be associated with increased risk of harm when initiated after 14 days. So early to be given, corticosteroid if given should be given early, should not be given after 14 days of mechanical ventilation. Monitor more closely for adverse effect in patients with immunosuppressed condition. Metabolic syndrome we know because it aggravates diabetes. So in those cases also you have to be, and there is increased chance of fungal, parasitic, mycobacterial infection. In that case you have to be visualized. So you have to be balanced to judge which cases to give. Practical consideration is optimal regimen including type of corticosteroid. But none of the guideline has given which corticosteroid is given and what should be the dose of the corticosteroid. It depends upon the patient selection and according to clinician. For patient with corticosteroid responsive etiology, regimen should be tailored to the specific condition. For other patients, regimen used in prior RCT may be used. For patients that improve rapidly, consider discontinuation at time of extubation. That is important. So discontinuation of corticosteroid at the time of extubation. Coming to veno-venous ECMO, there is when partial pressure of arterial oxygen to FiO2 is less than 80, you consider it, or pH is less than 7, severe hypoxemia, severe hypercapnia, and there is these conditions you can consider veno-venous ECMO. So conditions associated with increased risk of futility of treatment. Which conditions? If a patient is having already renal failure, kidney damage is already there, what will happen if you are subject the patient to VV ECMO? And if there is mechanical ventilation for more than 7 days, don't give. And immunosuppression, multi-organ failure, older age, systemic bleeding or other contraindication to anticoagulation, having bleeding tendency, not to be subjected. So these are all the specific precautions to be taken before advising VV ECMO. This is less invasive therapy including long protective ventilation, prone positioning and neuromuscular blockade should be initiated prior to ECMO. So ECMO is not the, as I have mentioned here, it is not the second option. It is the option before that. It should be prone positioning should be practiced and proper ventilation effect neuromuscular blockade should be given. NMBA, neuromuscular blocking agents. Neuromuscular blocking agents is cisatracurium. This is given because it is seen that if it is given within 48 hours of ARDS in ventilator, then the duration of sedative given is less and there is decreased ICU survival stay and there is less complication. So that's why it is advised in early ARDS less than 48 hours with FiO2 less than 100. These cases can be subjected. This is high PEP is given when oxygen saturation is less than 200, PaO2, FiO2. Respiratory mechanics, hemodynamics and response to PEP should be continually monitored because I have told PEP should be given to prevent this volute trauma, and also when there is expansion of alveoli there will be barotrauma, surrounding alveoli will be atelectasis or collapsed. So these are in detail the newer changes in basing on the older guidelines I have focused. So this is the current guideline of American Thoracic Society. You can see those are having star marks. These four things, those are newly added, and this green, there's having that one cross sign, those are earlier in previous guidelines. So according to severity, these things, strong recommendation is against prolonged recruitment maneuver, high frequency oscillatory ventilation. These two are strong recommendation against. Rest things I have already discussed. Corticosteroid I have already discussed. Severe community acquired pneumonia and pneumocystis jirovecii pneumonia in patients with HIV infection presenting as ARDS, they are known to get benefit from corticosteroid in large RCT. For other ARDS etiology, any of several regimen in clinical trials could be chosen reasonably on the individual's risk profile for steroid side effects. Important to note that initiation after 2 weeks of onset of ARDS, associated with harm, non-intubated patients do benefit from corticosteroid, that is we have seen in COVID-19 and severe community acquired pneumonia also. Role for other etiologies in non-intubated patients with ARDS is uncertain. Type of ECMO, I have just discussed BB ECMO. This is less invasive therapy to be recommended for ARDS, that is long protective ventilation, higher PEP, neuromuscular blockade and prone position before BB ECMO. Again highlighting this topic. And adverse effects, this is not neuromuscular blockade, decreases mortality in patients with early severe ARDS. Mechanism is unclear, probably due to decreased ventilator-induced lung injury via a reduction in patient ventilator desynchrony, in addition to reducing oxygen consumption, inflammation and alveolar fluid. But also increases the ICU-acquired weakness. So prolonged, it is not free from ICU-acquired weakness, but in comparison to prolonged sedative, it is in comparison less. And PEP already described. So this is the American Thoracic document, that guideline that is published in the official clinical practice guideline of the American Thoracic Society, approved in September 2023. With this, I completed my talk. Thank you.
Hello. Thank you, madam, for dealing very important subject, because we face many times these problems. Once our patient goes to ARDS, means we lift our two hands, and everything depends on the ICU people. So many thanks for dealing the subject. Any questions from the audience? Okay.
Need a tea break.
We will go for the next speaker.
Thank you, sir.
It's Professor Dr. Manoranjan Behra. He is currently Department of Medicine, SCV Medical College, Cuttack. Has multiple publications. He has been the Honorary Secretary API Odisha from 2015-16 and Honorary Secretary IRA, and multiple chapters in various books. Sir will be speaking on the topic management of acute liver failure. Over to you, sir.
Very good afternoon to all. I think only students are there. So this last topic on liver failure, I am talking on the top of mind failure, because it's time not to receive anything. Yes, all are in state of failure. Liver is most important organ, most important vital organ, in the sense that it weighs around 1.5 kg, highest weight, as regards to solid organ. dual artery supply, and highest regenerative capacity when there is damage to organ. And it is the hub of metabolism, storage, synthetic function, detoxification, and many things. So when it fails, it revolves around not only restricting to liver, also multi-organ failure. When I searched literature, I found it is very difficult to have any recommendation because the incidence is very low, around 2 to 6 per million people. When I asked hepatologists, they told that I don't have any specialization in this because I have specialization on acute and chronic liver failure, but we don't see many cases of acute liver failure. Even if you review the literature of American associations, there are two associations in America. American Association of Study of Liver Disease and American Society of Gastroenterology. They have different opinions. They don't have any clear-cut recommendations. They have recommendations based on expert opinion. All the recommendations, even if you see European Association of Study of Liver Disease, International Association of Study of Liver Disease, American Society of Gastroenterology, American Association of Study of Liver Disease, all have different opinions. So all are based on expert opinion, not based on an RCT or any solid evidence. So I'm just a cooking case. 30-year-old woman presents to hospital with 2-day history of nausea, vomiting, and right upper quadrant pain. She has been healthy and denies any medication use. She recently traveled to one place where twisted her ankle while bungee jumping. The pain has been well controlled with over-the-counter and natural remedies. On examination, she is slightly confused and moderate distress from the pain. Vitals stable, but heart rate was 110, respiratory 24, saturation 98% and room air. She is having diffuse abdominal tenderness and palpable liver edge with a scleral icterus. And initial workup showed ALT around 4,000, AST around 5,000, total bilirubin 9, alk phosphate 283, INR 4.2, creatine 1.1, and pH 7.3. What in the history gives us clue to the cause? There are many histories in this patient. History of travel, possibly exposed to any hepatotrophic virus like A, E, like that. Over-the-counter drug, acetaminophen, very commonly used paracetamol over the counter. Natural remedies, because of pain she is on, maybe sometimes drug or toxin, and she is a female, childbearing age, maybe fatty liver or pregnancy, may possibility. So what is the most likely cause of this patient's presentation? So what are the common etiologies of acute liver failure? It can be categorized as A, B, C, D, E, F for easy remember. That is acetaminophen, hepatitis A or autoimmune under A. Under B, hepatitis B. C, cryptogenic or hepatitis C. Hepatitis C very rarely causes acute hepatic failure. D, also alone doesn't cause on above of B hepatitis. And E is esoteric cause like Wilson's disease and Bord-Chiari. F for fatty infiltration such as fatty liver of the pregnancy and an NFLD. So originally it was defined by Trey and Davidson as fulminant liver failure. First term was fulminant liver failure in 1970, but the term acute liver failure was coined by O'Gray in 1993. So this definition still stands good as regards to American Association of Study of Liver Disease up to 2025. That is a rapidly progressive jaundice, but the duration is limited to 26 weeks. Coagulation abnormality iron more than 1.5. Any degree of altermentation is a mandatory, that is encephalopathy. And the basic thing is it should not be over the top of any pre-existing liver disease. But there is some cavity in it. I will come to that. So if these three above things occurs on the background of without any pre-existing liver disease, we can term it as acute liver failure. What are the exceptions to the pre-existing liver disease? There are certain liver diseases on the chronic background also can be classified under acute liver failure, the patients having autoimmune hepatitis, Body-Chiari syndrome, and Wilson disease. Remember, the sequence of events first almost and always occurs jaundice, followed by impaired coagulation, and hepatic encephalopathy is the terminal event, and it is all three criteria are mandatory for classification. And this is the European Association of Study of Liver Disease. You can see the variation in classification. They have classified the most important thing they needed is the acute liver injury on the top of without any basic liver disease. The liver should be fine at the base, but there should be evidence of any liver injury in the term of increasing the AST or ALT more to 2 to 3 times, and impaired liver function in the term of jaundice or coagulopathy. This is the basic term, and this is the basic. First, jaundice, coagulopathy, and hepatic encephalopathy should develop after, and they have graded the total event into 3 phases according to the time of appearance of the hepatic encephalopathy. So it is crucial for the diagnosis of ALF. Mental alteration may be initially subtle. So intensive screening at the first sign of hepatic encephalopathy is mandatory. Most of the time the patient comes, but you have to very diligently look after the signs of hepatic encephalopathy, whether clinically or by some investigation. So first occurs liver damage in the term of liver enzyme and liver function jaundice and coagulopathy, and development of encephalopathy in succession. So they have different according to first jaundice and appearance of the encephalopathy. If it occurs within 1 week, it is known as hyperacute hepatic failure. If the occurrence of encephalopathy is between 1 to 4 weeks, then it is acute hepatic failure, and if it occurs between 4 to 12 weeks, it is subacute hepatic failure. So in hyperacute failure, there occurs increased coagulopathy. Jaundice is low, but there is increased intracerebral pressure and there is cerebral edema. But remember, the prognosis is excellent in hyperacute phase if you are going for liver transplant, even also from conservative management. And most common causes are your paracetamol, there's acetaminophen, and A and E, sometimes B also. And acute, there is a moderate degree of coagulation, abnormality, moderate severity of jaundice, and moderate intracranial hypertension, cerebral edema or hepatic encephalopathy, but chance of recovery is moderate here, and most common cause is acute is hepatitis B, and even drug also can cause moderate. There is overlap between acute, subacute, and chronic. Everyone can cause everything, but there is some predilection for some etiologies to some group. And the final but most prognosis, that is the subacute failure with severity of coagulopathy is less, but severity of jaundice, because he had progressed, so severity of jaundice will be more, and degree of intracranial pressure is mild to moderate, but chances of recovery is very rare, and those are the non-paracetamol drug induced, that is Delhi. And this is the same American College of Gastroenterology. First I have told you regarding the American Society of Liver Diseases, but this is the definition given the same country. They have divided the first, they have not divided into acute, subacute like that. Only acute liver failure, duration 26 weeks and 3 definitions. But this you can see within 7 days, hyperacute, say 1 week to 3 week acute, and 3 week to less than 26 weeks same or duration same, but they have divided into 3 categories. The rest are same. And this is the International Association for Study of Liver Disease diagnosis or the criteria same till 1999. ALF as less than acute is defined as within 10 days, fulminant 10 to 30 days or 4 weeks, and subacute hepatic failure 5 to 24 weeks. But for all practical purposes, remember liver dysfunction, jaundice, coagulopathy, hepatic encephalopathy within 20 weeks maximum to max, because beyond that 26 to 20 weeks we declare a chronic disease. So for us practically let us concentrate on this. So these are the clinical scenarios, because patient comes with a normal liver, acute hepatitis, chronic hepatitis, cirrhosis, maybe compensated cirrhosis or a decompensated cirrhosis, and they are land up into ward because of some acute insult. So what are those clinical scenarios? First is decompensated cirrhosis with acute insult and further worsening. This is the acute insult on a chronic decompensated cirrhosis. This is case you can see a normal liver, acute insult leading to acute hepatic failure. Here liver was completely normal. You can see a fatty liver which can also go acute liver failure because of some insult. That is maybe viral, maybe some drug, in female also pregnancy, like that. And this is a compensated cirrhosis with acute insult, that is known as acute and chronic hepatic failure, and another is another is chronic hepatitis. So this is the spectrum of liver disorder which on acute insult goes right to either acute liver failure, acute and chronic liver failure. So for all practical purposes, our definition remains confined to on a solid or a unaffected or a very good liver. What are the principal etiologies? Most common worldwide is two, viral and drug. Most common are the hepatotrophic viruses like B and E. Less common are the CMV, EBV, adeno, COVID-19, HSV, varicella zoster and dengue. Toxins like amatina, phylloids and yellow phosphorus, and others like Wilson disease, autoimmune lymphoma, malignancy, and HLH, pregnancy-related, that is HELP syndrome, and that is the fatty liver of the pregnancy, and the vascular causes like Budd-Chiari syndrome, hypoxic and ischemic hepatitis, and drugs is a long list. Most important in the paracetamol in Western countries, but for us is antitubercular drugs, chemotherapeutic, statins, NSAIDs, phenytoin, nitrofurantoin, caramazepine, fluoxacillin, propyl thyrouracil, and your alternative medicines and immune checkpoint inhibitors. Nowadays, these alternative medicines, medicines used to reduce weight, over-the-counter medicines for the immunological disorders, rheumatoid arthritis, like that. Also, they are having chronic liver disease, and on the top of may sometimes have a acute liver failure in those conditions. This is the etiological profile worldwide. If you see very few studies from India, and in India the prevalent virus is HEV virus, hepatitis C, and unknown cause is not known in 31%, hepatitis B is 15%, but if you see USA and UK, paracetamol is the leading cause. Even after diligent investigation in careful investigations also, other causes and unknown causes around 18 to 20% in the Western world also. So what to define the primary and secondary causes for to consider transplantation? Remember, transplantation is the answer nowadays to have a good prognosis, because without transplant the mortality is 80 to 90%. So you have to, if you see a patient, first decide whether it is a transplantable or non-transplantable. So what are the diseases where you can concentrate for transplant, like drug, acute viral hepatitis, toxin, Budd-Chiari, autoimmune, pregnancy. Not all autoimmune, I'll come to that, pregnancy related. But two most important things, that is the ischemic hepatitis, no transplant. For example, out of septic shock, ischemic hepatitis, no. Acute liver failure, no chance of liver transplantation. And some inflammatory diseases, lymphoma, metabolic disease, hemophago, HLH, some infections like malaria, scrub typhus, leptospirosis, acute kidney injury, acute liver injury, no chance. So what are the ALF mimics? In tropical area we are suffering from this, all this dengue, malaria, enteric, scrub typhus, leptospirosis, macrophage activation syndrome. They mimic like acute liver failure. So these are the different etiologies of liver failure, acetoamin toxicity, and your idiosyncratic drug related, the viral hepatitis. Particularly I am interested in viral hepatitis in the sense that hepatitis B is the commonest cause, but also poor prognosis. A has very good prognosis, hepatitis E, A and E also, but E is very bad prognosis when pregnancy is concerned. And acetoamin toxicity is the most common in Western world, and pregnancy, two important things, that is HELP, that is the hemolysis, elevated liver enzyme and low platelet count, and fatty liver of the pregnancy. And autoimmune hepatitis, you can see there will be autoimmune disease background, there will be elevated nuclear antibody and smooth muscle antibody and hypergammaglobulinemia, and other markers of autoimmune disease, clinical as well as laboratory markers. Wilson's disease, usually young, and these persons, they have a cum negative hemolytic anemia and features of acute hemolysis and rapid progression to renal failure. You will get a KF ring, otherwise known as the hepatolenticular degeneration. And mushroom poisoning, there will be acute gastroenteritis in first few hours, followed by acute liver injury in 1 to 2 days, and multi-organ failure in 4 to 7 days. Budd-Chiari syndrome and ischemic liver injury and malignant infiltration. These are the causes and different clinical manifestations. I will not go to detail because of time constraint, because you have to go through many things. So these are the complications of acute liver failure. Most important, you can see the neurological complications, that is the cerebral edema and the raised intracranial tension, the metabolic complications like hypoglycemia, hyponatremia, hypophosphatemia, and hypokalemia, and toxic renal failure, maybe due to toxic or functional, and pulmonopathy, acute respiratory distress syndrome as described by Madam, pulmonary overload. And you can see different arrhythmias, cardiac arrhythmias. Most important, the bacterial infections, maybe gram-positive, gram-negative, and fungal infections, pneumonia, septicemia, and unitary infection, and coagulopathy, that is unbalanced hemostasis and thrombocytopenia. So there is now a very important thing is to differentiate between acute liver failure versus the acute and chronic liver failure. So acute liver, they are the younger persons, and acute and chronic liver, because they are chronically suffering, so they are the older persons. And chronic liver, the stigmata are absent in ALF, but the other stigmata are present in ACLF. Precipitating factors here are the drugs, virus, and autoimmune hepatitis, but here the precipitating factors are the infection, alcohol, and GI bleeding. And the clinical signs are the liver injury and INR is more than 1.5 and hepatic encephalopathy. But here also same, many things are same. Coagulopathy, elevated bilirubin, shock, and multi-organ dysfunction. If you do the liver biopsy, here you will get in ALF, most important thing, hepatic necrosis and collapse of the liver, and with sudden gross decrease in size of the liver. In case of acute liver failure, but in case of ACLF, you get a fibrosis, regenerative nodules, loss of distortion in the architecture of the lobules, perihepatic, lobular, and periportal area. And coming to the CNS manifestation, you can see the increase in intracranial pressure and hepatic encephalopathy. Here also hepatic encephalopathy is there, but here hepatic encephalopathy, they respond to your lactulose and rifaximin, but in case of ALF, they respond to CRRT, and infection is late in case of ALF, but early in case of acute and chronic liver failure. And liver transplantation has a very good prognosis in ALF, because and it is guided by two criteria, that is the KCC criteria and MELD criteria. And these are the things how to differentiate. How coming to the management? So it needs a teamwork. So we have little to do. It's the teamwork of the hepatologist, surgeons, ICU doctor, and coordinator. But when a patient comes to us, let us first diagnose its case as a acute liver failure, and I will give some points where which things we can do, and at least we should not do any harm to the patient till the patient transferred to a hepatologist or a liver transplant unit. So you have to assess and management at the presentation. You have to address all the cardiovascular complications, respiratory, gastrointestinal, metabolic, acute kidney injury, coagulation, sepsis, and the brain. And other things like artificial and bioartificial liver biopsies, and ultimately the liver transplantation. So immediate measures are you have to exclude any cirrhosis, alcohol-induced liver injury, or malignant infiltration, and initiation, discuss with the attendants for their tertiary liver transplantation center, screen intensively for an hepatic encephalopathy, determine the etiology, assess suitability for liver transplant, and transfer to a specialized liver unit at the earliest possible. So these are the, I have discussed, these are the conditions where you can, these are the first in the left, there are the conditions where transplantation is possible. In the other causes like hypoxic or infiltrative, metabolic, lymphoma infection, so transplantation is not possible, it should not be done, and they should be managed conservatively. So what are the things you should do when the patient, before going to the ICU, you have to search for any etiology, you ask the medications, history of any substance abuse, and suicidal attempt for taking paracetamol like that, any patient concerned with gastrointestinal hepatitis eating mushroom like that. So these are the history you have to take, identify the condition that could have ALF, if the patient is pregnant or not, is exposed to travel to any HPV or HEV endemic area, had the patient received an immunosuppressive therapy or chemotherapy for any autoimmune disorder or for any cancer? Does the patient have a history of any autoimmune disease? And decide whether emergency liver transplant is feasible or not. And always try to find out the interval between the onset of jaundice and first sign of hepatic encephalopathy to categorize. So these are the general support outside the ICU. Before going to the ICU, we can do, you have to assess, as apart from the general test, we can do a liver test, liver function test, PTINR, and renal function test, urine output, creatinine, and ABG, and arterial ammonia, and check the etiology, toxicology profile, what blood and urine, viral etiology, A, B, C, E, HE, and HSV, varicella zoster, CMV, EBV, like that, and autoimmune profile, and you can do for ANA, ASMA, and you have to do for HLA typing and ANA profile, and test for any complications like pancreatitis. You have to do for amylase and lipase. So what are general support outside the ICU? You also do culture from the respiratory and blood and urine, chest X-ray, ECG, liver, liver, ultrasound. You can go for elastography, like fibroscan, like that, to see whether it is acute liver disease or it is a compensated cirrhosis. You have to do echocardiography, see the cardiac condition, do the ECG, routine monitoring like oxygen saturation, blood pressure, heart rate, respiratory rate, clinical neurological status, and glucose infusion should be given, and stress ulcer prophylaxis with PPI, restrict clotting factors unless, don't give any clotting factors like cryoprecipitate, precipitate, vitamin K, like that, unless active bleeding is there. NAC should be given in the early stage, even in non-paracetamol cases. So preventive measures: avoid sedatives, don't give sedatives, and avoid hepatotoxic and nephrotoxic drugs. Transfer to an appropriate level of care at the first symptom of a mental alteration, and the patient should be kept in a quiet room, bed head at the 30 degree, and head in neutral position, and intubate, ventilate, and sedate. If there is stage hepatic encephalopathy, say 3 or above, like that, you have to intubate the patient, and low threshold for empirical start. If the patient is in low condition, you can start an empirical antibiotic, even also antifungal if required. In case of evolving hepatic encephalopathy, intubation and sedation prior to the transfer. Ensure volume replacement and normalize biochemical variables like sodium, magnesium, phosphate, and potassium sodium. Liver biopsy normally don't do because of chance of bleeding, but sometimes you have to do to exclude any infiltrated disease or malignancy, and to see whether there is contraindication for a liver transplant. Some cases of autoimmune hepatitis, because if they will be cured by your immunosuppressive therapy, there is no need for go for in liver biopsy. But the recommended method is transjugular liver biopsy or mini laparoscopy with liver biopsy or endo-US guided liver biopsy. Don't go for our conventional biopsy. So there are some etiology specific treatment. So you have to start both for paracetamol and non-paracetamol. You can go for N-acetylcysteine. These are the different regimens given. You have to select. For drug induced, you have to discontinue the offending drug, and you can consider for NAC. And corticosteroids can be given for any drug which have a hypersensitivity or autoimmune features. For hepatitis B, you can start entecavir or tenofovir, and for hospice zoster or varicella zoster, you can go for acyclovir, CMV, ganciclovir, mushroom poisoning, IV silivin, or if not available, you can go for IV penicillin. Wilson disease, you can continuous hemofiltration, plasma exchange. For autoimmune disease, IV steroid and immunosuppressives. For HELP syndrome or pregnancy-induced fatty liver, you can go for a prompt delivery of the fetus, supportive care, and body chair syndrome, anticoagulation, like that. So what are the organs for specific management for the cardiovascular? Most of the patients develop systemic and spasmodic vasodilatation. So patients should be volume limited, so give crystalloid. Ideal balanced crystalloid is the fluid of choice in those patients. And when you are giving the fluid, you should check whether fluid is adequate or not adequate. Overfeeding should not be done, or hypo feeding should not be done. So vasopressive agent of choice is noradrenaline, if at all, if need. And if adrenaline, noradrenaline fails, you can give vasopressin. And for hypoxic hepatitis, you require some inotropic agents. A blood pressure
is not clarified, but mean arterial pressure should be about 70 to 80. Hydrocortisone therapy is not usually required in 50% cases, but may need in 50% cases because we can get adrenocortical insufficiency. And albumin is not indicated unless until very severe hypovolemia is there. For respiratory, you have invasive airway management and organ-specific equipment for gastrointestinal. You can say a good nutritional support you have to give. You have to recommend for protein for 1 to 1.5 gram per kg. But if there is hyperammonia, you can defer for 4 to 5 days. After that, you can start, and you can start 1 gram per kg. So protein, most of the time we feel that protein is not required, but protein supplementation is required. For metabolic, you have to correct the hypoglycemia, hyponatremia, and acidosis. And for any renal impairment, most important thing, particularly in paracetamol-induced poisoning, it is the most common occurrence rather than the viral. So early institution of extracorporeal support and the anticoagulation of the choice is citrate. And remember, continuous renal CRRT is the method of choice rather than our intermittent hemodialysis. So coagulation, most of the time there is bleeding that is. So there is increase in the PT and INR, but there is rarely any bleeding. Around 10 to 15% they have bleeding, and thrombosis can occur in 5 to 6% cases. So be careful while giving blood products, because there is a balance between the decrease in the procoagulant and anticoagulant factors in liver failure, acute liver failure. So there is rare chance of bleeding in acute liver failure patients. So be careful. So you have to manage. PT-INR is not the method to be adopted in those cases. Nowadays they are doing viscoelastic tests like the thromboelastographic test like the TEG is the point of care. So routine use of fresh frozen plasma, cryoprecipitate platelets and other coagulation factors not supported and should be limited to specific situations such as insertion of ICP catheter or if there is active bleeding. No evidence of vitamin K improves the coagulopathy, and hemoglobin target is around 7, and venous thrombosis prophylaxis should be considered if required. Sepsis, bacterial sepsis is most common. Pneumonia is the most common infection, followed by bacterium and united infection, and gram-negative sepsis is most common, and around 30% cases they develop candida. And procalcitonin and C-reactive protein are not valued because in acute liver failure also they are secreted by the liver, so they don't directly correlate to the infection. For fungemia, you can have some marker, the serum galactomannan and glucan level. And for sepsis diagnosis, you have to do regular cultures, and prophylactic antibiotic can be given in high-risk group, and preemptive therapy, antifungal therapy can be given in high-risk groups. So management according to hepatic encephalopathy, grade 1 and grade 2, they should be taken to ICU. Grade 3, 4, they should be intubated. So this is the method how ammonia is produced, leading to hyperammonemia and hepatic encephalopathy, that is leading to increased intracranial pressure. So invasive methods are not done to measure the intracranial pressure. We can see brain imaging, how the cerebral edema by MRI is superior than the CT. So nowadays the indirect method like optic nerve sheath diameter, pupillometry and transcranial Doppler and continuous EEG are done to see the intracranial hypertension and cerebral edema. And how to manage the cerebral edema, this is the nursing care I have already told you. Use of N-acetylcysteine I have already mentioned in that chapter. But it is helpful in grade 1 and grade 2 encephalopathy, but not in more than advanced grade. It reduces the hospital stay, but it doesn't have a survival benefit in advanced hepatic encephalopathy. You can give mannitol, used in case of grade 4 hepatic encephalopathy, but not to be used round the clock. Stop if the osmolality is more than 320 and if the creatinine is more than 1.5 or oliguria. And hypertonic saline like 3% saline bolus 250 to 500 ml or 10 ml per hour should be given to decrease the intracranial pressure but maintain the sodium at level 145 to 150. Hyperventilation, mechanical ventilation can be instituted. Hypothermia has a little role. Hepatectomy and cranial decompression has little role. So coming to hyperammonia, most important treatment of choice, the continuous renal replacement therapy, and that is even in the absence of conventional RRT indications. Even there is no indication for dialysis if they have a hyperammonia and some chance of hepatic encephalopathy, go for CRRT. So ventilation, elective intubation before transport to transplant center,
maintain PCO2 30 to 35, sedation, you use propofol, use atracurone if there is ventilatory asynchrony, barbiturates if there is no chance of transplant, you can give barbiturate, fentanyl better avoided, midazolam certainly avoided. And extubation be planned after the sensorium has improved. CT scan when there is a chance of neurological deficit, all the patients with hepatic encephalopathy. Management seizure, pre-transplant phenytoin and post-transplant levetiracetam. High volume plasma exchange is also now tried in many centers, and other modalities like artificial, bioartificial liver support before, that is the bridging period to transplantation, is also tried. And some Indian settings also have tried. I'm not going to the detail, and there is some benefit, but it is not recommended now. The American Society of Apheresis recommends the therapeutic plasma exchange early in the reduced volume in case of acute liver failure, and molecular adjuvant reticular system, their mass, that is the extracorporeal liver support by dialysis and albumin-based detoxification are being tried, but in experimental phase. For the time to liver transplant, now last part of my talk, is it too early or too late? If you are doing it too early, there is chance of recovery spontaneously. So it will be a criminal part, or it will be a judicial, scientifically it will be wrong to institute liver transplantation. You are going too early. You have to observe for 48 to 70 hours. If not responding, you can go for liver transplant. But if you are too late, then there occurs permanent neurological damage, infection, renal injury, and renal transplant may not become successful. These are the predictive models like your King's College criteria. So what are the criteria by which you select the case for renal transplant? Nowadays, they are following two criteria, that is the KCC criteria for the paracetamol-induced acute liver failure, MELD criteria for non-paracetamol-induced liver failure. And now, the latest is the ALFED, that is the acute liver failure extensive model for this decision. So, when to do, you have to confirm acute ALF, meet the criteria, the KCC or ALFED model, hepatic encephalopathy, raised bilirubin, increased INR. Trends are more important than the absolute values, and hyperammonemia. What is the level till now not decided. What don't do when there is neurological signs, infections, and renal impairment. So some Indian protocol, they are doing like this. I'm not going to detail. This is the timeline. First emergency department, then ICU transfer, then to the transplant center. This is the protocol and not going. These are the ongoing clinical trials nowadays. The MARS, the SPIRE, and different other clinical trials are going on for treatment of acute liver failure. So coming to my contemplate slide, ALF is a medical emergency and is potentially reversible if recognized and treated early. ALF must be differentiated from ACLF and decompensated cirrhosis because management is vastly different. ALF affects multi-organs and carries high short-term mortality. Early transfer to the liver care or transplant center a priority. Patients at high risk of death have excellent prognosis after life-saving liver transplant. Thank you for attention.
Thank you, sir, for your extensive coverage of this very important topic. We can have one question at least.
Thank you, Professor Behera. All the literatures in the world and all the textbooks of medicine probably you have covered.
Yes, sir.
Nothing else is left anywhere. But the question is, you are an astute clinician with great experience. In our practice, we see paracetamol poisoning causing liver failure, I think extremely rare. Only in European literatures they have found, because paracetamol is OTC drug. Somebody willing to cause suicide, he can take 40-50 grams of paracetamol, and those who identify also, they have their N-acetylcysteine injectables, they counter it. Number one. But what we see, hepatitis A virus in rural belt, They take it, develop jaundice, but never come to a doctor. They take their indigenous drugs like some leaves, flowers, and they delay the period. Then only they come with acute liver fever. That is what is my experience. But carbamazepine we are neglecting. Sometimes it comes with the jaundice and some autoimmune hepatitis they develop at acute liver failure, and they have also gone for this liver transplant. 1 or 2 cases I have seen. And we are extensively taking these mushrooms.
Yes.
In rural areas, there are 3 types of subtypes of mushrooms. One causes respiratory failure, other one is cardiac failure, the third one is liver failure, preceded by gastroenteritis. And of course, you have said about the management and everything, but our common, what should we take precaution, how to identify that yes, here is a patient who is going for liver failure and the kidney should be protected. That should be the motto of our management.
Another thing for us, while we have to be very cautious regarding ATT therapy. First thing.
Yes, in our setup.
We are seeing. And another thing, pregnancy with hepatitis C, very, you have to be very cautious. Always fatal. That is most important thing.
Professor Behra, rightly you have covered, but I have one doubt. If during treatment we get prothrombin time is raised, PT is raised, what should be our next after this session?
Time raised, they are saying that
what
the
will
cutoff,
say?
first just the cutoff value they have given more than 1.5. The authors they tell that it should be more than that. 1.5 is not sufficient. But some tell that if the cutoff value is 1.5, you will be very cautious so that you can address the patient at the onset, one thing. And in acute liver failure, what happens? Prothrombin time goes on increasing in a regular, in a very predictive manner. So are the INR also. But that doesn't replicate into bleeding. Most important thing. On the contrary, you can see some percent of cases also have thrombotic manifestations. So why this happens? There is a dramatic balance between the procoagulant and anticoagulant. Both are decreased. All are produced by the liver. So this side decrease, this side decrease. So there is a balance decrease in the both procoagulant and anticoagulant. So that is probably the reason which doesn't incorporate into bleeding manifestation. But certain criteria they are telling that in case of children also, if the PT INR is more than 4, don't wait, go for liver transplant. Certain Indian guidelines I've seen, if INR is more than 7, 6 to 7 like that, that is also one criteria, go for liver transplant. But remember, INR or PT doesn't translate into bleeding in acute liver failure patients.
So we will just masterly watch when their PT goes high and INR goes high.
And even if you give cryoprecipitated FFP or vitamin K, you may land up into thrombosis also.
Okay.
Microalbuminuria oblique EGFR less than 60 for 3 months. There are 2 varieties you are getting. There is a non-proteinuric uremia or renal failure, but EGFR is less than 60. And in many cases, elderly persons, those who are 65 and 70, they do not have microalbuminuria. Even urinary albumin creatinine ratio is more than 30. But they do have EGFR between 50 to 60. How do you address?
You see, diabetic kidney disease, what I have told, that is urine albuminuria, ACR more than 30. Okay? Or EGFR less than 60. Either of or. It's not like that both are present. If somebody is having less than 60 and diabetes, that will also cause a diabetic kidney disease for persistently more than 3 months. If somebody is only albuminuria for more than 3, that is also diabetic kidney disease. If both are present, that is also diabetic kidney disease. So it should be persistently more than 3 months. Okay? Then I told
what I told, or even that is non-albuminic diabetic kidney disease. What you are considering, that is non-albuminic diabetic kidney. Even if only eGFR less than 60 without albuminuria, that is also diabetic kidney disease.
Right, but what is therapy?
Therapy is same. Therapy is same.
Again, sir, there are another variety. So, if you go to the deep literature of kidney disease, chronic kidney disease, one is non-proteinuric kidney disease. Second is some patients also having normal kidney also, their GFR also at low setup. So they are also normal, but you also be wrong if you see the GFR also. That's why these novel biomarkers now are coming up. So to exactly quantify the diabetic kidney disease or non-diabetic kidney disease, but this percentage is very low. Now reduced GFR with a normal kidney, the percentage is very low, but there are two distinct varieties: non-proteinuric kidney disease and low GFR normal kidney also exists. Yes. Yes.
No, you see, what you see. No.
But over 99%,
it is a clinical diagnosis.
Yes.
I tell you. But the gold standard is to do a liver, kidney biopsy. But kidney biopsy is not done.
not done.
So it is a clinical diagnosis. The clinical diagnosis is if it is more less than 60 or albuminuria, for all practical purposes, you take it as a case of diabetic kidney disease.
Will you give any therapy for that?
Naturally, yeah.
70 years, as you said, a normal, that is a normal kidney disease, but eGFR is less.
There is no such age guideline.
Age rated, there is no age rated. Yes, sorry.
But CKD is already.
Jemji sir, diabetes is a coronary equivalent. Diabetes is also a kidney equivalent. Take it a point. आपके दिन पर आसीबो diabetes mellitus is also kidney equivalent. Diabetes is a coronary equivalent. Diabetes mellitus is a
Manoranjan, that equivalent is not yet applicable. That was some, I think, ATP guideline 3 in the year 2001.
But you have to think like that.
With the 2001, we are taking it is a CV equivalent cardiovascular disease. Now it has been changed because suppose a 40 years old male comes as a diabetes without any other comorbidities, any other risk factors, that is not diabetes CVD equivalent. So there is, yes, in some cases it may be CV equivalent, but it is a high risk factor.
Yes.
Now diabetes is a high risk factor for kidney disease, high risk factor for cardiovascular disease. So we have to take like that. Anyway, thank you.
We are serious about the cardiovascular, not about the kidney. That is the main point.
Thank you so much, speakers and chairpersons, for such an insightful discussion. Now I would request our chairpersons to please come on stage and felicitate our speakers. Dr. Bharat Panigrahi sir, Professor Dr. Sarita Behera ma'am, Professor Dr. Manoranjan sir. I request Professor Dr. Rasmi Ranjan Mahanti sir and Dr. Anupama ma'am to please join us on stage. Sir, Dr. S.N. Swai sir to please join us on stage. Sir, we'll be having, yes, sir, Rasmi Ranjan sir. Sujata ma'am, please come on stage. Devanand sir and Srikant sir.
Circle should be wider. The secretary is hiding inside. Let everybody.
Srikant sir. Dr. Meghnad, please join. You will be felicitated. Meghnad sir. Chairpersons to please felicitate our Yes sir. Dr. Santosh Swai sir. Dr. Santosh Swai sir, Dr. Sanjay Jangit sir, Dr. Manoj Kumar Chotre sir. Sanjay Jangit sir. Sanjay Jangit sir. As we come to the end of our conference, we now announce the winners of poster competition. To give away the certificates, I request the dignitaries to be present on stage. The third prize with a prize money of Rs 2,000 goes to Dr. Selva Mani of AIIMS Bhubaneswar. A huge round of applause, everyone.
Where is the... So you have it. Hey, you give. Come. Handsome boy. What is that?
That will be transferred. The second prize with prize money of Rs 3,000 goes to Dr. Souvik Pal of AIIMS Raipur. A huge round of applause.
Very good. Very nice.
3,000. And the first prize with a prize money of Rs 5,000 goes to Dr. Avarna Agarwal of KIMS Hospital. If anybody is there, please collect on her behalf.
Anybody can collect on her behalf? Anybody from KIMS?
Prize money is Rs 5,000.
Come. Don't take away the money.
A huge round of applause for Dr. Abarna. She is taking it on her behalf.
Congratulations to Avarna. You get the money, you get the photo.
With this, we come to the conclusion of MEDICON 2025. I thank each and every one of you for your enthusiasm and active participation in making this event a successful one. I request all the delegates to please join the dignitaries on stage for this photo session.
To request our esteemed faculty members and senior doctors from the state to please say something about the conference. I'll go to Bharat sir.
Thank you, Anupam. I think in our lifetime, it is the first time we are entering AIIMS, at least with such a conference and participating in it. And thanks to Anupam. It's a nice one. Actually, we were discussing, Anupam and me, we had discussed many times regarding holding such a conference in AIIMS. And I also have discussed with Dr. Vishwas today. And I have asked him, I requested him that why not city chapter API with AIIMS to conduct many more CMEs in future, and he has agreed. And I'll be planning again, maybe in the month of around 2 to 3 months. So we'll be having many more such CMEs intermittently
on different topics. So let us, academics has no end. So let us continue and go on, and let us involve others also. Let everybody come and thank you organizing such a beautiful conference, and thank you all the organizing team also, everybody. So thank you all.
So thank you. This is the end of the session today. Dr. Cecil Mahapatra and Dinabandhu, please come to the dais.
So whatever you say, we agree with
you. But you are a white person inside and outside, so very clearly hearted and very good person in the medical fraternity. Then I'm telling you, just you don't disturb me. So this is a very nice gathering of academics and a lot of speakers and chairpersons from inside the state and outside of the state, and mostly from AIIMS, and our close friend AB, they also came. So it was a very good session with friendship, academics, knowledge sharing, and wisdom increasing. So this is a very good get-together, good academics session organized by the organizing chairman, Dr. Dey, the scientific chairman, Dr. Mahanti, Rasmi Mahanti, and the organizing secretary, always going back, although he's Dhriti, he's so humble, although he's doing many things, but he's always in the behind, not taking his photographs. Most handsome boy still. and most of the chairpersons have done their job, and Dr. Astos Biswas, director, and most of the AIIMS colleagues, and who have come and joined and given his valuable speech, has enlightened and enhanced our knowledge and the knowledge gap, and it has made us wise. And many more sessions will come through API or through RSSDI, and I am also presently the chairman of CCDSI. Santosh will help me to do it here. If you are not getting a place, he will give this place, and food, etc. also can be arranged by them. So there is no problem. So you can have a CCDSI meeting here. He is the secretary, I am the chairman. He is not finding time or the venue. I don't think so. It is there. And he is given the consent. So you find out the date. So the next meeting of CCDSI will be here with Secretary Santosh Swang and me, the organizing chairman, and he is the patron. And chief patron is Asutosh Biswas. So, and all are good to join. And Dhriti will be always there and not behind. He is very humble and very fair and very handsome. So anyway, thank you very much for your kind participation, and with good humor and friendship. I now hand over to Dr. Mahapatra.
No, thank you all. Really, within a very short period of time, Dr. Anupam Dey and his team has done excellently well to the satisfaction of everyone. And they have their ability and dexterity to organize such a symposium in a very short time. So our heartfelt thanks and congratulations for all, for this organizing team headed by Dr. Anupam Dey and Rasmi and Dhriti, and you all supporting colleagues and your students also as well. So let us hope this will continue. This is quite a very good academic, very extravaganza, and people have an attraction. We had our seminars at a capital hospital and other places at a peripheral levels. We are conducting it. But AIIMS has a special attraction, and it has a special image and a dignity. So try to invite also, and also accommodate many other physicians, and there are many, about 12 medical colleges. So let them be also involved in future time and have some also clinically interested topics also. Something, some research topics, some cases must be presented. For example, you have made a rheumatology session, 1 or 2 cases with a case of say reactive arthritis you have added. Similarly, 1 or 2 such clinical, pathological, clinical symposium, 1 or 2. So that can have also be adjusted, and we have to look after the choice of the physicians, others of different interesting discipline that will also give a good this focus on this CMEs. So my hearty congratulations now the anchor madam and other supporting madam, very nicely you have been managing. So from all our side, we will wish a future such occasions in future. Thank you all.
I forgot to give thanks to Arpita, who is my relation. So she is behind the scene always and also calling everybody, and her mind is tense always. Who will be there next? Is finding out and giving copies and of their backgrounds of all the speakers and chairpersons. So I again thank Arpita, who is contacting everybody also. And other, she is behind also. I am giving him thanks.
All the delegates are requested to join, please.
Sir. Ma'am, look, ma'am. Sir. Sir, look, sir. Thank you, sir.